25th Annual Integrated Care Conference. First of all, I would like to thank our Portuguese guitarist, Mariana Martins. She has given us such a warm and beautiful welcome to this conference. She began studying music at the age of 10, and in 2021 she made history by becoming the first woman to graduate with a degree in Portuguese guitar. So we were very honored to have you with us today, Mariana. So just before we start our opening ceremony, we have some Slidos, which I think are going to come up on the screen in just a moment. And our first question on the Slido is, where are you coming from today? So if you scan the QR code, that will take you to the Slido site, and please do answer that question. I'm now going to invite my friend and colleague, Professor Anya Carroll, who's the chair of the International Foundation for Integrated Care, to welcome us all and give us some inspiration for the next 3 days.
Thank you, Niamh. Bom dia a todos. Good morning, my dear friends, colleagues, fellow travellers, and kindred spirits in integrated care. It is such a pleasure to be here with you this morning for ICIC25. On behalf of the IFIC board, it is a great pleasure to welcome you to the 25th gathering as a global community committed to the vision and practice of integrated care. And what a moment we are in, colleagues. We arrive here together in times that feel both perilous but also promising. The world is hurting. Our systems are straining. Inequality, climate crisis, political division, and chronic disconnection continue to threaten our health, our cohesion, and indeed our futures and the futures of our children. And yet, we are not powerless, because integrated care is much more than a technical solution to system fragmentation. It is a movement rooted in values of dignity, solidarity, participation, and justice. It is a quiet revolution that starts not in policy documents, but in relationships, in the courage to listen, in the humility to learn, in the belief that better is possible and that it begins with us. In this room today, we are policymakers, professionals, researchers and reformers, patients, carers, advocates, educators, leaders. But more than that, we are people who care deeply about how care happens. We know that building sustainable health and care systems is not only about innovation and efficiency, it is about humanity. It is about placing people and communities, not systems or services, at the centre of all that we do. It is about making room for voices that have long been excluded and designing with and not for the people we serve. So over the next few days, let us ask the hard questions. Let us share what works and what hurts. Let us be generous with our insights and bold in our learning. And more than that, let us leave this place changed, not just more informed, but more connected with one another. Not just more aware, but more ready to act. Because the path ahead of us is long, my friends, and the work is not easy. But in this room, and in the countless communities we represent here today, there is courage, there is hope, and there is a growing conviction that a more just, a more caring, and a more integrated future is not a dream, it is a shared responsibility. So let us rise to that responsibility with our heads and our hearts. Let this be the conference that renews not just our strategies, but our spirits, because this movement needs all of us and it needs all of us now. Thank you for being here. Thank you for what you bring, and thank you for what we will build together. Colleagues, let us begin.
Thank you very much, Anya. And I think that really has given us a stirring start to the conference. I'd like to now welcome on stage Professor Alvaro Almeida, who's the Executive Director of the National Health Service here in Portugal, to welcome you all.
Good morning, everyone. Welcome to Portugal. As the CEO of the Portuguese National Service, I am greatly honored that you have chosen to hold this 25th International Conference on Integrated Care here in Lisbon. It is a privilege to host in Portugal an event that brings together leaders, researchers, clinicians, managers, community representatives, service users and caregivers from around the world, united by a shared commitment to the development of healthcare integration. Healthcare integration is a keystone in the Portuguese National Health Service. The Portuguese NHS was established in 1979 with a clear constitutional mandate to provide universal healthcare based on the principles of equity and free access at the point of delivery. Over the last 4 decades, the Portuguese NHS has evolved to respond to demographic, social, and economic challenges while remaining firmly anchored to these founding principles. Today, Portugal has a strong public health system. For instance, in 2023, life expectancy at birth in Portugal reached 82.5 years, surpassing the European Union average. We are happy but not satisfied with these results, especially because the Portuguese health system is, like many other health systems, under significant pressures. An aging population, increased clinical complexity, workforce shortages, rising expectations for timely and high-quality care. These are further compounded by budgetary constraints and persistent social inequalities. Portugal has experienced a significant demographic shift in recent decades. The proportion of the population aged 65 and over rose from 16% in 2000 to 24% in 2023, which is slightly above the EU average, and is expected to reach 34% by 2050. Non-communicable diseases such as cardiovascular conditions and cancer continue to be the leading causes of death, accounting for approximately 50% of total mortality. Mental health has also become an increasingly pressing issue with high rates of depression and other disorders, particularly among women and individuals with lower incomes. Approximately 1/3 of all deaths are linked to behavioral risk factors. In terms of health financing, Portugal allocates around 10% of GDP to healthcare, but this expenditure is it's based in about 30% on out-of-pocket expenditure, which is a concern for the universal healthcare system. The shortage of healthcare professionals remains a critical issue. Over 1/3 of physicians and 1/4 of nurses are aged over 55. At the Portuguese NHS, we employ over 150,000 people, which is more than 1/3 higher than a decade ago, as a result of the policies that aim to strengthen the capacity of the NHS to respond to increasing health needs. We have very good results in terms of avoidable hospitalizations. largely based on a primary care system which is delivered through family health units. These organizations are multidisciplinary teams of general practitioners, nurses, and other professionals who provide primary care services to a given population focused on prevention and health promotion, always with one concern: to have the person at the center of all care. The family health units are just one example of the many reforms the NHS has endured to improve the health of the Portuguese population and to advance the integration of care. There are two other recent reforms that we believe provide a strong impulse to integration of care. First is the creation of the Portuguese NHS Chief Executive Officer, which is a recent organization created in 2022. And this organization is focused on the coordination of care in the NHS in order to ensure that we have a smooth transition from primary care to hospitals to long-term care. The NHS CEO has as its main concern precisely the integration of care between all NHS institutions, to ensure that these institutions are efficiently coordinated rather than just merely institutionally aligned. And more recently, the NHS has adopted a new organizational model as its base, the local health unit. We have had experiences in local health units for about 25 years already, but in 2024, we decided to apply this model to the whole country. And this model is based on the integration of primary care and hospital facilities under a single management structure that is responsible for all dimensions of the health of the population in its area of influence. Local health units are based on the principles of integrated care. They aim to provide a more rational allocation of resources, to foster continuity of care, to facilitate the sharing of clinical information, and to reinforce local level management autonomy. This transformation requires investment in people, in training, in information systems, in contracting models, and in results-based evaluation. It also requires a new type of leadership, one grounded on evidence, accountability, and cooperation between NHS units. In this context, primary care becomes even more relevant as the coordinator of hospital care, palliative care, long-term care, and home health care. Their integration into a functional care network, now under the responsibility of the NHS CEO, is essential to ensure coherence to healthcare provision throughout the life of each person. We are fully aware that care integration cannot be imposed by law. It must be built. It demands a culture of collaboration, organizational alignment, time, and perseverance. Above all, it requires a clear sense of purpose, a clear focus on people-centered care. This is why gatherings such as this, the conference on integrated care, are so meaningful. They allow us to step up out of our day-to-day activities and out of our local biases and to confront ideas, learn from one another, and strengthen an international community of practice committed to the sustainability of health systems. To all participants, I wish a productive, inspiring, and impactful conference. Thank you very much. Welcome to Lisbon. Welcome to Portugal.
Thank you very much for that welcome, Professor Almeida. And I think it gives us a sense of just what a period of change and transformation is being undergone here in Portugal. And I certainly, like many of you, am looking forward to hearing a lot more from our Portuguese colleagues about the work that they're doing over the next 3 days. So we're delighted to welcome 1,000 of you over the next 3 days from 56 different countries. We'll have more than 150 sessions, so there's a lot to try and pack in over the next 3 days, and this is our opportunity, as Anya has so eloquently said, to connect, to learn, to share. Now, to get the most out of the next 3 days, please do make use of the conference app. Everything is in there. You will see that there's a personal program that you can build. You can also connect with other delegates if there's somebody on the delegate list you want to meet. And for our Portuguese-speaking delegates, there's also an AI translation service within the app, so please do use that if you need it. We're especially pleased to welcome 50 patient, family caregiver and citizen representatives to the conference this year. We do recognize as a foundation the essential importance of lived experience running through everything that we do, and that very much includes our conferences. There is a dedicated quiet room, and it's room 11, which is a calm space should anybody need a little bit of time out. This is a very busy conference, so having that calm space is particularly important. And if you do require any assistance during the conference, look out for anybody who, like me, has an orange lanyard from the ICIC team, or please do approach any of the staff that you see around the conference centre. And for any general inquiries, Abbey Conferences, our conference partner in the blue t-shirts, seen throughout the venue, but down at the information desk, please do go there. All of our sessions are free to attend, including the workshops. Some sessions do get very full very quickly, so make your way to the sessions that you want to go to as early as you can to secure your place in the room. We have an exhibition area with e-posters, the kiosks there. So that's on level 2, the foyer, which is the level above this one. And please do go and have a look. We had some excellent posters this year, some very high quality posters. So please do go and have a look at those. We also invite you to stop by our stand, which again is on the foyer on level 2. Come by, see the work that we do as a foundation, and come and meet our team over the next 3 days. For those of you who've booked the conference dinner, that takes place tomorrow evening at the Paseo de Gale, and that begins at 7:15. Unfortunately, it is now fully booked, so if you haven't booked already, and you will need 30 minutes to travel to the venue from here, so please make allowance for that. And during that evening, we will be celebrating our Integrated Care Awards to the best papers and best posters from this conference. Site visits are already also fully booked, but if you have registered for one of the site visits, please go to the conference registration desk just before the site visit, and lunch will be provided for all of those who are going on site visits on their return from that visit. We have a painting exhibition, which you will see, and it's a beautiful art exhibition created by 6 artists from the art studio of the Occupational Therapy Unit at ULS São José Hospital, Julio de Matos. It's a very personal, and I had a look around yesterday when we did a tour, some beautiful, evocative artwork. So I highly recommend that when you're having your coffee, and perhaps when you need some of that quiet time, you spend some of the time exploring that artwork. We will be live streaming all of the sessions in the main auditorium and the small auditorium, and you can access those live streams through the conference homepage on our foundation website. And all the sessions in those 2 auditoria will also be recorded, so you can catch up if there's anything you miss after the conference. If you're sharing your experience today from social media platforms, please tag us on ICIC25 and Integrated Care. And just going back to Slidos for a moment, the next Slido we have is this your first ICIC25? Or, well, it'll be your first ICIC25, it is mine. But is this your first international conference on integrated care? We have one more. I'm going to come back to that in a moment. So, at the Foundation, we have 5 values that we talk about. And Anya talked in her opening about the importance of values and values driving what we do in integrated care everywhere in the world. But these are the 5 values that the Foundation stands for. The first is collaboration. We recognize that people and communities are central to our movement for change, and Anya used that phrase, a movement for change, because that's what we are. We welcome people with lived experience to this conference today, so please do make them feel welcome. Our second value is around integrity. We also recognize that this is the basis of trust between professionals, researchers, policymakers, populations, citizens. And it's our partnership with local hosts like PAFEC. It's one of the ways that we build long-lasting relationships. Inclusivity is the third of our values. It takes people with different ideas, different strengths, not always in agreement, to build integrated care and make it succeed. And at this conference, these different perspectives are embraced and celebrated. Our fourth is around quality. We achieve excellence in integrated care by continually reflecting and learning together, and that is what we spend the next 3 days doing. And finally, passion. We have fun together, and we celebrate our successes and our achievements. Doing integrated care is hard work, because often we are working against the status quo. So taking time to have fun and celebrate what we do is really important, and our conferences are all about that. So take that energy, take that passion back home with you. So the final question we're going to ask is for you to reflect and think about what you want out of the next 3 days. They're going to be packed, they're going to be busy, but they're also going to be a lot of fun. And I look forward to enjoying that fun with you. And now I will hand over to my colleagues, and we'll have our first plenary of the conference.
So, good morning, everyone, and welcome to this first plenary session of the International Conference on Integrated Care ICIC25. Welcome to all of you who are joining virtually. This is live stream, so hello. And my name is Arturo Álvarez. I'm a senior researcher at the International Foundation for Integrated Care. I am the head of solutions, which is the part of IFIC that supports organizations, ministries, providers in designing, implementing, and evaluating integrated care services and programs. And it's a privilege for me and a real pleasure to welcome Adelaide Velo. And let me tell you, I think this is working. You go here. Because Adelaide is the reason why we all are here. She is... I was going to ask for a round of applause, but let's make a good one. So she's going to introduce herself. Well, she's the president of PAFIC, the Portuguese Association of Integrated Care. And as I say, together with her team, they've made this possible. So say something about yourself and say something why we are here. And thank you.
Good morning. I'm Adelaide Bell. I'm a senior internal medicine consultant, and I work for more than 40 years in the Portuguese health system service. And now I am the director of the Portuguese Association of Integrated Care, but more than myself, I have a team that a lot of them is here with us, and this is this team that work hard to be here, and we appreciate that IFIC give us the privilege of this year, the ICIC25.
Fantastic. Let's move a bit to the center, because we were in that side. I think everybody can see us better. So ICIC25, this conference, is going to be an invitation to the integrated care movement to reflect upon how we are contributing, how integrated care is contributing to the Sustainable Development Goals, SDGs. Right? You know, this agenda, this is United Nations agenda, which started in 2015 as part of a wider 2030 agenda for sustainable development. We believe that integrated care is instrumental in achieving these goals. So each plenary session is going to be dedicated to different sustainable development goals. And this one, the first plenary, is SDG 3, which the title is Ensure Healthy Lives and Promote Well-being for All at All Ages. So it's about, well, it actually aligns very well with an understanding of integrated care that is holistic, has a holistic approach, and goes beyond just managing or promoting strategies to manage the absence of disease. It goes beyond health, covers health and social care, and many other aspects. One of the key targets and components of the SDG 3 is universal health coverage. And the WHO definition of universal health coverage, I'm going to read it, is all people have access to the full range of quality health service they need, when and where they need them, without financial hardship. So this plenary is going to be an invitation to explore these linkages, these links between integrated care and universal health coverage.
Yes. The Portuguese, as the executive director says, the Portuguese healthcare system is created 50 years ago. And one of the main goals since the beginning is the universal health coverage. And today we have Professor Rui Santana, that is the Vice President of the National Public Health School. He has a long experience and publication about integrated care. And his school, the National Public Health School, was a great partner to, so you can have this conference this year in Portugal. Professor? The Professor Santana presentation is about learning, challenges, and opportunities for integration of care as major driver for universal health coverage.
Okay, good morning, everyone. Thank you very much for the invitation to be here, to Adelaide in the organization of IFIC. First of all, on behalf of the National School of Public Health, of course, I would like to give you a warm welcome to Portugal and to Lisbon. It's a great honor for us to host here this conference. Before I start my presentation, I just want to share with you, and I find out that I'm just a veteran of participants, of attendees on this conference of integrated care, more than 5 presences. And at the beginning, at the first one, several years ago, I said to one of my colleagues that we should bring this conference to Portugal because it's a great opportunity to share our knowledge. It's a great opportunity to know another people and to create here a great network on integrated care. That is one of our issues and one of our key research problems. And after several years ago, Dr. Adelaide and his team did a great job just to bring this conference to Portugal. So I would like to thank you to PAFIC. We started PAFIC in 2014 and tried to make some connections also with IFIC in the first conversations with Nick Goodwin. Good morning, Nick, and all your team. So it's a great achievement for us to have this conference here. And thank you very much, Dr. Adelaide, just for all of your work and to the great job that you did on the backstage, you and your team, of course, just to have this conference here in Lisbon. So I would like to say this previously and before my presentation. So the topic of this presentation is the creation of integrated care organizations. If the creation of integrated care organizations here focus on the Portuguese reality can contribute to universal coverage. So this will not be an academic presentation, okay? I'm just going to share with you some thoughts that I have about these questions. And I'm just going to move forward here on this agenda just to give you some context description. The CEO of our NHS already did some snapshot of what we are living at this moment, but I'm just going to go a little deep further and try to ask also here as an academic, we would like to put questions more, sometimes try to find answers. So my two reflections here are based also on if we are using the right concepts of this universal coverage and the integrated care here in Portugal, and of course, my thoughts also about how we can improve the situation. So one of the biggest transformations that we've made here in our healthcare system was in January of 2024. It was like a big bang reform that transformed our intermediate organizations. Before 2024, we had 5 regions. At the left of this map, we have the Atlantic Ocean, and at the right, we have Spain. And we had 5 health regions at North, Central, Lisbon, Alentejo, and Algarve. And at this moment, we transformed here the intermediate organization into that local health units. These local health units, like was said before, are vertical integrated organizations based on the population that gathers here, that merge primary care and hospital and long-term care. So it's a great challenge also for the managing of the system. So we had these two kind of realities. The first one was this 5 health region that includes hospitals plus primary care centers. And after that, we have here a national executive direction and 39 local health units. Those local health units are quite different because they have different dimensions, okay, concerning the budget, the human resources, representation, and of course the population that they covered. So we had before some experience on these local health units. It started in 1999. I saw here before this presentation the president of local health unit of Matosinhos. That started in 1999. Then we had here a lot of new local health units between 2007 and 2012. And in 2024, we transformed almost all of our country, creating 31 new local health units. There is only one area that is not covered, that is nearby Lisbon, in Cascais, that the provider is a PPP, is a public-private partnership that is not covered yet by a local health unit. Well, but my question, in looking for that question, if we are looking for and using the right concepts, it's one of our fights since the beginning of these local health units is that integrated care, it's much more than the creation of local health units, okay? If we look for the dimensions that we should achieve here at the functional level, at the systemic level, clinical information, etc. So we found that just the creation of these intermediate organizations that gathers at the normative level, the primary care centers and hospital care and long-term care, it's not enough, okay? We should go deeper and we should go after the integrate in all of other dimensions that are crucial for our system. The other concept that we are using here is universal coverage. And Arturo, I think we did the same homework. So I'm just using here the same definition of WHO that looks for this universal coverage, not only for the coverage of the population according with the resources that we have, but also just to guarantee the right access, the financial protection and equity. And when we look for the Portuguese reality, one of the main promises of the last decades from our politicians were the full coverage of the population with family doctors. Of course, they are very important for the system, they are quite important, but we should not only focus on that, because when we look for the access, we saw that Portugal is the country that more used the emergency department per capita in the OECD countries. If we look for the financial protection, like the general director of the system, the executive director of the system said, we have 30%. It was a huge increase in the last 20 years. So in 2002, he have an out-of-pocket expenses percentage of 23%. At this moment, we have 29%. So there is an increase of the effort that the citizens may have to have access to our Portuguese system. And if we look for the equity, we also find out that the life expectancy in Portugal is the same, is almost the same as the EU average. But when we look for the last 10 years of life, the quality of life is quite different. So maybe the focus that we are looking for here when we talk about integrated care and when we talk about universal coverage at this moment is very narrow at the Portuguese system, and I think we should address and we should look for the deepness of the concept, just to look for that we have a lot to achieve and a lot to do in the future. So, but I'm an optimistic guy, and I just want here to share also with you what we should do, or what are here the main recommendations, how we can improve on that. Well, I put here 3 or 4 thoughts about this, and for me it's quite important just to have here a clear strategy for integrated care in Portugal. The creation of local health units, it's a great ground just to the integrated care can grow, but the truth is that we should do much more than only at the structural and the intermediate level of the system. I have some doubts if the concept of integrated care is just achieving the patients. That's what we want. So, but even at the strategic level and at the policy level, in the last year, we found it here a lot of instability. So the party that creates these local health units was, so in January of 2024, there were created local health units, and in April, there was a new government with another tools and with another policies. So, and we find out that there was develop an emergency plan just to achieve quick wins in 60 days. And there was also here some discussions about the integration of university hospitals inside of these local health units, if it is okay or not, if there is here some problems, and the development of new public-private partnerships. So indeed, it creates here lots of instability in the implementation process of these local health units. So as you may know, in the next Sunday we are going to have new elections, so we are expecting from what is going to happen. But we need stability and a clear strategy for the implementation of these local health units. The other question is about the organizational design that we are using. When I look for the organigrams, and the organigrams of this institution represent the hierarchical relations of the department services that we have, the truth is that when I look for them, it's quite, I think I'm in the 70s or the 80s of the last century. So there wasn't so much innovation here in dynamic on these organizational designs. And if I look for the risk stratification of my population, and at this moment we have lots of information, we have data science on this data, and of course we have here tools for risk stratification to know deeper the profile of our patients. But here the question is how we are addressing these kind of needs in this profiling, because these local health units just had the primary care centers like a parallel line we are not using here some different models of organization like a matrix or a product line or a service line organizational design. So I have some doubts about here this relation between what the patients really, what are the profile of these patients, what are the real needs of these patients, and what kind of organization I have just to answer to these needs. So I think here we must, of course, to improve and to question, because local health units, like I said, it's an intermediate changing on the system. I don't know if we are just achieving here the population and the patients. Another question, I'm just on the end of my presentation, I'm just asking also here about the financing model. With the creation of these local health units, we changed also the finance model of these institutions that previously was based on production, on the basis of volume and episodes, and now we changed it to a capitation model in the risk-adjusted capitation model. But the main problem here is that when we look for inside of these local health units, there's a lot of different incentives. And there is a lack of alignment between here the horizontal and the vertical incentives that we created. Again, I have some doubts if the incentives that were created by these capitations are achieving the right populations, because the incentives that health professionals have are quite different inside of these local health units, and in the majority of the cases, they are not shared across teams between, for instance, primary care and hospital care. So there's here a lot of things to work on. Well, I used also to show this to my students, and I have here two main comments about this: the whole paradigm and the new paradigm of healthcare. The first one is, I'm sorry, the letters are very small, but is the bibliographic reference. It has more than 20 years, okay? Everybody knows this. And the main problem is not looking for what is there, and the problem is not the people that are in the audience. The problem is the people that are outside of the audience. Because you are already converted. You already know and you already believe on this movement towards a more integrated healthcare systems. The problem is that the people that are outside, that they are not here. So our job is also just to spread this word and try to change here our mindset. And I think this is my last and key home message, is just to try to reinforce this idea of it's not enough to create local health units. It's not enough here to just bring this organizational changing at an intermediate level. We must achieve the patients. And I think the main question that we have here and the main challenge, even for the future, is this changing the mindset of the people that are in the health system. Not only policymakers, managers, health professionals, patients, but that's our job and our main challenge. Thank you very much for being here, and I hope that this conference should fulfill all your expectations. Thank you.
Thank you very much, Rui. This is very interesting. Thank you for taking us through this bumpy road journey, which is as in every country that we experience that. So moving towards integrated care has, I remember this slide that you had with how elections affect new governments and how that can affect. Thank you for linking with universal health coverage, and thank you also for pointing in this last slide about the need to change the mindset. Our next speaker is Carla Giacomin, and I want to invite her to come here to the stage. And I like the audience because just, you start clapping before I start sort of inviting you to clap, which is fantastic. It means that you are very engaged and you listen. Fantastic, that's great. So Carla Giacomin is the president of Cuidadosa. She's going to introduce herself now. Is the Brazilian Care Association. And she's going to challenge us to think that long-term care is a fundamental right, an agenda issue. And to conquer such long-term care right, and to move from theory and nice declarations or nice words, to move from policy discourse to real and effective practice, we need a social movement for change. So Carla, the floor is yours, and challenge us as much as you can and you want, but stick to 12 minutes, 15 minutes maximum. Fantastic, Thank you very much.
Thank you so much for this invitation. Thank you, Professor Adelaide. Thank you, Portugal, because we are very impressed with your warmful welcome. I'm Carla Giacomin. I'm a geriatrician. I'm a public servant. I'm leader of a social movement in Brazil, and I'm a focal point of the International Longevity Center in Brazil. So, when we see this picture, all of us think about care, think about tenderness. But I will challenge you, who here has think about an old person is born? Because it happened. An old person is born. It's so hard to see our aging inside ourselves. It's so hard to see care inside ourselves. So the care challenge is to understand care as a right. And we believe that long-term care must be recognized as a fundamental human right. Another challenge is the gender inequality, because care work disproportionately falls on women, creating social and economic disparities. And we need a social movement, a collective action to transform care policies and practices. I don't know why there is some repetition. Really, I don't know. But what defines care? I love this picture. It's a Brazilian Yanomami indigenous. And when I see this picture for the first time, I was very impacted. What defines care? Attitude, relationship, and responsibility, because care encompasses a concrete response to the need of others. And others, we are not talking only about human beings. So why should we think of long-term care as a fundamental right? Because we are caring beings as long as we live. And why is long-term care a fundamental right? Because it's an universal need. Everyone requires care at different life stages. Because we believe that we deserve human dignity, because quality care preserves dignity and autonomy. And because care can promote social justice, equal access to care, reduce inequalities. And another challenge, why should we think of long-term care as a gender issue? Because 70% of women caregivers, 70% of caregivers are women. Women have the main responsibility for family care. But this care is invisible because it happens in the domestic environment with no reward, with absence of rights, and because it's considered a not productive action. Is it correct? If 70% of caregivers are women, there are multiple costs of care, because care impacts health risks, financial losses, it promotes social isolation, and it has a continuous and exhaustive dedication with time commitment. So it's not easy to provide care. It's necessary, but it's not easy. There are many researches that we can work together. I participate in some researches with IJIC in Canada, with the group of analysis for the development in Colombia, with the Northumbria University and our association, because we need to change this mindset, as Professor Rui Santana has said before. And why should we promote a social movement for change? Because there are a mismatch between theory and practice. In the theory, we have advanced legislation, constitutional guarantees, international commitments, but in practice, we have insufficient policies, scarce resources, and the priorities are not correct. And more, public policies can perpetuate social and gender inequalities through biased concepts, ageism, and force that don't transform social situations. Do you learn something with the COVID pandemic? Yes, I suppose. And some lessons from the COVID pandemic are the vulnerability, the precariousness, the invisibility, and the need of mobilization of the society for facing a global and a common challenge. In Brazil, we have many difficulties during the pandemic. And because of this, we lead a social movement named National Front for the Strengthening of Long-Term Care Facilities, with zero euro. We achieve more than 708 100,000 access in our social media. We made 206 sessions with experts with more than 50,000 views. We create 5 projects with strategic partnerships, and we train more than 13,000 people for good practices. We have our former president, there was a negationist, anti-vaccine, and what else? And when we talk about invisibility of long-term care, we should focus on the invisibility of the long-term care facilities, because there was a global evidence that pandemic revealed the invisibility of long-term care facilities around the world. But Brazil didn't know how many long-term care facilities we had, where they were, who worked there, they care for whom. We didn't know nothing. And we were completely upset and surprised by the pandemic. So we needed a civil mobilization because society had to act in the face of the state omission. And how was the COVID mortality in long-term care facilities in Canada in the beginning of the pandemic? We were completely scared. So, because in Ontario, more than 85% of people in long-term care facility died because of the pandemic. And in Spain, in the beginning, more than 60%. In UK, 50%. And USA, so the North were unprepared. What about Brazil? If you were unprepared, what about us? So our social movement only have information, knowledge, and we share this. And we achieve less than 1% of death inside long-term care facilities in our country. So public policies are not neutral. They reflect power and power struggles and social priorities. And the sectoral model is inefficient for care. So advocacy must come from society. Don't expect a bedridden movement. It's not possible. We should do and we should represent this vulnerable voice. It's our collective responsibility. Advocacy must come from society and from policymakers. And we need a proactive approach. We must act before crisis, because crises reveal system failures. So our key learners, we need a coordinated action. Data matters. We didn't have any data about long-term care. We need a civil society strong and courageous. And we need to train professionals and services. It's essential. But we also need to break stigmas, because we see people in need of care as losers, and they are not losers. We usually see families who use long-term care facilities as if they were neglecting their family members, and they are not neglecting. And we need a care ecosystem that includes home, community, and long-term care facilities, because different needs require diversity of care points. And how to promote a social movement for change? Raising awareness, build coalitions, advocating for policy, and supporting caregivers. For us, it's incredibly necessary and urgent. And we hope at the end of the conference, we will be more aware, we will be more challenged for mobilization, we could do some joint action, and we believe in rights-based care. So the movement for long-term care as a fundamental right and gender issue needs to continue to growing. Please join the movement. We need to still making research, and thank you for your attention.
Well, I wonder if I can invite our panel to reflect upon both presentations. We have got a fantastic panel lineup, which I'm going to present now. I asked to come to the stage Anika Ley, Carla Pereira, Tatiana Donstrin, Carlos Martins e João Breda. Anika Ley is Vice Chancellor of Health Affairs from the Ministry of Social Affairs of Estonia. Carla Pereira is there Carla Pereira? No. Tatiana Donstrin is an expert of integrated and social care and from a chronic disease program from Moldova. Carlos Martins is the CEO of a big university local health unit of Santa Maria, and he was former Secretary of State of Health in Portugal. João Breda is head of the WHO Athens Quality of Care and Patient Safety Office. Thank you very much.
Thank you.
Okay. First of all, I would like to invite you to reflect upon the Professor Santana and Dr. Giacomi have said in their talks. What are your thoughts thinking about your countries? Can you begin, Tatiana?
Yes, sure. Hello, everybody. Actually, these two presentations, they are bringing us to the thoughts that the problems, challenges are quite similar. The way we see the link between the right of people to receive health and social care and how the systems are trying to react to this. I would say that for Moldova, somehow the right for care, we are coming from old Soviet Union systems where we pretended to have all these things and rights covered. And I would say that for Moldova, the important lesson now is to, and I will bring both presentations speaking about individualizing care and approach, trying to respond to the real needs of people and build on individual aspects. And here I'm speaking not just about people that need care, but also the statute and support that it is needed for informal carers. Because we somehow traditionally and culturally believe that family is responsible for care, and we have the same aspect of the gender issue, not just in informal care, but in formal care also, because women are taking care of our people in need and people with complex needs. And also the not just individualizing, but breaking and do systems more human in responding to the needs. Because somehow, traditionally, we are administrative, we are bureaucratic, we are looking in papers rather than in people. And this is probably one of the common aspects that I see in both presentations, and also we need to learn from this, to meet the real need and to look through all these boundaries, trying to build a network of support. Thank you.
Thank you.
Annika.
Okay. I have so many thoughts after all these presentations in the morning, so it's really hard to focus, but maybe just some thoughts to reflect what I heard and what I was thinking. First, regarding universal health coverage and integrated care as part of it, moving towards universal health coverage, I think integrated care is a very good tool what we can use actually to maximize all of the health impact, whatever resources we do have. And what also some of the presentations brought out, that many countries in the world at the moment are living in a situation where resources are limited, both financial but also workforce. But we have to use the strengths what we have. We have to use the resources what we have and build on that. And this is not something we couldn't overcome. It was really good to hear also the example from Brazil, where actually with €0 you can actually move mountains. And this is what in Estonia we are also planning to do. Not especially with €0, but still with a very limited funds, because I don't know how many of you know where Estonia is situated. It's 1.3 million people, and we are not exactly blessed with our geographical situation. So our neighbor is the one who pushes us now to invest more into national security rather than health systems. That is that we are in a situation in Estonia where we still need integration. This is not the question of why, this is the question of how. It's a necessity. And we are still planning on moving further and using really the strengths and possibilities what we have. And what was also said today is using the communities, using the ecosystem of social and healthcare providers, because you cannot work always from top to down, but it has to be worked out together with the communities. So all the solutions what we are creating also in Estonia, these practices we're building upon on integrated care, we're building upon the experiences and practices what we already have. Many people have them, and we can use them, and I can see that the readiness to move further with actual changes are there. And then I go to the point of the change of the mindset and the paradigm. We, of course, have to build structures, we have to build legal frameworks, combine fundings, pool fundings, and also create these kind of teams to work together. But the most important is not just to bring people together, specialists together, that now you have to work together for the needs of our clients, but it's the matter of the culture change, of the mindset change. All these changes in the paradigm, what was shown us from the previous speaker. This is important that when we manage to change the mindset and get it right, then we are more possibly succeeding. And last, maybe but not least, point I want to make, yes, there has to be a right to care. Absolutely agree with that, and in Estonia we are having this also in our regulations, that this is a right, but at the same time we should also think about how we empower our people. And I really like my colleague from WHO, Natasha Zabardi, who always says that aging is living, that we are all aging, and how we support our people, that they would live healthily, that they would be empowered, that they would be able to lead independent life. That is the ultimate goal. And we should also use integrated services to support that and to promote healthy living, not only providing care. Yeah, as I said, I have too many thoughts, so maybe I was a little bit fragmented, but there they are.
Dr. Carlos Martins.
Thank you very much. Well, and thank you for the invitation to be here in this key conference that we welcome, and that is the result of the fantastic work of Adelaide Bell and this team is also recognition of that. Well, about the two conference before, let's put, if you allow me, let's put the things in a different way. We have, of course, we have difficulties, and that's also on our minds when we try to change mindsets, when to try to make something new, when to try to put ongoing innovation. But in each difficulty, it's always opportunity. And let me tell you my opinion as a manager and with some results about the integrated care. The integrated care is in fact opportunity. Opportunity to quality, opportunity to efficiency, opportunity to sustainability, to motivation, and, very important, to integrated responsibility. Responsibility of the public sector, responsibility of the private sector, responsibility of the social sector, responsibility of the municipalities, and family responsibility. We are doing this way. It's not easy. Of course, it's not easy. We are a very big institution, an university institution, with large national and international responsibilities also. But we defined a way to do it. We have a vision and we have a strategy. And after 1 year and, 15 months, we start to have some results. Of course, the best way to do something new is think that small is beautiful. The big problems, we start with small solutions. Of course, we have here, in a national point of view, we have all the conditions in a legislation analysis or even in human resources or conditions for this kind of integrated policy. We have the legislation, we have the institutions, we have the municipalities, we have the families, and we have the patients. Then we need to define the way of doing it. Of course, the hospitals are in, of course, the health centers, the proximity health centers are in, but we need to define, for instance, the long-term cares, the palliative cares, the home hospitalization, the home cares, and prevention of the disease and promotion of health. That must be in this integrated care strategy, where everyone is invited to be part of it. Hospitals need to be near the families, need to jump from the buildings to go near in proximity with the patients and the families. The proximity cares that have all the solutions about knowledge of the local community need to be present with the municipalities, and then we need to welcome to board some private sector and some social sector to make the long-term cares and to help us with the palliative. And that is resulting. And in the end of the day, and if you think in the vision that is normal, human resources or financial resources, in the end of the day, in economical, social economic point of view, this is very positive. In motivation point of view, is very positive. In quality and results about our patients and families is very positive. Involving the municipalities is something that is needed. In a financial point of view, of course, it's a kind of investment. We need to invest 1 to 2 years, but the turnover after the 3rd year, it's going to be very good because we're going to make more and better with the same euro, speaking about euros. And that's the key. The first results we have, as I told, for the first 15 months, are quite great. But we are starting. And that our country, we have very good examples from the north till the south, and this is the kind of way. But we need to show, and this is, of course, also kind of stage to speak about and share experience and challenge, but integrated care is the way of doing with efficiency and sustainability our way.
Thank you very much. And for the end.
Okay. Thank you so much. Good morning, everyone. Welcome to our beautiful city of Lisbon. For me, it's always really great to be back home, and I commend and thank the organizers for giving me this opportunity. Maybe I would like to congratulate the keynote speakers, two of them. I think they really touch upon very important issues. One of them more in terms of the organization we have in Portugal and the transformation process, which is really interesting and inspiring, I would say, for many other countries across the WHO European region. And if I may say, the second one more focus on a compassionate approach and really go beyond the normal thing we consider when we think about integration and integrated care. That tends to be more, and this also comes from our experience in the context of WHO Europe, that many times we see integrated care as a technical and organizational fix. You know, it's very mechanic, it's more technical. It's about, managing better chronic diseases, complex cases, bridge some gaps between, health and social care. But you said it very well, both of you. It's actually more than that. And this is really very important. Even if you are serious about achieving universal health coverage, which is about compassionate care, which is about looking at issues of disparity and equity, and this is really WHO mantra, is that what we put forward globally, but particularly also in our European region. We work with 53 countries. And for us, although we have a very strong focus on PHC, of course, because we have many countries in our region is very diverse and huge differences. And in some cases, we're missing the basic, and it's very important to start with PHC, but the issue of integration, it's really always there. And therefore, I think that this panel puts it, the speakers, and I think also my colleagues in the panel, put it very nicely, which is something more profound. It's really about a societal imperative, something which is about rights. I agree, dignity. I'm not sure we need a right to care. We already have a right to health. And the right to health needs to consider more the right to care, because sometimes, I'm a great fan of prevention. I've always worked in chronic diseases, non-communicable diseases, all of my professional career before WHO and since I joined WHO, and I really understand that the right to health, sometimes we maybe focus not too much on prevention, but we really need to focus more on all the continuum and not to forget the dimension of care, which is very important. So my challenge to you would be to, as you talk about the right to care, integrate it in the right to health, because the right to health is by far not being achieved in all of our countries. There's always excluded people from the poor to the richer. So congratulations. Thank you.
Thank you. So you see, there's always a risk when you share the questions with the panelists that they anticipate things that you wanted to ask them. But so I knew Joao's response about the right to care, right to be care, whether it is independent or is it embedded in the right to health WHO definition, which I think Carla left it there, saying, no, we need a right to care, being more explicit. So let me ask, you've said at the end, so we have not achieved right to care, right to health, let alone perhaps right to care, so health and social care. In our countries, in the 3 countries, by the way, we've got here with us, the panel represents 3 countries that are, you've been on the journey towards integrated care for a few years, but let's say that you are newer to the integrated care movement, which is fantastic. Do you think that the right to health expanded to this concept of universality of health and social care, is that embedded in your countries? Is this something that your countries, they have not achieved that, but you are actually working towards that, and it's part of the policy discourse? Or no, you are too far to that? Who wants to start? I'm going to start here with Carlos. I know your answer already, Joao. So, Carlos, what do you think that's in Portugal?
No, I believe in Portugal, of course, right to care it's achieved, but we need to make some changes that are happening. Last year we have a change in the organization of the system. We have some changes in the legislation to allow the stakeholders to make better. And it's not, sometimes we speak about COVID, and COVID brings, and of course COVID is a lesson. And we learn a lot. But the point after all these years is that COVID is a big lesson, but the problem is that society is changing, demography is changing, and the dynamic of the health sector is great. Then we need to revise, in spite of saying that, okay, we are very well in the rankings, in the benchmarking, we have a nice legal building, we have a nice cover of the country, we are doing innovation, but the problem is that each day you need to think a little bit about yesterday and about last week. What's happening, what is changing, and you need to adapt, because for instance, I give you an example, for instance, cancer. Cancer is growing all over the world, but cancer today is completely different than it was 5 years ago. We have babies that born where cancer is pointed in the analysis. We have children with cancer, even more. We have 39 cancer diseases in my institution. And then that means you need to adapt your organization, you need to challenge the politicians, and you need to challenge the society and the families to new realities and to have integrated answers for integrated cares, and to fulfill the right to care and the right to health. And this is an unfinished job. We need to think like that. We never go to finish. Each day is a new day where we need to. Then the kind of system that I spoke about, that we are following, is to join all the pieces of the system, not the service, the National Health Service, the system, the National Health System, and try together in partnerships, whatsoever, but try together to have proximity answers, middle answers, and top answers. That means high differentiation, state-of-the-art technology, innovation in the therapeutics, but we need to look to all the chain, from top to bottom and from bottom to top. Because families are, each day, they are asking more for the rights, or they are not complaining, but they are, remember us, the rights of the families also, not just the patient's rights. And that is a new challenge that needs to be shared and worked.
This is very interesting, and the thing is that we are taking now time from coffee, and I can see Fiona waving at me and saying that you have to. So I'm going to ask Anniki and Tatiana to summarize very quickly that response. How are your countries in that potential move towards right to care?
Yes, thank you. I think there are no countries who wouldn't think about these things, about the right to care and how to provide it to everyone. And important is that we wouldn't leave anyone behind, that we actually do our best to provide people the services they need. And I would bring in the right to integrated care, which is that ultimately people would have the right not to fall through the cracks. That means that we have to design our systems this way that people would not have to navigate between all the services and all the care providers on their own, that this is also done in a respectful and coordinated manner. And there might be waiting list for some services, but when we provide people the support and the knowledge in the right time in a different manner, this is also important. And I forgot what I wanted to say. Yes.
That's fine, that's fine. We move to Tatiana then.
Thank you very much. Actually, we saw integrated care as a solution in facilitating access of people with complex needs to support health and social care. Actually, initially we started to think how the health system and social system can communicate, exchange, use terminology, use services, how they can coordinate care, how they... We have some progresses actually, we have some definitions embedded in key strategies, health and social care. But really, accent now would be the policy dialogues that we started, and the way we are trying to find similarities, but also find gaps in access to health and social care, and developing this new, very important for Moldova, terms and practices like participation of people, involvement in individual planning, listening to people, designing the service in such way to respond to the real need, not to papers and theory. Thank you.
Fantastic.
Thank you.
So we are going to finish now, and we're going to go into coffee. Just to say thank you to everybody.
Thank you.
And Adelaide, you are going to close the session.
Thank you very much. It has been a fascinating discussion, and I believe it has set the tone for the whole conference. The next sections will discuss the interaction between integrated care and others sustainable development goals, as we did here with the University of Care. I would like to thank Professor Rui Santana and Dr. Carla Giacomini and our panelists, Tatiana, Anika, Carlos, and Joan. Thank you very much.
And Carla, if you come now to take a picture of the... Where is the... Sure, we can take a picture of the panel. Yes. Shall we take a picture, everybody?
So, good morning. Hello, everybody. Shall we make a start of the session? This is a very special session we've got today because we are celebrating 25 years of the International Journal of Integrated Care. And this session is going to explain a little bit how did we start and where are we going. The structure of the session is going to be, after a short introduction, Nick Goodwin and Gus Rivers are going to explain a little bit the history of the journal, how everything started. Nick Sonnenberg is going to explain a little bit one of the review we did of the past 10 years the publications, and then a panel discussion is going to discuss on researching impact and integrated care. And Victoria Stein is going to close the session explaining a little bit what's the direction, what's the future. So we said this is really important session, and one of the reasons is because this conference and everything started with just a journal 25 years ago. We are going to be really privileged to hear Gus and Nick speaking how everything started, because founded in the year 2000, this journal was created and built by a visionary group that thought integrated care was something that we should be talking about and that we should create a platform to advance about the science of integrated care globally. And actually, this is a cornerstone of the International Foundation of Integrated Care. It's one of the strategic lines, and many of the things we do are related and linked to what's happening in the journal, because the journal is the space we've got to create and share the knowledge. And not only this is for academia, following the values and principles of integrated care, this space is open to researchers and policymakers, healthcare practitioners, but also people and the community who's got lived experience. This has been a long journey. 25 years in history is short, but at the same time for this movement, it's been a huge progress. And we're going to see a little bit some numbers afterwards, but just talking about the history of the foundation. After everything started with a kind of modest journal, we are moving, and lots of people, we've got a huge network, and we are started a movement that internationally has been advancing integrated care. This conference is part of it. So, what's our journal? What's our characteristics? And one thing is that it's international. It's peer-reviewed, it's open access, and the focus is in all aspects of integrated care. But also there is something that is really key for this journal, and is that as the foundation is, this journal is also not for profit. The fees, for the publication fees, sustain the operations of the journal, and if there is any surplus, it goes back to the foundation to continue working on integrated care. And very importantly, all the people involved in the editorial work, reviewing work, they are all doing it as a volunteer basis. And you see the editorial team is big. We've got 5 editors-in-chief at the moment. I am one of them, but you're going to see the rest of them on the stage today. Nick Goodwin, Robin Mila, Victoria Stein, and Michelle Nelson are going to join us. There are also many other editors that we can see we are going to see here in the auditorium, in the conference, at the conference, but also that they could not come here, but they are really important for the work we do every day. And one of the things that we are really proud of is for having included the editors with lived experience, that we hope they are going to bring something that is really important for the integrated care movement. Because as you are seeing, all this team that is working behind the journal, in the backstage, they are the leading researchers and people with lived experience that they are moving the science of integrated care. So we started in year 2000, and we have documented the trends and the developments and findings of research, theory, and implementation of integrated care. I would like to go back to the first editorial that was published in year 2000. And it was recognized then already that integrated care had different names, and it was applied in very different contexts and structures worldwide. And I would like to invite you to actually have your eyes open and see, even in this conference, how this is shown, how there are different ways of understanding and implementing integrated care. Have we changed that much in the past 25 years? But also, and this is going to be discussed in the panel, what's the impact of integrated care? What is the evidence we've got on the integrated care interventions and initiatives we do? This was already put on paper in that first editorial when there was a discussion about, okay, we should do integrated care and we know there are advantages, but how much integration, what type of integration is good? And the journal started with the idea of actually getting that evidence and getting some scientific support of understanding how we should implement and understand integrated care. The panel is going to discuss a little bit on this. So I told you earlier how, again, this is a question. Have you seen any evolution, any progress? Because I think in the journal we have. We have revised the past 10 years and the publication we've done in the past 10 years, and Nick Sonneveld is going to explain a little bit the results. But one of the things that I think we have learned is that there is no one final answer to the questions we've got about integrated care, and that all the models, all the initiatives, all the frameworks we publish, we understand, we theorize, they need to be contextualized locally. And when we say locally, it also means that people that are involved in health and care at the local level, including the community and people and practitioners. If we consider what is the space that the journal has taken in this integrated care arena, we've seen that in the past 25 years, we have increased our publications. But not only the number of publications, we are also getting more and more submissions, meaning that there is some interest. We are seen as leaders of the integrated care concepts when we speak in the international concepts and taking all integrated care initiatives into account. We have become, in the past few years, we are in the first quartile of health policy, social sciences in health, and sociology and political science journals. So without making this introduction any longer, we are going to pass the mic to Nick Goodwin, who together with Gus Rivers, who is going to join us virtually, are going to tell us a little bit about how all this started and the history of the journal. Nick, I'm going to leave you with this slide. In that first editorial, the editors wrote that we wanted in the journal distribute knowledge and create research that was evidence-based, and that we wanted the journal to be eminent and international and focusing only on integrated care matters. Is this the way it started? So we are going to invite Gus to come to the session virtually, and Nick, the mic is yours.
Hi, Gus, how are you?
I'm fine. I listened. It was a very good speech by the chair, and I'm happy to see there is so much growth in papers, and it is, but on the other hand, the editorial we started 25 years ago is really not old-fashioned. It is still the same. You could write it down by copy-paste in the next journal, because it is so up to date. Thank you for inviting me. inviting me, and I'm sorry not coming to you. I will come in Birmingham next year, but I have to teach integrated care tomorrow and Friday to professionals in the home. For me, that is the University Medical Center in Utrecht, where I am still professor since nearly 40 years.
Thank you, Huus. We're going to speak a little bit about the history of the journal now. So I'm going to say a few words, and I'm now going to pass over to you to give us the history, and I believe you have some slides as well. So I remember vividly in about the year 1999-2000, and I was working at the Health Services Management Centre. That's at the University of Birmingham in the UK. And our director was Professor Sir Chris Ham, who was pretty well known in Europe as one of the leading advocates and leaders for the integrated care movement, particularly around Kaiser Permanente and understanding how our own health and social care in England should reform. So I was called into his office, not knowing what it was about, which is always slightly nerve-wracking. And I walked in and he said, I've been contacted by my colleagues in Netherlands to a meeting that they want to hold in Almere in the Netherlands to establish a new journal. Would you like to go in my place? So whereas I'm sure Guus would have liked to have had Professor Sir Chris Ham, he got me as an early mid-career researcher instead. But I'm ever grateful for that because, of course, for me, it started a 25 journey in integrated care that has kind of led us to different spots, including this one. So how fantastic is that? And of course, when I went to Almere, I found a lot of interesting things. Firstly, it's freezing cold. How many people are here from the Netherlands? Yeah, so, okay, so the wind was coming in across the Dutch polder, across this windswept place, and I'm meeting Guus and all of his colleagues, and I've come from England, and I'm absolutely freezing cold. But it's an amazing place, because Guus and his colleagues had worked with Hans van Oosterbos to create the Almere Healthcare Group, which was one of the first purpose-designed integrated health and social care systems in the world, based around primary healthcare in Almere. So we learned a lot around what they were doing. We went to go and do a little different site visits, and then we sat down with a whole range of different people who I got introduced to, including some of the leaders of the integrated care movement at the time, such as Professor Cor Spreeuwenberg, Professor Barry Middle, I think we had Professor Dennis Kodner, maybe colleagues from Canada and internationally, to start thinking through what would this new journal look like that was being created between the University Library Utrecht, who were creating a digital publishing unit, an online publishing unit, with the content driven by Professor Schrijvers and his team. And it was an amazing experience, and Professor Schrijvers couldn't have been more delightful in bringing me under his wing to take us forward. So, but Guus, you are the father of the journal with Bas and others from the University Library Utrecht, so I'm going to pass to you to give us a bit of a history from your point of view about the whole thing was founded.
Thank you very much for this beautiful story. And I have the impression that I will tell something is the same. But I will keep it short. I prepared some PowerPoint slides. I will share these. And now, I do that now. If I am able to find my way, I come. Okay. Could you help me, the administrators, share this? I start with this. Chair, could you confirm that you see this?
Yes, we can see it perfectly, Guus.
And this is my contribution. And I made a research question. I make a joke, but why did the Utrecht University Library start in 2000 the publishing of the online International Journal of Integrated Care? That is the question. I have a quick answer. I have 4 reasons. And I could talk with every reason 15 minutes because it was so beautiful to tell, and I have the age of 75, and I should talk much to the next generation. However, the integrated care was already developed in the Netherlands, I had wind in the back when I'm cycling in the Netherlands. It is very windy here, but I had wind in the back. So that was the same was the case in other countries, also in the UK. And with Chris Ham, he was in the front, and he was a colleague of mine. And I was a little bit disillusioned that he chose the British Medical Journal for his ideas to compare the National Health Service and the Kaiser Permanente. He should publish that in our journal. But nevertheless, he became a good friend also later, and a brilliant idea to send Nick to Almere. Then, second point, there was a Utrecht librarian of the university, Bas Saveneye. He had the ambition to innovate the library of the university and to start with online scientific journals with another business model. The authors are paying and not the readers. And it is an open access. That was his idea, and that was rather new for him and also for me. And we made more or less, I was in that year, I was in the Workers' Council of the UMC Utrecht. And the person in the chair near to me was the Utrecht medical librarian. That is, let me say, the vice president of the library. And she introduced me in 1997 to Bas, and later I introduced Nick to him. He is our godfather. In the first 12 years, he sponsored us, and he gave support with his staff, and he was successful also with his own ambitions. It was more or less a joint venture. He was not really interested in integrated care. I was not really interested in digital journals. However, he told me you should combine it with a virtual community. And because he liked people, the scientists in the 17th century who were writing letters to each other. And he had the idea that could be renewed, refreshed between that. And finally, I was a social entrepreneur within the UMC, and I was organizing congresses for postgraduates, for people, professionals, policymakers, and I did that from the start because it gave me some extra money and it gave me a good network to get PhD students and so on. And this together was what happened before in 1997. And I could stop now, Nick. If you have more questions to explain one of the 4 reasons, I have other slides.
I think that's great, Hoos. Maybe we have a conversation because when we started out with the journal, I think in the early days we had a small group of people, and what we wanted to do was create. I think there was one idea for a European Society of Integrated Care, and then we came up with the idea of the International Network for Integrated Care, and I believe it was in Birmingham again in 2003, where we held a conference at the Birmingham Botanical Gardens, where we launched the network. Is that right? That's what happened, wasn't it?
Yeah, that is true. That is true. And that was the first thing. And what you talked about the Almere, I come back to this. I must find out. Well, here, about myself, I wrote my first paper on integrated care already in 1972. That was also the first paper in my career. And I was working there at the Faculty of Medicine in Utrecht. I saw wrote in 1980, I was city councillor of Utrecht. And there, during 10 years, I had a portfolio of public health, social service, youth health, and primary health care. I combined that with writing my PhD thesis. And there I saw in 1974 the big reorganization in the UK. in 1974, and I visited 4 or 5 times a year. We had plenty, we had enough money as a university in those years to follow all the discussion of one tier too many, the district management team, integration, health planning, and that was, we had in Holland the same, more or less the same ideas, but not an NHS. In Sweden, so I had already more or less an informal network that made me professor of public health in 1987. And it is the period of 1980 until 1990, I wrote PhD thesis, how could we organize integrated care in the Netherlands? And then 4 weeks later, the important people, the VIPs from Almere, a new town, come to me and please, could you realize the integrated care in the new town of Almere together with a lawyer and a general practitioner. That was the Troika. And we said there should come integrated care through the front door or to the back door or through the windows, but this should be a city, a showcase. And until the day of today, I have contact with Almere. I see it as one of my right things. I did a lot of wrong things, and that it was completely right that we came together and that we were sponsored by Almere and also by the university library. And then that was an important day, and Birmingham was important for me. And also a year later, in 2001, we came together with a small group in Maastricht. That was a new university, is a new, it started then 5 or 10 years earlier, and we had there our, more or less, our first congress, and later in Birmingham we had plenty of people, and I am happy that we stay in the position that we try to reach professionals, scientists, and CEOs of health services. In my career, I had sometimes the role of scientist, sometimes more as an entrepreneur, and then I also as a city councillor, I was busy with the public health, and that is difficult. And in previous years, if you were an artist in the Netherlands and also in other countries, you had one role. You were, for instance, a theater player. But later, you had to play in a musical, and you have to sing, and you have to dance, and you have to play. And that is what sometimes I had the feeling, I'm not good enough as a health economist, not good enough as a politician, not good enough as a CEO. And other moments I had the feeling I am multi-talented, but that was not always the case. And I'm very happy to celebrate this 21st anniversary of the International Journal of Integrated Care.
Thank you, Koos. And I think you're absolutely right. At the beginning, integrated care, whilst it has a history, we were all kind of at the forefront and pioneers of what this was. Because even for myself and others who are involved in integrated care, you want to be able to influence healthcare providers and policymakers and academics and patient advocate groups to understand what this means in terms of proving care and outcomes for people. So for me, it's always been this opportunity to use the journal to provide the scientific evidence that's going to be required to make the decisions that people need to have that you heard at this morning's plenary to make a difference, to move towards new organizational structures or funding mechanisms or ways of working that can embed new ideas. So the idea of creating some science behind that through the journal to create credibility behind the belief that we need to change the system was always there. And right from the very beginning, we wanted to make sure that the journal was high quality. Because you see today, a lot of the online open access journals not a very high quality, and you can put any sorts of papers in there. But we wanted to make sure right from the very beginning that we were at the forefront of science. We wanted to emulate the British Medical Journal. We wanted double-blind peer review. We wanted to ensure that all of our governance processes behind the journal were as best as they could be. But in the early stages, Hus is right. We would come together, the library would sponsor us to come together, and we would go to Maastricht, and then I think we went to Strasbourg, then we went to Barcelona, and more people started to come, but we're talking 10s and 20s and 30s. And actually in those days, we would bring full papers. We would write full papers, and we would bring them, we would present them, and then people would annotate them. On the basis, these full papers would then end up in the journal, because we were starting off at a very early stage. And we recognized that we needed to create a double mechanism, not just of the journal to publish the articles, but of the network and a society that could bring people together to share information, to come together to actually advance the research, which would help the journal to gain more papers, more valuable papers going forward. So we created the International Network of Integrated Care in 2004, and a first foundation was created between the 3 Dutch universities and the library. So you had the network on the one side, which I became chair of, and the journal on the other side, of which Hus was the editor-in-chief, working together for a number of years. And then we had a little bit of hiatus. Clearly, at some point, the BAS couldn't keep bankrolling us after 12 years of supporting the journal. So we ended up coming to think through, well, how do we now transition to a different approach? And we created the International Foundation of Integrated Care between us, co-founded that in 2011, and the journal was then transitioned across from the library to Ubiquity Press a few years later, which is now our professional open access publisher. And through that time, and the ability to have the network and the foundation to grow, as you see today, 1,000 people from 60 countries, I heard, and generally more than that, across the foundation today. There's a really rich opportunity for coming together to share ideas that has fueled the growth that you see in the journal, and also its impact. Being a Category 1 journal in all of those 3 areas is something we probably didn't dream of back in the year 2000. But at the time, it was very much a group of pioneers in, like Koos Vreewenberg, in developing nurse-led primary care, pioneers in like Hus, who was understanding how to develop the political systems and the systems you needed to create it. Others, like Professor Koos Vreewenberg, who understood about long-term care and the ability to create integrated care systems for health and social care to dual eligibles in the United States. These were all pioneers at the interface of academia, of practice, and of policy. So no real place to sit, sitting at the edges of all of these different things. And integrated care still sits at the edges of all of these different things. So as we go through the conference today, I think you will hear the importance of having a scientific journal to understand the impact of integrated care, which we're going to talk about a little bit later. Because without that place, integrated care can be a little bit lost, because it's always at the edge of our systems and how we develop things. And we recognize that it needed to be near the middle of things. I know we're close to the end of our time. I'd like to thank you. You might remind me of the people, Hus, but I think we should take this opportunity to thank the people who actually enabled the journal to grow over the 25 years that it is today. So from the University of Library, Utrecht, you heard of Bas, but there was also the original managing editor, which was Stephanie Helfreich, I believe, and then it was Erika Manten, Saskia Franken, and then for the network, there was a lady called Jennifer Smith who helped us with the network. So all of those from the library, I believe, were really instrumental in the early days. And then Erika, towards 2008-9, handed it over to Dr. Lourdes Ferrer, who's in the room, as the managing editor, and then to Susan Royer, who's our managing editor today. But of course, a lot of it came back to Hus at the University Medical Center Utrecht, particularly the Julius Center, who had to pick up the pieces for a number of years before we transitioned across to the foundation. And I think with Hus's leadership, with Clarine Cies, Annette Esser, and others, we've been able to now progress to the foundation and journal as you see it today with all of the organizing colleagues that you see. And to all of those and their generosity and their time, we've been able to progress the journal along. And at many points it's been an issue. You do an open access digital journal, and at some point you want to get it impact rated. So we ask those people who do the citation indexes like PubMed and elsewhere, what do we need to do? And we had to go through a whole process of completely changing the way the online journal was positioned and created in order to get it into the citation indexes. And that enabled us to get the first impact rating that you saw back in, I think, 2012 or something like that. And then there was another one that we now got to transition from the library to a new publishing unit. So we've got to take all of those articles and position them in a whole new Ubiquity Press publishing unit, which is another huge task, which I think was Lourdes and Susan and others doing that. It's a huge amount of effort behind the scenes from both the library, from Guus's colleagues in the Netherlands in particular. Would have happened many, many times, I think, are we doing the right thing? Is this the right nature of the journal? Are we getting enough But the thing is, integrated care is always going to be necessary. So if Guus is saying those original things we wrote 25 years ago are still relevant today, they are. Because it is a question, it's not a question of should we do integrated care, it's a question of how we do it. And how do we convince people that we should do it? And it's always been that question, and that's what we heard this morning. Guus, I've got to hand back to Edelweiss to carry on the next sessions. Any last words of advice and wisdom from our founder?
I have one question to you. Do you remember that we had a long, long debate about where we have to pay our value-added tax in Holland or in England or in Spain, where we had a Congress, and we had to come over because we were a small, very small multinational, and multinationals always are thinking, where should we pay least and how to create a construction? And have you this problem still until the day of today, or is it old-fashioned?
We have now, thankfully, with Georgina Ferrer and everyone else at the Foundation, a very professional organizational setup in terms of its financials and management. I understand, because I've not been involved for 6 years, Guus, but it was a problem for me when I was leading, but I'm not leading anymore. I don't think it's a problem for these guys, because not only has the Foundation grown in terms of its membership and reach, it's grown in terms of its organizational capability and professionalism, which I think we should all celebrate as well.
Okay.
Thank you.
Thank you.
Edelweiss.
It was nice to see you. Yeah.
So thank you so much, Nick and Guus. Can I just also highlight that we are celebrating 25 years of the journal. And as you have seen in this presentation, we're also celebrating 25 years of Nick being the editor-in-chief in the journal. There is no journal without Nick in all those years. And we hope to have him linked to the journal in any way he wants for a long, long future. And thank you so much. He has mentioned lots of people that are in the audience, some and many that are not in the audience, but all of you are really important for the journal to advance. And one of the things that is really important is the authors and the people who write the scientific papers. And one of the authors that have published a lot himself and his team is Nick Sonnenberg. He is going to explain a little bit one of the review we did, because we have started with the history, how all this started, but we have also revised what have we done in the past 10 years? What type of publications have we done? So Nick, what have we done? What was the result?
Thank you very much, Edelweiss, for introducing me. Well, have you ever had the chance to review all IJIC articles for the past decade? Well, I did. Well, luckily not all by myself, but as you can see here on the slide, we've had an amazing team. And it was quite an exciting undertaking, to be honest. And in total, we reviewed more than 500 papers. And we did that to get more grip on the development of integrated care knowledge, to celebrate the 25th birthday of the journal. Yeah, to do so, we identified trends and gaps in 10 years of articles in IJIC. And by listening to this short presentation of me now about our review, you can learn about what these major trends and gaps are. So that we as an IFIC community here today in Lisbon, we have a clearer view of what the actual state-of-the-art in integrated care is, but also that we have a clearer view of what the gaps are, so that we can develop a more concrete and a more focused research agenda, so that we can bring integrated care to a next level. First, I'll explain a little bit about the trends we identified in the review, and after that, I highlight 3 trends and gaps we found. First, geographical inequities, based on the geographical background of the authors in the journal. Second, the role of co-production with people with lived experience or actual service users, patients, clients. And third, the role of impact management in integrated care articles. Now, first, the overview of the trends and gaps we found in more than 500 papers in the International Journal of Integrated Care for the past decade. As Edelweiss already presented in a nice graph, you saw the number of publications is increasing steadily. So there's a growing interest in the field of integrated care, or, well, at least in the journal, in the International Journal of Integrated Care. What we also noticed, and well, that may not be a surprise, that the dominant contributors in the journal are primarily Western and high-income countries. And there are, well, especially 2 gaps we found when we analyzed the content of all these articles. And that, on the one hand, is impact measurement. There's no clear pattern in these 10 years or progress when it comes to the actual measurement of impact and outcomes of integrated care. And the other issue that we identified is co-production. Less than 5% of the studies actually engaged people with lived experience or service users, clients, patients. And that was also a point that was striking according to the research team. Well, there's also a positive development here, looking at the co-production issue, that is that there was actually an increased involvement of people working in integrated care, so professionals and policymakers. Now, let's start with the geographic inequities. Well, as I said, it may not be a surprise, but it's still important, I think, to address this, that most publications in IJIC for the past 10 years are dominated by European or North American or Western Pacific authors and research groups. And there is still an underrepresentation of scientists publishing in the journal from low and middle income countries. And in the research team, we also, well, discussed a little bit about what possible explanations for this could be. Is this about limited infrastructure, for example, in low and middle income countries? Is it about funding or publication support? Or, on the other hand, is it an issue of that the focus of the researchers from these countries is more on the global health journals, for example, instead of IJIC? So, well, I have to say there were a couple of examples, but, well, it's still underreported. So, yeah, I would like to use this opportunity to also call for a more inclusive and globally representative research agenda here at this conference today. The second theme that arose from our analysis was the role of co-production. That is still rare. It is emerging, and there's more attention for co-production, I think, across all kinds of journals for the last years. But it's still surprisingly low when we looked at our analysis. There's a low patient or community involvement in research that is published in IJIC. And yeah, there's also a low representation of people with lived experience. And also here we thought about, well, what could be possible barriers to not do co-production? Is it a lack of funding, for example, because it could take more time or takes more financial budget? Is it about power dynamics, the researcher-centered paradigms we all know? Or is it maybe about skills? Do we simply do not know how to do co-production in research, in integrated care research? And now there's some recent progress, and I think we are also going to touch on that in our later discussion. But IJIC took some steps to develop this point a little bit more. IJIC now includes editors with lived experience, as you also saw in the presentation of Edelweiss. There are revised author guidelines, as you also may have seen when you submitted your abstract for this conference. And lastly, we see that there's a rise of implementation science and also participatory action research in which you can actually include people with lived experience. And the third point I want to discuss is the role of impact measurement. So what are the actual outcomes of integrated care, and why can't we find them in international research and in the International Journal of Integrated Care? In the analysis we did, so on 10 years IJIC articles, we didn't see a trend in impact-focused research within IJIC, although policy calls for it. And also here we thought about, well, what could be possible challenges, possible complexities, difficulties? Why is it so difficult to measure impact in integrated care? And we came to a couple of points. First, there are very diverse stakeholder views on what impact actually means and what outcomes should be of integrated care. Second, methodological complexity. We see that the development of integrated care services, but also of collaborations and networks, take a very long time. In fact, maybe they have a timeline of 10, 15 years. And our research methodologies and also our research budget do not account for that. And lastly, naturally, in practice, we see a lot of pressure on workforce. We see a lack of data integration, so it could also be a practical issue. And well, as a research team, we discussed, so what do we need to take a step forward in impact measurement? And we thought, well, a first thing we could do and develop more theory on as well is to have clearer definitions of what we actually want to achieve with integrated care and how the outcome should look like. Second, I would propose and call here for more long-term and multi-perspective evaluations. So to break integrated care, break the black box of integrated care in more pieces and study these pieces from multiple perspectives, in multiple timelines, and with multiple methods. And lastly, I think it's very important that we do research by which we can actually demonstrate to our funders, to policymakers, what the impact of integrated care is. So we should also invest in our marketing, I think. So this was a very quick overview of our analysis on 10 years papers in IJIC. I hope you learned what the trends and the gaps are. And if you are interested in more insights about this research project, we are preparing a publication which will hopefully be published very soon. Thank you very much.
Fantastic. Thank you, Nick, for summarising a very complex set of activities that were undertaken, and to you and Jessica for leading the review as well. So we've heard about the background to the International Journal of Integrated Care. We've talked about the research that we publish and some of our gaps. And we wanted to finish this session by thinking about how we respond to those gaps, because we're very aware as a journal that we're here to add to scientific knowledge, to provide people with the insights they need to deliver and to commission and to plan integrated care. And as Nick said, we were very surprised and a little bit disappointed to think actually that the science of impact had not developed as much as we probably would have thought over 25 years of the journal. And so Nick is going to be leading a special issue on impact, which is going to be launched imminently. But we thought it'd be good to have a discussion today about what are some of the challenges and the opportunities for better understanding impact in integrated care. So we're going to have 3 new people join us on the stage. So if you could come up and join us on the panel, that'd be fantastic. So yeah, we've got Cara and we've got Michelle, we've got Eskil. And they're going to come and join the panel. And we've got some questions here. And I think you can lodge questions through the app as well. And maybe Edelweiss will be over those and can highlight any topics that come up. So you've already met the 2 Nicks, which is somewhat confusing in a panel. But we're very pleased to be joined by Eskil, who's one of our lived experience editors. And Eskil is based in Sweden. He's the Vice Chairman of the Swedish Brain Tumour Association and has done extensive research at Karolinska and Gothenburg University. So it's a great addition to our editorial board. We've got Michelle Nelson, who's our newest Editor-in-Chief. Michelle is a researcher and a scientist based at Sinai Health and University of Toronto in Canada, and has done a lot of work thinking about the experiences and outcomes of people with complex health needs and how we can respond to those in a person-centred and community-orientated way. And for example, just now she's undertaking a really big randomised control trial project looking at the role of volunteers in people who have experienced a stroke and have been discharged from hospital. And finally, last but not least, we have Cara English, who is originates from the USA, currently lives in Portugal, so had a very short journey here today, and who is the Chief Executive Officer of the Graduate Institute for Behavioural Health Studies. And amongst other things, they do postdoctoral studies in integrated care and have recently celebrated 10 years of running those programs, which is not only amazing to get that up and running, but to sustain it, which is often the hard thing. So, panel. To set you going, and we like to go for short and snappy answers in the panel if we can. Nick G, we're going to go through the panel and ask for one quick challenge that you often see in relation to impact and integrated care. So.
Wow. Well, the biggest challenge is, of course, integrated care is a complex service innovation.
Yep.
So if you're going to be able to understand what the impact of your integrated care program is, you also have to understand how all of the interplay between the different organizations and players works.
Yep.
So it's not like a clinical trial where you have a drug and then you have an outcome. You have all of this section in the center, which influences what you're trying to do with what the outcome is. And in fact, once you start thinking about it, that's actually the intervention itself. It's not what you're designing, it's how it's actually implemented in the networks that you create. But unfortunately, it's really complex to do. It requires multi-methodological approaches. It requires quite a lot of in-depth understanding of the interplay. And the further you go into that, the harder it is to understand the generative causation between what you put in place and the outcome that you observe. So the hardest thing, I think, is understanding the complexity and finding the methods to understand why impact occurred.
Fantastic.
Because you can see impact has occurred, but actually, if you don't know why, it's not very helpful.
Great. Thanks, Nick. So, complex, and we're not always clear what's actually led to the impacts or stopped the impacts being achieved. Nick said, what would you be your challenge? And it gets harder to go around as you go around the panel, clearly.
Well, when it comes to impact, I'm afraid that a lot of people, I come from Netherlands, so especially in the Netherlands, are mistaken impact for process. So when I study a lot of healthcare networks and I ask, what did you achieve? What is your impact? What are your outcomes? The answer is usually, well, we are getting along very well. And there's a lot of trust between the organizations. And that's not really impact yet. Maybe that's one of the conditions. And a recent literature review, for example, of Robin Peters from Maastricht University. She did a large review on effectiveness of integrated care networks, and a lot of these determinants were process related instead of actually outcome related.
Yeah, okay, so we can feel that we're making good collaborative relationships, we can feel we've got good guidelines in place, but actually are we making a difference to the people who matter in terms of the people who receive the service? Cara?
I spend most of my time doing education and training and looking at workforce development, and my doctoral students are all either part or full-time employed in healthcare worker positions. And so at the foundational level, we're trying to look at theories and models of change and how to achieve that, but at the same time, in their workplace, they're trying to apply that. And they are in the trenches each and every day, applying what they're learning, but also typically the only person qualified to educate anyone else, including those above them, those funding them, those organizing and making decisions about the entire system, about what integrated care is, or even some of the foundational concepts of integrated care. So their challenge is not that they don't understand it or that they can't apply it. Their challenge is that the system isn't prepared to do that, and that there isn't a system or structure in place to measure the impact. Also, there's no funding for that research because the funding is really directed more at the delivery of services.
Yep.
And then also just to go back to the point of impact to who? So if you ask any person in any healthcare site, the answer would be different. So, you know, for people who really care about efficiency from a cost perspective or efficiency from a how quickly did I get my grandfather in and out today perspective, the answer would really be different. So I think we need to think about providing support and also good models for that in a really wide range of needs to really get the kind of data. But I also think that quantitative and qualitative data are both important. So looking at mixed methods.
Back to that. We'll come back to that. Fantastic. So complex interventions, but also therefore complex data, and data is not necessarily joined up, and there's not the capacity in the system in order to understand that data. Michelle.
I'm going to try to add on. I think we have been and are on a cusp of experiencing and maybe sort of overcoming a disconnect between academic and practice. So I think what impact means in practice settings is not been conceptualized as impact in academic settings. So as an academic, I have a vision for the impact of my work, but then I have to propose each study as a brick that has outputs and potentially outcomes that I hope help me drive impact, but I don't necessarily articulate that. And so I think if you can't keep your North Star of impact and communicate it, I think you run the risk of producing studies that have outcomes that may be interesting in a particular setting at a particular time to a particular audience, but I don't know that they drive impact. And so I think we need to be really clear, what's the vision of impact? And can you truly achieve it with a single study?
Fantastic. So it's not
and maybe
only,
you can, but...
It's not only how we measure impact, it's about what impacts we want to achieve from our work and how we are being assessed and quantified in terms of our work as researchers. Esco. Not easy being the last person on the panel to respond to this, but anything else you'd like to add to that challenges of impact and integrated care?
I think we are missing, if we look for the drug development, they are really much now and demanding on real-world data evaluation. We see that the same evaluation pressure from medical devices. Why don't we see the same pressure on integrated care interventions, for example? And I will give you an example. I'm from the Brain Tumor Association, and we know that we can prolong life for a patient with a glioblastoma with a certain treatment for 4 to 5 months. We also know that we can really increase the caregiver burden of the ones who are caring for them. We don't measure that at all, that impact. And we know that children living next to brain tumor patients, or people with neurological disease, they will have a higher risk for committing suicide longer on in life. So we don't measure all the system. We only measure parts of the system. And by real-world data evaluation, more focus on measure things that matters to patients, next of kin, society, and children and family, we will also start to learn a little bit more. Because on the other hand, we know that some of the patients will live longer, Some of the next of kin will have a higher increase of caregiver burden, but some will have positive effects of being an informal caregiver. And we also know that some children will receive a higher level of risk for committing suicide, and some children are building resilience. So we also need to learn in the impact to understand that our interventions benefit to some and this benefit to others. And we need to put more into that.
Fantastic. Thank you, Eskil. So, thanks panel for that very helpful first thoughts about the challenges of impact evaluation and integrated care. And now we've got 3 questions we wanted you to think about in particular. The first thing is we've got researchers, and it takes many years of PhDs, of undertaking methodological courses, of applying your skills in a practical setting before somebody would be leading an impact evaluation integrated care. So they bring the methodological understanding, the theoretical insights, the understanding of how to apply tools. So what could people with lived experience bring to the process of planning and undertaking impact evaluations? Eskil, would you like to go first for this one, please?
Thanks for that question. I think people with lived experience can bring in a lot. And I'm a little bit biased in that concern, I will say also. But I must say what we can also learn from other scientific areas. And I think we should be really humble in that. We are really focusing on the medical science or social science. What can we learn how to use the lived experience, from example, for climate change or climate research? We know that there are more citizens today that are sharing their data, building their own stations for delivering high-quality pollution data than any university or government can ever manage. We know that, for example, in art diversity and biology, that without the citizen actually going out there and capture what type of species we found in the forest or remote areas, and for free send that data in, and we can use those data for so much more. So I believe lived experience is not something that we should use to have it just to have it. We should look at it, how can we increase the quality on what we're doing? How can we actually use the lived experience to increase the impact, but also by purpose and the quality of the research?
Fantastic. So people with lived experience can bring a richer quality and a richer depth of data to the research process or interpretation of that. Michelle, what would you agree with that, or would you add further contributions that people with lived experience can make to the research process?
So I was really struck by the comment, and you made it very quickly, so I'm going to want to follow up on this, around thinking about additional data points that come from lived experience. And so I'm taking that back because a few years ago, pivoted my research lab to investigator-driven to a living lab. And we convened citizen researchers, people with living experience of chronic conditions, policymakers, practitioners, researchers, and we came together to construct a research agenda. And actually, the study you talked about came out of that. And it has created a much more authentic and much more meaningful way to pursue the work. So it definitely links the impact to the day-to-day. And it's not necessarily about engaging lived experience, but everything we do comes out of the desire to be grounded in and have impact on lived experience of work, play, care, and life. And so it has changed the way we do everything.
Fantastic. And Cara, I know that the work you do at the Cummings Institute, the values of co-production are really embedded within it. So in terms of your PhD students and others, your doctoral students that you have, what are some of the challenges that they experience in relation to involving people with lived experience in their studies? And some of the examples that you have of how those could be overcome?
Sure. So one of the issues that I mentioned before was being, sort of the only integrated care expert in a site when you go to apply and then conduct applied research. So when that's true, there's often a lot of pressure to take a model that's academic and theoretical and to apply that in a setting without having involved anyone in the local context or having, contextualized it at all to the local population, to their needs. So I think, back to your original question, what can people with lived experience contribute? The answer is everything. Just from the perspective that if you're driving, if there's a bus going down the road with no driver, and that person should be the person with lived experience, if that's the person you're trying to help, the bus is going to go wild and completely off the street and hurt people. So, from the doctoral research perspective, we have found that unless we make it part of their assignment to make it required that they include individuals with lived experience, not only is it not thought of in the assignment process, which all of the assignments in our program are directly applied, but that will then prevent them from being able to be published, because in the Journal of Integrated Care, which we so appreciate, it gives us additional motivation to say, and this is now required. So we now have a double, point compass that says, remember, this is everything about what you're doing, and this is the compass point as well as the heart and soul of why you're here.
Fantastic. So as ever, kind of almost it's behavioural change for researchers, isn't it? And it's a incentive, but also a potential punishment if you don't do it, which really helps.
A carrot
to do that.
and a stick.
Yeah, exactly. So I'm going to move us on because time is tight. So we touched on earlier, Nick said about the fact that the different methodologies people use. And it can be very difficult if you're an integrated care researcher and you're trying to understand the impact of a program, to know the balance between quantitative and qualitative methods and data and how to apply those. This is a tough question, and I understand that. But from your experience, how do you go about trying to understand the balance between those different methods?
Well, I think as Nick Goodwin already put it, that integrated care is not just one intervention. It consists of a lot of building blocks, a lot of bricks, and all these bricks need different methods, in my opinion. So I think in the ideal situation, we would make a map of what the integrated care model consists of, and what parts should be quantitatively measured, and what part of the model we should use different methods for. And maybe we would also use different timelines for that. So I think if we would unravel it a bit more, then we could use both.
Okay, fantastic. Nick G, anything you would add to that? You've got an extensive experience of evaluations at a national level, but also
program evaluations, national evaluations, things that look at economics and things that look at process evaluations. I think it's hard. For me, I think it comes back to the co-productive process that I think Michelle talked about before, to understand what it is that you're actually trying to do in your evaluation. Because unless you are very clear in terms of what it is that you're really seeking to examine, and maybe you've worked through that co-production process to maybe understand a theory of logic as to what it is that you're looking at, you're going to find real difficulty in doing any form of evaluation with any methodology. It's going to give the answer to you're looking for.
Yeah.
So you need to be clear from the beginning what the aspirations and outputs you really want to focus on, and then you can work back to understand why do we think that's going to happen. And once you work through why this is going to happen, then you can work through your methodology. How do we collect the information to understand the why?
Yeah.
So it's all about that prior process of planning around the research, often with people with lived experience or the community that will answer that question better. And if you do that, you'll get to the question that you're looking for much better. So I've seen too many really good funded studies that end up with very unclear answers because they haven't defined the question from the beginning. So that would be my advice, is to spend that good 6 months with people working through what it is that you're really looking for, and why. Because otherwise, you could spend a lot of money and not get to an answer that you were really looking for. Even if the answer is we don't know, at least you've gone through the right process.
Thanks, Nick. And Michelle, I'm going to bring you in here if that's okay, because I know you're in the midst of this really big research project, which is, as I said, I'm calling it a randomized control trial, but it's a trial of some sorts. And it involves both, hardcore comparative data, but also interviews with professionals and people who access services. So yeah, what were some of the things that you had to juggle in your head when you're thinking about planning that study, and what have you learned from doing that?
Yeah, that's a good question. So I'm going to go back in time 2 years ago, and in our living lab, the question was, if we don't think we're going to have more health human resources, how are we going to support people from transitioning from hospital to home, and is there a way that we could leverage the power of community? So that's where we started. And that question actually came from our citizen researchers who had been living this experience and really said, okay, how do we do this? And so to Nick G's point, thinking about methods as tools, we said, what are the 3 things we want to know? And we said, we want to know, is this an effective way? Does it actually make a difference to people if we use volunteers to support transitions home? Does it make a difference against what? So we said coping. The second thing we said was how, so we know the what. The second was the how does this actually happen? Because that's what we want to come to this meeting eventually and talk about. So not the what, but the how. And then we said, okay, but the third thing is, what's the context? What's the organizational considerations that we need to think about? So we've got a what, we've got a how, and we've got a where. And so we've designed sub-studies with different methods to address each of those. So one of it is a trial, but the other is an implementation study, and the third is really a qualitative exploration of an organization to say, does this organization have the capacity to do this thing? And what does it look like if it's successful? So those are the things, when we think about impact, the effectiveness of the intervention is great, but what's going to make it scalable and impactful are the other components that tell people, if you want to do this, how do you move this intervention elsewhere?
Yeah, fantastic. Thanks, Michelle. No, that's really helpful, and I would encourage anybody who's thinking about doing a similar study to speak to you, because it's so well crafted and put together. I think it's going to have some really important insights. So final questions then. So often we see that politicians and people who fund integrated care services are most interested perhaps in what the savings is going to be and how has it affected their activity patterns, particularly admissions to hospital and discharges from hospital. Whereas often people who work in health and social care and people who access it and with lived experience are most interested in the quality and the personal and community outcomes from integrated care. Eskil, how do you think can we balance those two perspectives, or fundamentally we just have to live with the fact there's a tension?
Yes, I think we can. I think we have to be a little bit bold though. Yeah. And I think we have to look at different methodology on how to reach down. One size for sure will not make all. I'm from a civil organization, and sometimes I also think that we are so traditionally, when we look into integrated care, that we're how to save money, not to look at the outcome, but also to start to ask the civil society, how can we, what are those movements that they will spark? How can they be a part of this sparking movement? And since I'm working in a civil organization, when we are so much more focusing on the impact of integrated care, so we are more and more getting also to be the driver of the movement. And we are now starting to recruit researchers to join us, not that we are recruited by researchers. And that has turned out to be much more easier. And also in the funding part, it's easier for us to fund when we have been really, really driving on the research question on the methodology. And that comes back to the policymakers, because those are also human beings normally living in a democratized society. So now we are, all political parties now in Sweden are reaching out to us to say, can you help us to write their programs for healthcare? So a little bit empower the citizens, empower the persons that are doing this, and don't use us for tokenism that we should be there because we should be there, but start to collaborate. Was that a question,
Michelle.
great answer.
Michelle, does that, in terms of Canada, and there's been a lot of reforms in Canada around community health teams, etc. Is that tension played out politically?
I think when we take it down to the most basic, sometimes I think there is this perception about we need to save money. We need efficient systems, and that results in discussions about cost effectiveness. But I think if you take it to civil society, people will say, but we want good outcomes for our dollars. And so that's not the same as cost effective. So I think we need to be really clear about what is the expectation around value for money, and recognize that we're often talking about the same outcome. So we talk about wanting to reduce days in hospital. People want more days at home. That's the same. That's the same outcome. Days at home, days in hospital. They're inverse. And so I think when we start, we could reposition how we talk about things to create better alignment with our policymakers.
Thanks, Michelle. Cara, you've moved recently, as we said, from the States to Europe. Do you see a similar debates being played out in Europe as there were in the States, or?
Yeah, we've definitely seen a huge evolution in the way that, well, buzzwords are used, right, to talk about cost and cost savings. About at least two and a half decades ago, the founder of the Cummings Institute, Dr. Nicholas Cummings, was writing about the medical cost offset. And what he meant by that was when you simply integrate mental and behavioral health into primary care to treat the mental health and behavioral health aspects of chronic diseases, including preventing or delaying onset of chronic diseases, by nature you save medical costs. You also save physicians who aren't trained in mental health and behavioral health from sending patients for unnecessary procedures, surgeries, pain management clinics. And so the medical cost offset, I think, is an important concept to all, because patients don't want, none of us wants to go for an unnecessary procedure. It's time and hassle and money, and none of our physicians really want that either. And the second piece is that when you look only at what the U.S. Institute for Healthcare Improvement called the triple aim, right? Patient engagement, patient experience, and cost savings. 10 years after the triple aim was published, the outcomes data indicated that they actually were losing a lot of money and that health outcomes were poorer because you forgot completely about the people who were delivering the care, and their lives were miserable, which led to further burnout and more medical mistakes and medical errors and poor patient experience. So, you know, we're talking now about the quadruple and quintuple aims, and that's okay, but I think if we just focus on that idea that if we're providing really good care and it's organized around the individual and the family and the community needs, we'll probably save medical costs.
Fantastic. So good quality care is more effective care as well. So, Nick, Zig-Zed, so you've done lots of work around values of integrated care. Yeah, do you see this tension in the fundamental values that people bring, which underpin their expectations and their practice of integration?
Yeah, definitely. We did a large-scale study in 2022, funded by the WHO, with more than 1,000 people in different roles in integrated care. And we basically asked them what underlying values of integrated care do you find most important? And in this set were cost effectiveness, but also person-centeredness, for example. And yeah, this may be an open door, but clients and service users, patients, people with lived experience, prioritize different values than policymakers, and also different values than professionals. Although they all thought, well, this whole set of values it's all very important, but when you really ask them to make a trade-off, what are the most important for you, then we saw differences between these stakeholder groups. And I think that's logical, but it's also important to be very clear about that and to engage in a dialogue about that, to save you from false expectations as well. Yeah.
Fantastic. Nick, your last comment from the panel then, so maybe respond to that, but also say, just to give people a little kind of insight in terms of the special issue that's coming up and what sort of things you'd be after.
Oh, wow. I mean, I agree with Nick. I think there is a mismatch of motivations that's natural in integrated care. So the answer to your question is that in theory, we should be able to find approaches that not only improve care and outcomes for people, improve the lived experience, but also maybe save us money or at least add value. That's the hypothesis of integrated care. The reality is, when you're on the ground delivering it, certain things tend to get in the way of our ability to deliver higher quality of care. And a lot of that is the tyranny of the now and the ability to create savings or the ability to do certain things. So I've seen too many projects where you've come in and all of the soft issues are on the table. It's got to be people-centered. We'll have co-design and co-creation methodologies. It's all about the community that we serve. But over time, the voice of people and the voice of professionals trying to do better for those people is crowded out as the concerns in relation to clinical quality, utilization rates of hospitals, money issues and other issues come to play. So too many projects end up going down a path that end up with, because we get a lot of pilot projects and a lot of small scale projects, they just disappear. And it's very hard for people on the ground who have the motivation to do the first aspect, which is improve. Everybody wants to improve care and outcomes for people. Every professional does, every person wants, every community does, probably every policymaker does. But all of these other things need to happen at the same time. So finding a project that does both is really hard. So thinking about the special issue, so many of you here will be submitting your articles to our special issue on impact. I think there are a number of things here. I think there are three challenges. What do we mean by impact? Which is all to do with the values and the different things that we've just discussed. What are the methods that we need in order to be able to judge impact effectively? And that's everything from understanding of the design right the way through to the methodologies that you use and the data results that you have. But also we're looking for the impact itself. And I think if it's one of the things that we've seen over 25 years where the science is weak, it's in two things. One is in the implementation science. We don't do enough around what we need to do to make things happen. So let's say we take realistic evaluation. We've got realistic evaluation leaders in the room. This will tell us an understanding of the sea, which we need to sail to get integrated care done. And it'll also tell you the design of the ship that you need to sail across that sea. But actually it doesn't tell you a whole bunch of other things around how you're going to navigate that ocean and what you're going to need in order to be able to deliver it. And for the policymaker, that's really hard, because it's saying we definitely need to do something, but we don't actually quite know how we're going to sail this sea. Despite the fact we understand the sea and we understand the ship, we don't know how to sail. So the implementation science of being able to get from one place to another is missing. And where people come up with the answers to that, it's very vague. It was the leadership. It was the management. It was something to do with relationships. It was the fact we didn't do this or that. And these are the soft factors that we need to try to work in to understand impact better. So that's the first thing, is implementation science. And the other thing is really trying to understand value so that we actually can deliver to the policymakers or to the Treasury a recognition of the return that you're getting. And whilst we have chronic disease management and some of those where you can create methodology which can give you an answer to that, a lot of that is missing, and a lot of the understanding of why that impact happened is missing. So for me, these are a lot of the challenges right across the spectrum. So we're looking for articles that can help us at least begin to navigate in a direction to help us, support us, what we need to do next in terms of approaching integrated care from a new angle maybe, but also I'd love to be able to see more articles that are beginning to demonstrate a whole range of impacts and how that's influencing the way we deliver care.
Fantastic. So look, thank you very much, panel. I've worked you very hard. You've responded very succinctly and clearly. So a round of applause for the panel. Thank you. And now, Victoria Stein, our final editor-in-chief, is just going to round the session off. So I'll hand over to you, Victoria.
Thanks a lot, Robin, and thanks to all of my colleagues. It's actually, I've never been called a chief, so thank you for that, Robin. We've only got a couple of minutes left, and actually we heard a lot of what we need to do and where we as integrated care community, but also as a journal, need to go to. So I think it is very clear for us as the editors-in-chief of the journal where we want to take it. And that is, as Nick has said before, on the one hand, actually launching a special edition on what is impact, how do we measure impact, what are those different perspectives that you were talking about as well, and what are those different methodologies, how do we combine them. It is also the second big gap that we addressed, and that is how do we engage people with lived and living experience in the research process and in our publication process. And for that, I want to invite you to a workshop that we're holding this afternoon at 4:30 in Fernando Pessoa. 5D is the session number. And that's where we will workshop together with you around how do we actually do it? How do we ensure that people with lived experience are actually included, are the ones who are leading and defining the research questions, and how do we then work together to also get those skills and competencies in place. And then obviously another big issue for us is to actually extend our reach. Because yes, we've seen in the history that we've grown from a group of enthusiasts of 10 people to over 1,000 now. And the foundation has, I think, 32,000 members now. So it has spread, but it definitely hasn't spread equally across the globe. And so also, if you have contacts, if you have projects that actually are based in low and middle income countries, if you have colleagues from those countries, please encourage them to submit, but also to contribute to the journal, because we do acknowledge that we are biased in what we publish. And so I think those are really the next steps that we want to address as editors-in-chief and with our editorial board members. And the final minute I would like to really spend in thanking one of our founding fathers. As we've heard, Nick Goodwin has been at the forefront for more than 25 years. And he's agreed, he said he would be stepping down as editor-in-chief after this conference and really focus on other areas in integrated care, other research projects, still contributing to the journal. But I think we know that none of us would be here if it weren't for him. He was the first person I met when I first started doing integrated care and joining the network in 2007. He's been a huge supporter and mentor for many of us, and every conversation you have with him is inspiring and brings up new ideas, new thoughts, and challenges. He's somebody who really also likes to challenge the status quo and challenge the thinking, which doesn't always go down well, I have to say. But without him, we wouldn't be here, the foundation wouldn't be here, and the journal certainly wouldn't be here. So, Nick, thank you really very much for all your energy that you put into integrated care, into the network, into the journal for the past 25 years, supported by your lovely wife, Lourdes Ferrer, who's been part of the journal as well. And this is just a very small token, actually. And I think it's a bit too small.
That's orange.
And it's orange, yes. So a t-shirt that
George,
everybody can sign with the Journal of Integrated Care leading since 2000. So thank you very much, really. A big round of applause.
Thank you. All right. You want me to speech? Oh, look, it's been a pleasure. The whole thing is such, everybody in this room is a believer in this. And I think that's what I got infected by that 25 years ago. And I suppose as I started, I was an academic, interested in complexity, things like that, as colleagues are here are. So for me, there was an academic question, first of all, around why is it that all of these things we can't do, or how do we do them? But then very quickly, when you hear about what's happening to people, particularly older people, which we heard this morning in the plenary, this can't be right. The way that we treat people, the way we treat older people, the way that the way the systems fail systematically to support the most vulnerable in our society is acute across every country we ever go to. So for me, it became much more than just an academic exercise very early on. It became a mission to do something. And the journal and the ability to put some science behind it, to be able to put some energy behind it, to be able to put a foundation behind it that promotes these sorts of questions alongside all of the other questions that can promote quality in health and social care was very meaningful to me from a very early stage. So that's what we've been trying to do. And now we have thousands of people coming to a conference and a network across the foundation, 80 nations and more strong. So it's been amazing. But it's a self-fulfilling prophecy because this matters and people understand that it matters. So we built it and they came. And it's been fantastic. So thank you. Very kind words. Thank you.
So thanks again. See you this afternoon or see you tomorrow at 8 for Meet the Editors of the International Journal for Integrated Care. Have fun.
If you're in the room for this workshop, please do take your seats and we'll just kick off. So, welcome everybody to this one-hour workshop on hospital-at-home and community-based hospital alternatives. I have the pleasure today of moderating this session. I'm Donna Henderson and I'm Head of International Engagement with the Scottish Government. And I have the pleasure of being here with my colleagues today who are going to share their insights into their services and experiences of hospital-at-home and other alternatives to hospital care. So the format for today is going to be that each of our presenters are going to give their experiences and insights, and then we're going to wrap up and take some questions. One of the sessions I think will probably have some questions at the end, but we'll just have a little informal discussion as well. So when we reach the time for Q&A, you can do that by going to one of the 2 central microphones that are here. So please do make your way for that. Okay, so let's just get kicked off. So we're going to start today with Dr. Yun Hu. So she's just going to do a presentation from up at the podium. And she's going to tell us about evaluating the patient outcomes and cost effectiveness of the medical home service, a hospital-at-home integrated care service by Yushan Health in Singapore. So over to you, Dr. Hu.
Thanks, Donna, for the kind introduction. And good afternoon, everyone. I'm happy to be here today to share with you a hospital-at-home services delivered by my hospital. Yeah. Let me try to click this thing. Sorry, I may need a little bit help. How to go to the next slide?
This one goes forward, this one goes back.
Yeah, okay. All right, okay. So first of all, let me share about my organization with you first. So my institution is part of the National Healthcare Group of Singapore. We are looking after 1/3 of the population, so which located in the central part of Singapore. And my hospital is in the red circle. Okay, we are looking after the 330,000 populations at the northern part of Singapore. So my institution actually is a part of a regional health system. We have an acute hospital with 800 beds and a community hospital with 200 beds looking after patients of rehab needs and subacute needs. Of course, we also actively engage our residents and the partners in the community to continue the care beyond hospital settings. Okay, as a regional health system, so one priority we have identified for our service delivery system is to expand our acute care beyond hospital. So engage our partners and deliver the service to the patient's doorstep is one of the mandates. And in 2019, we start to pilot a service, hospital-at-home service. So we'll call it medical home in our hospital. So the patients were identified by the clinicians. If they are suitable for the service, acute care, they have the needs to be admitted to hospital, but we evaluate them by medical criteria and some other administrative criteria. If they are suitable, then they will be recruited to these medical home services. Yeah, so this is a complete in screening criteria. So we have the inclusion criteria mainly based on the medical conditions. We also have some exclusion criteria. So this is to make sure the feasibility of delivery of services, also to ensure the safety and the quality of our patients. Yeah. So our service evaluation team actually conducted a quasi-experimental study to evaluate the outcome and the health outcome and the cost effectiveness of this analysis of this service. We have recruited 125 patients together with the caregiver who joined these medical home services. And on the other side, we also have the equal number of patients being admitted to this conventional care, which means in the hospital wards. So those patients serve as control. Actually, they fulfill the same criteria. Yeah, they are eligible for the medical home services, but they either reject our service due to personal reasons, or they are staying, far beyond our catchment area, or our medical service at that moment is fully, occupied, so beyond our capacity, so we have to put the patients in the hospital settings. So these two groups, we did a comparison. The data was collected at the admission, at discharge, and also at 90 days post-discharge. So we try to compare the outcome, the clinical outcome, functional outcome, experience, and the cost outcome to the patients. And the cost-effectiveness analysis also been conducted. This evaluation actually is funded by our Ministry of Health Transformation. So we also collaborate with our research bodies in Singapore, Clinical Research Council. Yeah, there's some example of patient profiles of these two groups. Actually, from the results we can see, they are largely similar. It's just our medical home service team, we recruited slightly older patients. And their education level slightly lower. And from the clinical frailty scores, the CFS, we can see our medical home services actually have more patients in failed status. But the accuracy are the same, and the Charlson Comorbidity Index are the same. So as an outcome, if we look at the clinical outcome, one of it is 90 days post-discharge readmission rate. So there's no difference, almost the same for both groups. So our medical service able to deliver the same kind of clinical quality to our patients. If you look at mortality, also largely similar, no significant difference. And if you look at the length of stay, actually our medical service is significantly shorter, at least 1 day short than these traditional, conventional admission cases. If you look at the quality of life indicator, EQ5D, for example, both groups are similar at either admission, discharge, and the 90 days post-discharge stages. So again, it proves the medical services are able to deliver same level of quality of service. Now let's move on to look at the cost. Yeah, our medical service cost was calculated by the itemized cost, including medication, consultation, visits, even operational costs, travel to patients' homes, phone calls, 24-hour hotline, everything included is still much cheaper than the conventional care in the hospital. Then we look at the 90 days post-discharge. So the cost after 90 days discharge, including the return to ED, some of them may have follow-up with a special clinic, but the cost is similar, there's no significant difference. So combine these two, from the index admission to 90 days post-discharge, the total cost, the medical services is much, much cheaper than the conventional care. Hence, we did a cost-effective analysis. So we look at the incremental cost, compare these two types of services, incremental quality. So the conclusion is, the medical home services able to deliver a net monetary benefit is 7,000 Singapore dollars. Yeah, so it's more cost effective and more benefit from the cost savings. Beyond the cost and the clinical outcomes, we also look at the patient's functional outcome. For example, we're using the modified Bartter index. So medical home also able to deliver same functional improvement from the admission to 90 days post-discharge, similar as our traditional hospitalization care. Another side, if you look at the caregiver's burden measured by Zari's burden, we can see the caregiver of those patients admitted to medical home is much less stressed than the caregiver for those of the patients admitted to the hospital. Yeah, so we were wondering why. So if you look at the experience, so both patients and the caregivers in the medical home, report a very positive experience with the care team. They feel they are more engaged and empowered. Yeah, so this is probably because explain why they feel they have the less burden of the care, caring their patients, caring their loved ones, because they feel the medical service team are always available, accessible. So they get supported and they also get involved, educated of providing basic care to their loved ones at home. Yeah, so they are less stressed. unlike the caregivers, of the patients admit the hospital, after discharge, they feel they less support. Nobody look after the patient anymore. Yeah, but medical home, because they constantly educated, demonstrate how to provide basic care, they feel they're more confident to continue the caring of the patients in the long term. So more sustainability, better sustainability of the outcomes in the longer term. Okay, in summary, our medical home is able to deliver comparable clinical and functional outcome as the conventional care in the hospital. And beyond that, both patients and the caregivers actually give us very positive feedback in terms of the experience. So if you look at the cost effective, yeah, it's definitely a preferred strategy. It delivered better quality and lower cost. So that's why we recommend these services to be rolled out. So currently our hospital has extended these services to reach we have about 30 medical home beds so far. Then we are going to roll out a larger size as well. So this is also adapted at the national level. So Singapore's all the general hospitals also started this initiative, and it's constantly, evaluated by the Ministry of Health. Yeah, that's all from my presentation today. Thanks for your attention.
Thank you. So if you can just stay there for a moment, we have some time for quick questions. So this is going to be interesting logistically. If you're in the middle of a row, you're going to have some gymnastics to do to get out to one of these microphones. But any hands up? Anybody got any questions for Dr. Hu? No, I'm not. Yes, thank you. Have a quick run up to the mic as you're going. Thank you.
Thanks so much for your presentation. I'm just wondering, you mentioned a lot of the outcome scales that you were using. What did you use for the patient experience measure? Was it a validated tool or was it something you developed?
We adapted from the patient experience survey. So we just shortened the questionnaire, but it's adapted from a standardized to validate the tool.
Yeah, do you know which one it was?
Maybe I can share with you the details
Sure.
later. Yeah, because it's a shortened version for our national patient experience survey, which is conducted by the ministry, ongoing every year.
Okay,
Yeah.
thank you so much.
No problem.
Great, thank you. Any other hands up there? Yes, thank you.
Yes, I'm already here. Thanks for the presentation, very interesting. If I'm correct, you measured the stress level of the caregivers. Yes. And also how happy the patients are. Did you also measure how happy the family was?
Yes.
Because, and I didn't see that one,
sorry.
maybe.
Yeah. So we measured the experience. We have quantitative data, measure the experience of the patients and the caregiver. We also conducted, I forgot to mention just now, we also conduct a qualitative IDI with the caregivers. So ask about the detail of their feedbacks of the services. Yeah, majority they give us very positive feedback compared with the hospital, traditional hospitalization care caregivers and the patients.
Okay, thanks.
No problem.
Great, thank you. So we've got time for one more. Could you just introduce yourself as well, thanks, just so we know where you're from. Thank you.
Hi, Alison Eyre from Ottawa, Canada. I work a lot with frail elderly in the community. And my question is, and forgive me if I missed the beginning, we had troubles figuring out how to get into the room. Does this program help people to reintegrate back into the community services so that the concept of the needs they have can continue at the community level? Because I think one of the issues we have sometimes in Canada is that we don't necessarily seamlessly coordinate between the hospital and the community, whereas 90% of patient care actually happens in the community, and that's actually where that should be transferred to. So I wondered how you do that so that you can have sustainable long-term support, hopefully keeping them out of hospital.
Yeah, that's a great question. Yeah, actually, because my institution is not just an acute hospital, we also have a strong community care team. So some of the patients actually are referred by the community nursing team. They have a longer-term relationship with the patients either after discharge from a surgery unit. So they have long-term chronic disease management issues. So our community team actually go home visits with the patients regularly. If they identify the patients with acute escalation of the care needs, they will refer to the medical services. Then we deliver the acute care to their home. After that, after we discharge the patient, maybe after 5-6 days, we return the patient back to the community nursing team. They will continue the maintenance of the care. Yeah, that's how we integrate this transformation from home to community.
Great. Thank you very much, Doctor. That was really insightful. I think we're always incredibly impressed by our colleagues from Singapore. So thank you for sharing that. Okay, so next up we have Luis Claro, who's going to tell us about Complex Wounds Unit in the Portuguese National Health Service. So from the hospital to community. So over to you, Luis.
Okay, thank you very much. Good afternoon, everyone. The Portuguese lunch was good for you? Don't sleep, okay? So, as Donna told you, I'm Luis, a nurse from Coimbra. That's a city between Oporto and Lisbon. And obviously, it's a great honor for me playing at home and to share with you our project. So, I will try to explain how we came about, some of the results we've achieved, how we intend to expand our response in healthcare, and how we are today, and what we want for tomorrow. Well, as you can see, the Portuguese map, Coimbra is right about in the middle, represented by these 6 colors. And since 2024, Portugal, just for you to know, has adopted a unified model of healthcare delivery through local health units, bringing together hospitals and primary care into 39 integrated structures across our country. Let me remember you that Portugal has a beverage model of healthcare funding, okay? So the users are free for paying. And I tell you this because in 2023, before the creation of our local health unit in Coimbra, 3 nurses with the support of the board of directors of the smallest hospital in the Portuguese national health system, call it Hospital-atHome João Crisóstomo, that small thing little there, in Cantanhete, it's a city nearby Coimbra, founded the Complex Wound Care Unit. And to this end, they all underwent differentiated training in the area of wound healing, and they had the necessary skills to be able to provide health care based on the most recent guidelines in this field. So the first shot was fired and the complex wound care consultation was established. At that time, it was deemed essential to adopt an holistic approach to the patient rather than focusing solely on the wound itself. And therefore, the consultation was integrated into the internal medicine department. Many of our patients present complex wounds precisely due to their physical weakness and related, obviously, with multiple associated comorbidities like hypertension, diabetes, heart failure, among others. And obviously, when necessary, in our team we had the support of the nutritionist, psychologist, dermatologist, orthopedist, or sometimes, or many times, I can say, with a social worker. So, in order to encourage referrals of the patients, because we're in the start, we need to get them from the primary healthcare and third sector institutions. To do that, the unit's nursing team conducted multiple on-site visits to introduce themselves and present the new established service. Well, the feedback received from all these locations were extremely positive, with many of those expressing that this initiative will provide significant support for long-standing patient cases. Indeed, there are individuals who have been living with chronic wounds for over 40 years, not 5, not 2 months, 40 years, and receiving continuous treatment in the community. Here you can see some different things that could probably think that could be applied just in hospitals, but it's possible in healthcare. And I talk about platelet-rich plasma-based regenerative therapy, negative pressure wound therapy in many countries already. It's happening in the community primary care centers. We use, since the beginning, artificial intelligence to calculate the size and different types of tissues on the wound bed. We need to have in our care units big displays to show the patient how the wound is healing, and you know this is important for the engagement as well. And we have several disposals to evaluate or to access the vascular situation, because we need safety to provide the best therapy for them. Okay. So I have here some data. What I can emphasize here is the origin of our patient. They came mostly from the primary healthcare, 76%. And here are some data about the costs. Okay, it's known that in average a dress changing costs 11 euros. We can do it for less than 10. The discharge time in our patients, it's in average 7 weeks. That's very good. They talk about, in the literature, about 10, 12 weeks. And we can reduce the transportation of our patients to 1 or 2 treatments per week, each patient. What I have here in these 2 graphics, the left one, is that you can see, because it's an outpatient basis solution, most of our patients have venous leg ulcer. Obviously, we know if it was home care or home treatments, we sure have more pressure ulcers inside there. Our discharge rate is following the pattern, 65%. And I think better than words are pictures, right? And wound healing is not different. So here you can see not just the coin, but a beautiful foot of a young lady with a diabetic foot. So if you see this, nothing serious is happening. But if you imagine this, and I don't want to shock you with the other image, for some weeks before, it was this, okay? So now I think you can perceive the smell, the pain, the quality of life of this patient, not just for her, but family as well, right? And this not so young man with his right leg with the wound almost healed, but for some months before, he was in this state, okay? Bones, tendinosis, exposure. So I think today he's in good shape. Always keep caring, just to do the follow-up consultation, but he's healed, okay? So what about the expansion strategy for our units? Well, in the beginning of 2024, we submitted an application to our local health unit in Coimbra for the expansion of our unit located in Cantanhede, and we won. So in that time, we thought, okay, can we do or stand with an operating theater in primary care? That's for nothing, right? But complex wound units in this field, in this setting, it's possible. Obviously, we expect some benefits with this, with shorter healing times, improvement of the quality of life of either patients and families, saving costs mainly in transportation, and I'll show in the next map the different locations we are going to be. Out-of-pocket savings, because even if it's free for users, there are some dressing changes that they are expensive. We don't have it in our national health system. And obviously, you put more time for primary care teams to develop other type of care, and we need prevention as well. Reduce it, waiting time for patient to to have a differentiated appointment. Sometimes takes a lot to see for the first time this type of situations. And obviously with this quick referral, we minimize the harm for the patient and the family. And obviously with this location from the hospital to primary care, we will coordinate and we are coordinating our efforts to make it more easier for the patient. That's our focus, right? So, as I told you before, our unit is there, above, on the left side, Cantanhede, next to the sea, not so near, unfortunately. But we expect to have 4 more units spread along our 6 little community, health communities in the local health of Coimbra. So, everything is beautiful, more or less. Not everything is beautiful, because obviously we have in our implementation steps many challenges. Beginning for choosing the locations is not so difficult like it can be, but equipment acquisition, staff selection, referral coordination meetings, make at the same level clinical record systems. Well, that's hard to deal because obviously we are talking in 2023 about different type of care and different kind of systems. Okay, now we are reunited at the same. So the future, we could probably say that after our first unit, the second could come for the end of this year, but no, I think more or less than 1-2 weeks it will occur. Okay, so our second unit is almost finished, so we are prepared to open it. Okay. So because we are so far from Coimbra, we cannot go there, but I can bring them here. Okay, so let's see a small video.
A elevada prevalência de feridas complexas é um grave problema de saúde pública e gera custos significativos para os utentes, famílias e sociedade. Um tratamento eficaz exige uma equipa multidisciplinar diferenciada e integração comunitária. Sejam muito bem-vindos à Unidade de Tratamento de Feridas Complexas do Hospital de Cantanhede, agora integrado na Unidade Local de Saúde de Coimbra.
Queremos agradecer a oportunidade que nos dão para apresentar o projeto desta resposta multidisciplinar do Serviço Nacional de Saúde. Começamos por vos dar conta de que a OMS, já em 2008, considerava as feridas e toda a sua problemática como uma epidemia e com uma prevalência estimada entre 1 a 2% da população dos países desenvolvidos. É ainda conhecido que cerca de 70% destes casos estão inseridos na comunidade.
Desta forma, face à inexistência de respostas integradas e diferenciadas no Serviço Nacional de Saúde, 4 enfermeiros com competência especializada nesta disciplina e com o apoio do Conselho Diretivo do Hospital de Cantanhede, fundaram, em 2023, a Unidade de Tratamento de Pessoas com Feridas Complexas. Atualmente, no contexto da ULS de Coimbra, é um facto que temos uma população mais envelhecida e bastante dispersa também. Desta forma, a acessibilidade aos serviços de saúde mais diferenciados torna-se ainda um obstáculo difícil de contornar. Hoje, temos a oportunidade para prestar cuidados altamente diferenciados na comunidade e, desta forma, ajudando a evoluir este novo modelo integrado do SNS.
A referenciação dos utentes com lesões de difícil cicatrização, ou seja, com evolução superior a 10 semanas, é realizada tanto pelos cuidados de saúde primários, através do registro de saúde eletrónico, como pelas instituições do terceiro setor. No final de 2023, atingimos a capacidade máxima instalada. Relativamente à tipologia de feridas complexas que acompanhamos em ambulatório, destacamos os utentes com úlceras de perna de etiologia venosa. Se em 2023 a maioria dos utentes eram referenciados pelo Centro de Saúde da área de abrangência do Hospital de Cantanhede, em 2024 essa realidade diversificou, com destaque para a agregação de utentes de concelhos mais distantes. Com a criação da ULS de Coimbra surge a oportunidade para a expansão deste projeto a toda a região, melhorando a acessibilidade e reduzindo não só tempos de espera, mas também os custos associados. Estamos a adaptar a carteira de serviços à realidade demográfica com a continuidade de cuidados centrada no utente.
A interdisciplinaridade permite avaliar e tratar outras comorbilidades. Conseguimos também criar vias verdes para referenciações mais diferenciadas. Utilizamos o conhecimento diferenciado e as tecnologias mais avançadas para diminuirmos o tempo de cicatrização. Desta forma, estamos a realizar um acompanhamento contínuo, promotor da adesão ao regime terapêutico, que se traduz na melhoria dos resultados e, consequentemente, nos níveis de satisfação dos utentes. A nossa casa é a vossa casa. Venham visitar-nos.
Thank you.
Thank you, Liz, and I'm so glad we had time to show that because it's really great to see the real, life service, so really impressive. We have time for a couple of questions. Anybody like to ask Louise a question? No? Any hands up? No, not right now. I have one for you, but I'm trying to decide if I say it now or if I save it for the end. No, I'll ask you it now, actually, just to kick off. So incredibly impressive results around cost efficiencies, and there is no doubt in my mind, having listened to you and seen the video, that having that level of expertise in wound care under one roof in the community is incredibly valuable. People are getting the best quality care, it's quite evident. But what about creating the business case for that expansion that you described? How difficult has that been to provide the compelling business case to go at scale?
Yeah, thank you for the question. Well, this solution was we thought about this solution in 2023 before realizing we will get local health units with this integration. And wow, it was so amazing to see that we have the government response for what we are thinking about the wound cares. So, right away, I know there are a lot of more units solely in different other health care units, but this type of answer going to the field in different locations, but continuously leading with the networking, this doesn't occur so frequently. We know the guidelines told us that this type of care is so needed and it's so precious in the community, but why until now does anyone do like this? I don't know who has more or who has this type of solutions here in Portugal. Neither, I think, other countries. I don't know. It's a good stage here to ask you if you have this type of answers in your countries. Yeah.
I think, certainly I suspect that the data around costs for wound care is probably so dispersed across the system that it's quite difficult to actually have a true picture. Mm-hmm. Anyway, thank you very much for that, Lewis. Thank you for sharing that. We really appreciate it. Thank you. Okay, so we're now going to go up to our last presentation for this session, which is going to be a double header, really. Do you want to go up together? Or are you going one after each other? Yeah, great. Okay. So can I just introduce to you, ladies first, shall we go? Yeah. So we're going for Dr. Michelle Grimmen, who is going to, with her colleague, Dr. Gazwan Altabas, I hope I've pronounced that well, and they're going to tell us about their Hospital-at-Home service in Calgary, Canada. So an opportunity for real-world care planning and integration. So can't wait to hear about it. So please take the floor. Thank you.
Okay. Hello, everyone. Thank you for your invitation to this meeting to present our experience with the Hospital-at-Home program. We don't have any conflicts of interest. And this presentation is going to include visiting again the concept of Hospital-at-Home program and also discussing with you some of the known facts about Hospital-at-Home program from the literature. And at the end, sharing with you our experience with the deployment of this program in Calgary, Alberta, and Canada. So the operational definition of hospital program that we adhere to and follow, we see Hospital-at-Home program as an acute healthcare model that offers comprehensive care for a selected group of patients that includes diagnostic therapeutics 24/7 in a time-limited manner. That means the patient who would have been in a hospital actually is at home receiving the care they need and receiving diagnostics they require, and some therapeutics that include also IV treatments. It's 24/7 service, it's time-limited, it includes acute situations. That means the patient still has ongoing requirement for service. What also helps here just to, not to define, also to be clear what is not Hospital-at-Home program. For example, Hospital-at-Home program is not an outpatient practice, it's not a primary care practice, it's not a prevention program, it's not chronic disease management program. And that helps all practitioners to narrow their focus on what they're really doing and not doing. The literature over the last 2 decades indicate that it's not a new healthcare model, but it has shown over and over again, whether a randomized controlled trial, systematic reviews, or meta-analysis, that it offers a lot of benefits. On the left side here, we can look at the patient aspect, which is patient-related outcomes. Patients who are at the Hospital-at-Home program, when they're compared to being in a hospital, they have less of a chance to have adverse events. There's less morbidity. They live longer. There's decreased mortality. Actually, number need to treat is 1 to 50. What's really also striking, when you look at the delirium, as instead of delirium goes down by 75% when the patient really is at home compared to being in a hospital. Also very important, the functional decline. There's less of a chance of functional decline when the patient is at home, and that really means less of a chance of them going to a long-term facility. This is where it goes to the quality of care. When we look at the patient satisfaction, common sense, patients really like to be at home, and that really shows over and over again with their patient satisfaction and their caregiver. This is from the patient side. Now, from a system level, we look at the cost. There's less cost, knowing that it's going to have less number of days in the hospital, less of a chance to be readmitted to a hospital, and less of unnecessary tests. The program we deployed in Calgary, Alberta, in Canada, Dr. Greenman initially deployed the program year 2018, and over time it has developed and added layers and layers of support, and we have a rebranding from what we used to call Complex Care Hub to Virtual Home Hospital. The way it operates, we have on the left side here the healthcare provider team, where you have a specialized physician, internal medicine, or the hospitalist. We have nursing staff, we have pharmacy, who work in a hospital setting and integrate with, of course, the patient who is really at home. And between us, we have the community paramedic who does the daily visits to check on the patient. The mode of communication between what we operate in the hospital, the walls, and the patients really at home, we have multiple channels of communication, including we have remote monitoring of their vital signs. We have the daily, or every other day, or every number of days, depending on the intensity of follow-up here, via video conferencing and electronic health records. Those patients admitted to Hospital-at-Home program in Calgary, just like we heard from our colleague in Singapore, we also have inclusion criteria, exclusion criteria to know who would be selected for this admission, where we can really provide this kind of care.
So the Complex Care Hub, some of the data that we'll present is from just before we rebranded. When initially we developed the Complex Care Hub, we have a lot of outpatient programs that provide actually wound care, IV antibiotics, home-based palliative care. But what we had was a gap in care for particularly vulnerable older adults. And so we aimed to take mostly vulnerable older adults initially, and we found within about the first 8 months that we were really struggling to discharge patients from our hospital at home because we would get into their home, find out all the reasons, all their barriers, all the reasons why they keep coming back to hospital, and we would find ourselves doing intensive case management for quite a long time. And we had planned for this, but it was even more than what we thought. So just to give you an idea, our nurse navigators are also what we call transition services nurses, so they can order home care, they can do all this kind of integration. But this, so this program, what we ended up doing is having an acute and a subacute arm. And I'll explain that in a minute. So first we take, most of our patients come from our inpatient wards. Usually that's our general internal medicine wards, sometimes from the family medicine hospitalist, sometimes from some of the other internal medicine specialties. So about 3/4 come from there. And then the other quarter comes from what we call admission avoidance. So these are people who either come to the emergency room and we divert them and put them on our hospital at home. So we admit them to the hospital at home and they never set foot on an inpatient ward in the brick and mortar hospital. Or we actually take referrals from the community and again divert them from ever setting foot in the hospital. So this is in the first couple of years. We did almost 9,000 acute care days, and we see these as days in which we're actually replacing in-hospital care, so in the brick and mortar. And then, you know, we had a range of ages from 19 to 101 for our patients, with the majority of the patients being over 65. And so what we then differentiated was, you know, if you're a less complex patient and you don't really need as much intensive case management, then we send you back to sort of your health home, your primary care health home. But if you need more intensive case management or you have something that primary care cannot provide, then you get put onto the subacute arm. And so we provided about almost 2,500 subacute care days. So during the pandemic, we wanted to know how we fit into that. So you have to remember that we started this in 2018 in one site, then we spread to a second site in 2019. And during the pandemic, we asked our patients, we wanted to know where we fit into the healthcare system because we saw ourselves, the reason we called it a hub initially, is that we saw ourselves as the bridge between acute and community. And so you can see that most of them would have stayed in hospital, some of them wouldn't even have sought care, or they would have gone to these sort of, with the exception of primary care, they would have started looking for alternatives to their care. And one patient said, well, if I hadn't had the complex care hub, I would have just died. We used the patient experience survey that our health jurisdiction uses. We didn't ask all the questions because they're not that pertinent to hospital at home, but we picked the ones that we thought were the most pertinent from, at the time it was the HCAHPS. And we also asked some questions about technology and that kind of thing when we implemented technology. But you can see here, so the majority of the patients felt that, so the blue is the responses we got before the pandemic, and then the yellow is after. We had some changes in methodology, so I couldn't amalgamate them. But you can see most patients feel that they understand their medications, they understand their conditions, and that we address their anxieties and fears. And like I said, that's because you're in their home, you're meeting their family, you're looking what's in their fridge, you know, you're meeting their cat and their dog and all the things that are happening in their life. In terms of health-related quality of life, we were initially going to randomize, but we weren't able to randomize because our healthcare system just asked us to just do this. Like, they didn't want us to not divert half of the patients. So you can see the EQ5D here. In all the domains, essentially, the patients from when they were admitted to when they were discharged and then 30 days after had an improvement in all of the domains of the EQ5D. In terms of questions that we asked them from the survey, 98% would have recommended it to their friends, 97% were either satisfied or very satisfied, and the one that I'm particularly happy about, given that this is a frail, elderly, complicated population, is that they felt that we treated them with dignity and respect. 100% of them said that. 94% of them included in their care, and 80% of them prepared to manage their conditions. We did want to understand how this impacts the healthcare system. And as I said, we didn't have a control group prospectively initially. So we've gone back. We're in the process actually of adding on another 3 years of data. But the first 2 years of data, we were able to take 241 complex care hub patients and then matched them to 138 controls. And so you see here the trajectory. So this is the trajectory on complex care hub, where they come on, they spend some time in the complex care hub. They may actually float between the two, between brick and mortar and hospital at home. We had like 11 different patient trajectories. And then there's a period of outpatient care. And because of this complexity, we actually measured their healthcare utilization out to 180 days from the day of admission to hospital, not to the program, but for their index admission. And then the controls, as you can see, come in, they spend some time in the brick and mortar, and then they have their outpatient care. And all of this represents either a control or a complex care hub index admission. So as you might remember, I talked about a quarter of the patients were admission avoidance, meaning they came from community or emerge, and then the other were early facilitated transfer. Sorry, that's meant to say transfer, not discharge. So what we saw in the admission avoidance is that our length of stay was as long as the hospital, the same, basically. So we did the same amount of acute care days as they would have if they'd been in hospital. And this is with propensity match scores controls. For the early facilitated transfer, so these were patients who had been in hospital for quite a long time, were very, very complex. They had nowhere else to land in the healthcare system. And we spent a long time sorting out what they needed and why they had so many readmissions. So for the admission avoidance, the cost was 35% lower in the index admission and then 13% lower at 180 days, so in that 6-month period, with an overall reduction in cost of 22%. For the early facilitated transfer, so these really complex patients, their index admission was a little bit more expensive, actually, like 78% higher, but at 6 months, they dropped their utilization of healthcare, of acute care by 65%, and so they ended up being cost neutral to the system. But the other thing that you can imagine is that this doesn't represent what it would cost to build a new ward, right? Like the actual brick and mortar ward. It also doesn't take into account how many times you can flip over a hospital bed when you have patients on your service for quite a while and you're sorting out all their issues. So overall, we thought this was positive, but this was also at a time when the program wasn't mature. So we're hoping that the next 3 years will help us understand really what the economic impact is on the system, and particularly around the time of the pandemic. So this is sort of coming to the end of our slides here. As I mentioned before, when I first built the complex care hub, my thought was that the hospital at home was a part of a bigger integrated healthcare delivery system, and that it would touch upon the health home as needed, so support primary care when patients needed something that was a little bit beyond the scope of primary care, and also to step down from acute care and enable us to provide care outside of brick and mortar. And I think what we've learned the most is that this model allows us to do really intensive case management, really good complex care planning while we're treating people's acute care issues. We can then figure out what they need, like from a real life care plan, not just we're both internists, so the internal medicine piece, but also incorporating an actual care plan that patients can actually follow. And so aside from the impacts that we think they have on patients, we also think that this model has a potential to support healthcare system sustainability and improve the quality of life for our patients. And we just want to thank the multitude of people that were involved in helping us to launch this program, evaluate the program, research on the program. So Gazwan and I Gazwan currently leads at the hospital that we both work at, and I am now leading the Canadian Hospital-at-Home Working Group. So that's it. Great.
Thank you both very much. Again, really, really impressive service and results outlined there. Okay, so before I ask Michelle and Gazwan to come back here for a little bit of chat, anybody got any questions that they would like to direct to them? You just want to come up to the mic if you do. No, I don't see any. Okay, so if you just want to come back and we'll have a little chat. Great, thank you. So, just reflecting on the three very different approaches that we've heard. For me, you know, this concept of evidence, because let's face it, when we're talking about health and care delivery right now, and cost efficiencies, cost effectiveness, creating that business case for services and service models is incredibly important. And that's got to be based not only on cost effectiveness, but also the quality of care and, you know, the patient experience. And we've heard from all three, you know, scenarios that you've done a lot of work in that space, particularly your service, I think over 20 years of data. I mean, that's incredibly impressive. But for me, why is thank you. Why do you think it is that we're still not seeing these models of care being routinely used to keep people out of hospital? You know, we're seeing pockets of excellent practice, yours included. Why are we not seeing this just as a standard model of care? Why do you think that is? So I'll just...
Maybe I can take it from the point of view of training, because we talk about that sometimes, like our trainees, medical students, and residents, when they go specialization, they all the time go into the standard traditional training options where you have to go to the hospital, see your patients there, give them prescription, send them home to their family doctor. To have this hospital-at-home program as a model which more available, I think should go back to the basics, where more of our trainees get to see and do some electives at the minimum, get to see the value, get to see the benefits, see their patients leaving the hospital, taking care of them at home, which is actually a different type of skill. It took me a number of years I'm trained traditional, see your patient in the hospital, send them home to their family doctor and hope for the best. It took me a while to wrap my head around it and feel comfortable my patient is really sleeping in their home and I'm here. I don't get to talk to them. I can talk to them, but I have to call them, it's a phone call. If something happens, I'm worried. So it takes a bit of time. It takes that curve of learning. So I would say training is one of major impact.
And from the way that you describe that training needs to be, as you say, actually experiential training, not just being told this is a model that works, actually doing it, seeing it, using it.
Yeah, it's becoming more of the people who are enthusiastic about it, who likes it, who believes in it, and they go and sign up for that rotation. They sign up to put me on the schedule to work there. People who haven't been there, they could be scared of it. They could be just like, how do I take care of this patient if the patient's really at home? What if something happens? Do I trust that community paramedic who's going to give me the report when I have never worked with a community paramedic before? So it takes that kind of time to train and get people ready, and more of them to get involved in it. This is from a training point of view.
Thank you, thank you. Michelle, anything to add on that? I mean, you touched a little bit there on clinical governance, which is always seen as a significant challenge. You know, that who has responsibility if the patient is at home? Is it me in the hospital? Is it a clinician? Is it the community? I mean, any thoughts on that?
Yeah, I mean, I agree with Gazwan. I think from a practitioner perspective, I think there's a cultural issue that we've been trained to centralize everybody in the hospital. We feel safer there as practitioners. We think we're doing the best for patients, when really, when you look at the literature, we're actually causing harm, especially for vulnerable older adults. And so when I was first trying to convince people about this program, like I had to knock on like 200 doors and convince them that this was actually going to be as safe or safer, and I'm still doing that, and it's been 7 years. But I think there's also a system issue, and I think it's that we don't have the funding for it. So particularly in Canada, there's a lot of questions around how to remunerate the physicians to be able to do this work, because there isn't a great model for that. We don't have, some jurisdictions are able to fund, Hospital-at-Home has a pretty large upfront investment at the beginning. And then it gives you lots of rewards over the subsequent 20 years. Even within the first year or two, some of the leaders in Hospital-at-Home from Australia cite a 20% reduction in cost, but you don't see it until you invest in it. And that upfront investment, and if you don't invest properly, I think is really kind of scary to health policy decision makers.
That's a really good point, because I was impressed by your the cost effectiveness, or rather the costs analysis that you did of the two different types of service. And certainly in Scotland, we were a few years ago saying rapid hospital discharge, fast, 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 that's the answer. But actually the level of period of support was very short. And I saw that yours was twice as long, something like that. It was significantly longer, which cost more at that point, but then the cost efficiencies later on in the service through reduction in admissions was incredibly, it was very compelling, cost neutral at the end. And I think that's one of the big challenges we have in persuasion, persuading people to invest at the start.
Well, the thing is that the way we've been trained to think about efficiency is do it quickly, right? And upfront, make it less expensive upfront. But with these, especially the really hyper-complex patients, that little bit of extra time that you invest in figuring out the root causes of why they keep coming back, why they're not able to follow a care plan and all those things, they pay off, but you have to have the time to watch it pay off. And for them, I think it pays off in terms of their quality of life. Like, I think, there is no service that I work on, like the Hospital-atHome, where I get hugged and patients cry when I try to discharge them. Like, they don't want to be discharged. And I think, like, to me, that's like, it's a little bit difficult sometimes, but,
Don't want to let go. So, Louise, you should get the prize for having the most awful slides straight after lunch. Because, there were a couple of, real shockers in there. Thank you for that. That really helped us digest our dinner as well. Anyway, your service is incredibly impressive. As I said, the video was really good because it really literally brought it home. But I can imagine just thinking about what we've just spoken about, for you to go and say, I want to set up this really specialist service, that could not have been easy to get, the funding for that. Any thoughts on how you managed to persuade them, apart from the awful pictures?
I've just shown our board of directors that they could save about 20 million euros per each year if we can establish the full complex wound care units. And
so
it's not hard to
the euros
exactly.
persuaded them.
Yeah, it's a lot because we have 1 billion of budget in our local health unit, one of the biggest in Portugal. And I want to mention as well that the mindset of Portugal medical hubs is changing, but for that vision, for the integrated care models. But I think that's the main problem here in Portugal. As you can see, we are in the beginning. We start this for the beginning of 2024. But I think among our country, the answers will be effective, like us.
Yeah, well, I think we're all very interested in your business case, there's no doubt. And Dr. Hui, last words to you. So your patient and carer satisfaction rates were so great. I mean, very, very impressive. The whole concept, as far as I am aware anyway, in Singapore, of this concept of community-based, care is very well established. So what for you is, was the main kind of lesson learned in terms of your service and how you would like to see that scaled out in Singapore?
Yeah, thanks for the question. Yeah, so our patients, identify, refer to the services, some of them already in the community care services programs. So the relationship already established. That's why I think that's part of the reason the satisfaction, the good experience score is so high, because they are coming from the same team, continue the care when they escalate to the acute care. So it's kind of same team, deliver a more acute care to them. After that, return back to the same team. So they feel it's a continuity of the care. So just want to add on the question, as now our Canadian colleagues have shared, why this service is not so far mainstreamed. Yeah, that is our hope in the future. So part of another culture, maybe from the caregiver and the family's aspect. So because this service do need a caregiver support at home, maybe stronger than those admitted to the hospital. So the caregivers just visit their families once a day. But yeah, in order to deliver the safety and high quality of home care at home, the caregiver support is really a main, component. So that's one from the patients and the family's perspective. Some of them actually reject the services because the culture, the availability of caregiver is one of the problem. Yeah. And we do want to roll out this, now it's actually adapted at the national level. So all the public hospitals already have these services. And I think that it's definitely cost effective for the payers at the ministry level, definitely cheaper and comparable outcomes than building new hospitals. Yeah, but our service delivery, for example, the clinicians, they still need more evidence to convince them. Deliver the services is cost effective compared with, they can see the patient one walk around, they can see 15, 20 patients a day. But when they visit the patients at their home, they can see maybe 5 patients a day only. Yeah. So they still wondering, is it really cost effective and efficiency? Need more evidence to approve that.
Which brings us very nicely back to your original point. Anyway, I think that's us run out of time. I'm sure we could have talked for much longer, but I'd just like to thank you all for your insights and sharing your learning so far today. So thank you all very much, and thank you for your attention and your input. Thank you, everyone.
to take a place, if possible, a bit closer, if not, okay. I learned for integrated care that proximity is very important, but maybe it's not the case for a workshop. Welcome to everyone. Welcome also for the people who are looking at the streamed, at the streaming, at home, at office. We have 3 presentations. We have 1 hour. It gives some room also for questions, etc. And so we are having first the 3 presentations consecutively, and I invite Mark Reis to come to the floor and give us the first presentation. Mark, you have the floor.
Thank you. Okay. So today I'm going to be talking to you about a collaborative innovation that we applied in our trauma care clinic, and talk a little bit about how that came about, what the impact has been, and what are the future opportunities. This is, I'm from Ontario Shores, and this is a collaboration between our hospital, which I'll tell you a little bit about, and a small non-for-profit community organization called Catholic Family Services of Durham Region, which is where we are situated. My colleague couldn't be here today, Sarah Kipping, but she had a great hand in leading this project. Myself, I'm an administrative director at Ontario Shores. I work in our adolescent program, our integrated health services, and also lead this particular initiative. Ontario Shores is a large psychiatric hospital. We have 346 beds, and it's in Ontario, Canada, just about 20 minutes east of Toronto. You may know that city. And we provide mental health services both inpatient and in outpatient services. And this particular project was in one of our outpatient clinics. Catholic Family Services, I said, is a not-for-profit organization that reside in a smaller area within our large eastern region, and it's called Durham. They provide trauma-informed care, child and family therapy, and culturally responsive services. So they're much smaller, but much more in expertise in delivering community-based care. So a little bit of background and rationale. What the burning platform for us, if you will, was accessibility. Is that for our trauma clinic, we had and continue to experience long wait lists for service, huge demand on our services, and we really didn't have a lack of any more resources to put in to scale up a traditional kind of service delivery model. So we needed to do something different. We needed to find a different way to provide service. Geographically, our region is quite vast, so access to service was also something we looked at around different service delivery models. So virtual care, which I'll talk more about, was a component of one of the things that we kind of integrated into this approach. And we really, I think, have a shared population between Ontario Shores and Catholic Family Services. We are both heavily invested in treating this particular population. We just needed to figure out how to do it better together. So the model that we chose to implement in this particular program was, we call it stepped care, which is really looking at 2 different tiers of care. What we found was that because we're associated, our clinic is associated with a highly specialized hospital, a lot of people want to be referred there. They want to see a psychiatrist, they want to see a psychologist, they want to get high intensive support and high intensive care. Well, we know that within the trauma population, there are people who require that for sure, but people who actually probably need maybe something more moderate or more mild in terms of service provision, and could do just as well from a clinical outcome perspective with that level of service. So we tried to stratify a high-intensity service and low-intensity service, and then looked at the cohort of individuals that were on our wait list for service and stratify that with who could be diverted to Catholic Family Services who had more capacity to provide this level of service, and those who still require that tertiary care, a level of trauma care. So that's how we decided to kind of subdivide the wait list. And what actually happened as we went through this was we started to recognize that another kind of a new wrinkle came through in terms of understanding the population, is that Catholic Family Services was really good at kind of big T trauma, kind of, specifically trauma, and people with more mild to moderate expressions of that PTSD. Whereas at Ontario Shores, we deal with people with require high service for trauma, but also had a lot of comorbidity. A lot of comorbidity in terms of that was impacting their functioning, impacting their care, and so we'll show you a little bit about some of the outcomes that we experienced. So that was how we decided to kind of subdivide that, our huge burgeoning wait list of individuals. We had a lot of expertise, we had a lot of infrastructure, and the community agency, while they're doing the best that they could with the funding they had, they just didn't have that. So that was a component where we were able to provide the training and education for their therapists, for their clinicians, to really support being able to deliver the kind of service that you would expect to have when you're accessing care. We actually divested 1.6 of an FTE into the program, so they hired their staff, they hired them. This is a 3-year project, by the way, on temporary contract, but that was their staff that they were able to use in the program with the funds that we were able to give them. So we were very much invested in this partnership at a budget level as well. From an evaluation perspective, obviously that was a really important key. We wanted to, and I think we have, developed a proof of concept that can be not only scaled up, but also applied with other patient populations. At Ontario Shores, we provide services from adolescents to geriatric care. So we wanted to look at, could this model be of value in other areas for us? So that was an important component to this. On the clinical outcome side, you might be familiar with these measures for trauma, the PCL, the PHQ-9, and the WSAS, which is our level of social functioning. So currently, over the first 2 years, we've got some preliminary data. We're entering our 3rd year with this pilot, which will have more fulsome data at the end. So on average, some of our key outcomes, we did see symptom reduction. So to us, this was the most important part of this evaluation is, are the patients that we're diverting over to the new service getting the kind of clinical care that they require, and are we seeing it objectively in improvement on the measures? The PHQ-9 and the WSAS scores showed significant functional improvements as well. Again, we're paying attention to the comorbidities. That was really a large chunk of the individuals that were on the wait list had to remain at Ontario Shores, but we were able to provide care faster to them because people were then moved to the other program. We had low attrition rates, so when clients came into the program, we had less than 10% dropped out. So we felt that people were staying in the program. That was a good sign. And then we had 77% high satisfaction scores across various domains. So we use a standardized patient satisfaction survey. It's called the OPOC, or the Ontario Perception of Care. So it's a validated tool. All hospitals use it in Ontario. So we're very proud of able to show that data as well. And then on the virtual side, we looked at individuals who previously would not have been able to access services because we were not providing trauma-based therapy in a virtual platform, but we were for this project, and we found, as you might expect, that 100% of individuals felt that was valuable for them. We also evaluated the partnership itself. Because we invested some resources into this, we needed to understand what is the return on investment, and is this something that has opportunity, as I said earlier, to be scaled up and to be more scaled up and also applied in other patient populations. The other thing we found, the last box on the right, is that the organization, Catholic Family Services, really benefited and valued the training and education consultation that we were able to provide to their team. They felt that it was allowing them to be able to have more confidence in dealing with clients that presented with more complexities, more comorbidity, although we were trying to kind of divert those back to Ontario Shores, but very much felt that was a great value. So moving forward, that was something we had to really consider, is how do we continue with that? I should mention too that as we went through, we met on a quarterly basis, both the administration side, which is my side, and our frontline clinicians, to really understand, look at the data. How are we doing with outcomes? How are we doing with attrition? What do the wait times look like? How are therapists feeling? Do we need more training? Do we need booster sessions? So there was this quarterly check-in all along the way so that we're able to quickly identify problems and where we could put in some QI work to see how to move forward with the initiative. So I think that was really important as well. We also evaluated our actual staff in terms of how they felt about the partnership, and we found 87.5% of the feedback that they felt it was beneficial, that they're better equipped to provide the care to the clients in a more timely manner, and that the Ontario Shores clients our staff felt that they're actually working with the population that they were hired to work with, those highly complex, a lot of comorbidities. So they were quite satisfied that that was the group that they wanted to work with, and that's what they were seeing in their practice. I mentioned about satisfaction. One of the things that we did find from feedback was communication could have been better and continues to be something that we want to strive to improve. Two pieces of that. One is when we're talking about moving clients into to one service or the other, obviously we're involving them in the discussion. We could have done that in a bit better of a way at the beginning in terms of how we made those decisions, how they were involved in making those decisions. So I think there's an opportunity for better co-design in how we communicate at the beginning up front around the expectations for the program. And then at the end, when clients were done, therapy was about 16 to 20 weeks-ish. It's kind of the range we found. How do we connect people in the community with community resources if they needed continued support, like case management resources and social support? So we could have done a better job there. And again, I mentioned we're going to be doing a full evaluation at the end of this year to see where we go from here. So policy implications and scale. I think this is scalable, the stepped care model. I think it's something that we certainly can see it growing. And from a funding perspective, what we want to do is provide a proof of concept to our government that this model is a better way to provide access to care. It's a better way of integrating hospital-based and with community in a very tangible, pragmatic way. You can actually see it, how it's working. And we have outcomes that show that there's certainly no reduced clinical outcomes in doing it this way. We can definitely leverage co-design and lived experience with our caregivers in the future. That was an area that I think that we needed to pay attention to. And then overall, I think that we really recognized that the expertise that our teams had and how that was really, really embraced by the community, and how do we continue to be of support in that area. That was something that came through very, very clear. That's it. Thank you.
Wait. Don't run away. Mark, thank you very much for this nice presentation. We are relaxed in time. You even didn't use the 50 minutes. Well done. Oh, this is awful to look into the room. I was wondering, I giving the opportunity to have questions asked. I was a bit wondering, so you have a before and you have after. You're showing results. You're talking about program, about pathway. What exactly made the difference? What was it that you want to scale up? If I can ask it like that. I don't know, maybe you should give a bit more detail on exactly how you got these results. Please.
Absolutely. So I think when I think about scaling up, it's really about providing the level of support to the community organization and how do we bring their capacity up in the community. Giving them the tools, the training, the education, the consultation. There was a lot of regular consultation we were providing for the clinicians so that they're able to serve clients in a much more optimized way. I think that's the opportunity for scale up. We can always do better on our side as well. Of course, there's always opportunity, but I think where we really saw it, looking at unique clients served, the attrition rate reducing of clients in the community group, and we're still getting the good clinical outcomes. So I think that was where the opportunity was.
But it came from, let's say, this collaboration between two organizations, and you were taking profit from the strengths from the one,
yes,
importing them to the other one, etc.
Yep.
Okay, thank you.
Well said.
Okay, questions? A bit like an Indian. No questions? Maybe they can come also at the end after the second one. Thank you so much, Mark.
Thank you.
For this nice story. And I would like to invite Vanya Martins. We are moving from Canada back to Portugal to present. So we are still in the mental care, I guess, huh? Yeah. Okay. Please.
Good afternoon. I'm Vanya. I'm a registered mental health nurse. I come from local health unit from Almada, Seychelles, just across the river. We are today two of us from Almada. Well, in Portugal, the treatment of individuals in psychiatric crisis still happens, mostly within the walls of hospitals. But what if there were another way? For over 2 decades, many countries have been managing acute psychiatric crisis through alternatives to traditional hospital admission in people's own homes. This model is referred to psychiatric home hospitalization and also known as crisis resolution and home treatment or intensive home treatment. In Portugal, this model does not yet exist. I'm here to introduce you to Home Engage, a PhD research project that aims to change that by involving those who matter the most, the stakeholders. Together, we're co-creating a more humane, effective, and integrated alternative. Well, let me see, I haven't tested this. Okay. Looking at how Portugal compares to other European countries, we have the highest burden of mental illness and a relatively low density of hospital beds. Given this context, we must follow the provision of comprehensive, integrated and responsive mental health services in community settings and explore the key benefits of community-based mental health care that is more accessible, better accepted, and institutional care, and plays an important role in preventing human rights violations and achieving better recovery outcomes. This model of care is embedded in a broader network of interconnected services that deliver mental health support beyond institutional settings. It highlights the urgent need to explore innovative and community-based alternatives for acute psychiatric care. Psychiatric home hospitalization represents not only a strategic and innovative proposal, but also a paradigm shift in mental health care in Portugal. When rethinking mental health care services, it is not enough to simply reduce hospitalizations. We must also actively design and implement viable alternatives to inpatient care, such as crisis residences, day hospitals, and psychiatric hospital-at-home programs, such as psychiatric home hospitalization. In mental health care service planning, it is essential to distinguish between preventing hospital admission and offering an alternative to it. This distinction is essential to uphold the principle of least intrusive interventions and to promote care in less restrictive settings. So, what does an effective alternative to hospitalization look like? Psychiatric home hospitalization offers compelling evidence across multiple dimensions. It is a promising response, offering high-intensity care that can prevent the need for hospital admission. It provides care in a familiar and supportive environment with advantages such as reducing coercive treatment, addressing trauma, diversifying treatment options, and promoting collaborative care. It has also been associated with reduced use of inpatient services, improved clinical outcomes, better care experiences, and lower costs. How widely can this model be applied in practice? Evidence suggests that a significant proportion of patients in acute psychiatric crisis could be safely and effectively managed through home-based care. As a fact, around 1/3 of patients in an acute phase can be directly admitted to psychiatric home hospitalization, and 40% of hospitalized individuals may be eligible for early discharge to this alternative. These teams may also act as a gatekeeper for psychiatric admission, assessing all referrals. When eligible for home treatment, hospital admission is then avoided. The Home Engage project aims to develop a psychiatric home hospitalization model tailored to individuals experiencing psychiatric crisis, contributing to its implementation within Portuguese mental health services. Additionally, it will contribute to a clear understanding of psychiatric home hospitalization models already implemented worldwide, as these vary in their strategies and often lack well-defined structures. To achieve these, we are now mapping existing recommendations and practices in international evidence through scoping review, after which we will describe the characteristics of service users and caregivers eligible for psychiatric home hospitalization in the mental health service, following the development of tailored guidelines validated by service users via focus groups and the integration of perspectives from key stakeholders using a Delphi study, ensuring a consensus-driven approach. We expect to develop a comprehensive and robust model adapted to the Portuguese context to be made available as an e-book and with essential components like eligibility criteria, team structure and organization, intervention, safety protocols, communication and coordination mechanisms among healthcare professionals, and also operational guidelines for implementation covering the entire process. In conclusion, Home Engage seeks to contribute to the creation of home hospitalization units in psychiatry, aiming to generate health value for users through a replicable model focused on the integration of care in the community context and centered on the needs of stakeholders. Much like Blueprint by Do Rousseau, where walls become transparent and spaces fluid, acute mental health care must move beyond the confinements of hospital walls. We must open that door, both literally and figuratively, to truly understand people's experiences in their own space. This project is part of the doctorate in Health and Wellbeing Sciences and Technology and co-founded by the Foundation for Science and Technology. Obrigada pela vossa atenção.
Obrigado. Nice presentation. You are short also. Yes. Room for questions, please. No, I start with one. I was, when listening to you, I was asking myself, but would there be one person in Portugal who is doubting about the approach you are developing?
Well, I believe no one is doubting about the effective and the quality of the improvement quality of care that you can deliver. But well, we are now transforming a big part of mental health services. And so maybe this project is a bit step forward, and he needs to to bring the research results and the experiences from other countries that have already implemented, and then take the time to make its proof of concept and future experience.
Coming from Belgium, I can confirm that this is an important step. Yes. So we also since more than 10 years in a move of closing down psychiatric beds, getting the people out, bringing them into the society, and then you need this. What is nice that you show the different aspects that need to be in place, both crisis, but also community support, etc. So from my point of view, I think this is a very important move you are making. Any questions, please? Move your arms, it's good for your health. No? Then, thank you so much. Thank you. Then we go on. And I would like to invite Professor Diana Varret to take the floor. Now we are going to talk about hospitals, I think, yes.
So, hello, my name is Diana, I'm a nurse teacher, and I'm also a PhD student. So I'm here today to present part of a research project focused on person-centered practice in hospital settings. Today I will talk about how combining the views of health professionals and other adults helps to reveal areas for improving person-centered practice. So we are facing an aging population with rising chronic illness and hospitalization rates. These patients are highly vulnerable during hospitalization, facing not only physical illnesses, but also emotional, cognitive, and social challenges. Person-centered practice emerged as a transformative approach that redefined the fundamental focus of care. It recognizes that people's experiences, values, and goals should define care decisions. When achieved, it improves satisfaction and can generate benefits to health and healthcare of all people, especially for those with complex care needs. The importance for creating person-centered healthcare services is widely recognized. However, implementing is not straightforward. Several barriers have been identified, and each country should define a strategy considering the health system, the care context, the healthcare professionals, and the service users. An understanding of the perception about care of the individuals involved in the therapeutical relationship may influence the advancement of person-centered practice in the clinical context. Accordingly, this study seeks to address the research question: how do the multidisciplinary team and the other adults perceive person-centered practice at an inpatient hospital unit? To address this question, we conduct a quantitative, descriptive, cross-sectional study to characterize, compare, and analyze the perceptions of both groups about person-centered practice. This study was approved by the Hospital Ethics Committee and followed the General Data Regulation and the Declaration of Helsinki. The study was conducted in an internal medicine unit with two different groups of participants, the multidisciplinary care team and the other adults with chronic illnesses. Person-centered practice inventories were applied. These inventories are based on the person-centered practice framework. They are both validated for the Portuguese population. They are different because they are applied in different groups, the service users and the teams, but they evaluate the same domain, the person-centered processes. These processes focus on key aspects of care delivery, including working with persons' beliefs and values, engaging authentically, sharing decision-making, being sympathetically present, and working holistically. Then the data was statistically analyzed with descriptive statistics, analysis of variance, and independent t-tests. Before exploring the perceptions, I will show you the demographic characteristics of our sample. So we had the healthcare professionals with 76% composing of all team composing our group. The majority were female, almost 80%. And regarding the profession, we have the bigger group of nurses, followed by physicians and physiotherapists. The group had, in average, 11 years of professional experience, and 37% of those professionals had postgraduate studies. Concerning other adults, the sample was composed by 192 persons, with 54% of females. In average, they had 75 years old and spent 7 days hospitalized. About school education, they globally had low educational levels. Our results about person-centered process domain show us that both groups rated positively person-centered processes, showing that person-centered practice is recognized in this setting. In the group of healthcare team, the professionals score slightly higher than older adults. When we see our results about the constructs that compose this process domain, we can see in detail how the different participants score the different constructs. We can see that overall, professionals rated more higher the constructs than patients, when some of them more proximate, or others more distant, but globally they scored higher. The only exception was only in the working on with persons' beliefs and values. This could say to us that older people recognize the team efforts to respect and align care with their personal beliefs and values. To understand how important are these differences about the scores, we conduct several statistical tests to show where are the biggest differences. So working holistically show the largest difference between groups, and this construct refers to connecting to the whole person through the integration of physiological, psychological, socio-cultural, and spiritual dimensions. Significant differences were also identified in engaging authentically. Both disparities may pointing us to a blind spot. Professionals may believe that they are addressing broader aspects of care, while patients don't perceive that integration. However, the results also show us shared perceptions, indicating a common common perspective about this construct. We are talking about working with persons' beliefs and values, sharing decision-making, and being sympathetically present. We also study the possibility of several individual characteristics influence the perception of person-centered practice in both groups. In all of those different variables, any effect on person-centered process perception was identified. This result suggests that each person experiences in a unique way the person-centered processes, and the therapeutical relationship should be individualized rather than a pattern of care shared by professionals and older adults. As conclusions, we could see that there is a higher trend of score the perceptions of healthcare teams. There are differences between groups, especially in working holistically and engaging authentically, that emphasize this gap. And we need also to gain awareness of each person's unique experience. These disparities can hinder the integration of person-centered practice, but also underscore areas for improvement. To bridge this gap, healthcare professionals should motivate strategic investment. A professional must cultivate self-awareness, invest in team reflection, and reinforce communication skills. To bridge the perception gap and strengthen the implementation of person-centered practice, we must move from delivering care to co-create care, aligning care with what matters to old people, emphasizing a holistic and person-centered approach. Ultimately, the care provided will be perceived in alignment with person-centered practice by professionals and older adults. Thank you, and I look forward for your questions.
Thank you. Thank you. Thank you so much for, again, nice presentation. I think it learns that also in hospital, this person-centered care, where we put so much stress on in integrated care, is important. PCPI, is that a scientific instrument? You said it's validated for Portugal. Is it something for clinical use? Could you tell us? It's remarkable. What I see now, how many abbreviations we use. We talk to each other in abbreviations. I think it's because then patients don't know what we're talking about.
It's true,
Okay.
it's true.
But PCPI, what is that?
The person-centered practice inventory is a tool that is the theoretical background is the person-centered practice framework. So they are constructed to respond to each domain. So that's why we have two different instruments, because the participants or the service users just can evaluate the process of care they are living, they are experiencing in the care context. In the other side, the staff, the health professionals could evaluate more dimensions about care. The prerequisites, the health environment, they can be evaluated all of those domains. So these inventories are internationally recognized. They are validated to several languages. In Portugal, we have both validated and culturally adapted to our population. They have giving us more knowledge about practice and how to monitoring that practice when we are trying to move forward person-centered practice.
And there is already utilization also in daily practice?
No.
No.
It's not just for investigation right now.
Okay. A third attempt to see arms lifting. Any questions in the audience? Someone can tell a joke? Or is it the pasta del natas that are waiting for you? Okay, I'm going to conclude. I would like to thank the audience. I want to thank the audience for coming and listening, and of course our speakers for 3 very nice, instructive presentations. Thank you, and bon appétit.
Thank you.
I've got a lot of people in this room, so come down. I would just like to welcome you all to the last session for this afternoon. Our session is on global approaches to designing and implementing integrated care pathways. My name is Tabitha Jones. I am a PhD student at the Leader Centre at the University of Sydney, and I have come from Australia, and I am very honoured to be asked to chair this session this afternoon. I think that we'll get straight into it because we have a really great lineup of people who are going to tell us about care pathways. So if you would just like to welcome Robin Raffs to the stage to talk about intermediate care in the Netherlands, exploring good practices and the co-creation of client-centred integrated care pathway.
Hello everyone, my name is Robin Raafs and I work as a junior researcher at Maastricht University in the Netherlands. I also work as a nurse at an SCRC facility. Today I would like to tell you more about our research on short-term residential care in the Netherlands, how we explored good practices and the co-creation of a client-centered care pathway. First, I would like to tell you more about short-term residential care in the Netherlands. It is a form of intermediate care and is known as a form of temporary inpatient care for older adults living at home with acute total decline. It is usually provided in nursing homes. The aim of SCRC is to stabilize and improve the patient's condition in order for them to return home. The population in SCRC is very diverse. We see a lot of different patients with a lot of different diagnoses, like people with hip fractures, or the recovery after a total urinary tract infection, or the recovery after delirium. SCRC is a very complex process. It involves various partners. It involves cooperation and collaboration between various partners and settings, for example, the general practitioner and the hospital. SCRC is not the same as geriatric rehabilitation. It differs in its intensity and its form of treatment. While SCRC is often monodisciplinary, geriatric rehabilitation is often multidisciplinary. To give you an impression of the patients being referred to SCRC, I would like to give you a brief introduction to the case of Mrs. Jensen. Mrs. Jensen is an 88-year-old lady living at home. She's a widow. Her husband recently passed away. She has 2 daughters living close by and they're involved with their mother. The patient feels very weak and she's unable to manage at home despite having home care twice a day. She went to the general practitioner and the general practitioner sent her to the emergency department due to a suspected delirium and a self-care deficit. At the emergency department, she is diagnosed with a generalized decline caused by a recent COVID infection, and also with a self-care deficit. There was no delirium diagnosed. The troubles with word findings align with a previous stroke she had a year ago. Mrs. Jensen is referred to SCRC to recover and regain strength before she can return home. Then SCRC is relatively new in the Netherlands. It is introduced in 2015, which is why there are no national guidelines available. This leads to a large variability in care provision across different regions in the Netherlands. As I mentioned earlier, SCRC is a form of care to improve the patient's condition in order for them to return home. In fact, in practice, we see less patients being discharged home than expected. The aim of our study is to improve the quality of SCRC by developing a care pathway which meets the patient's needs. We did this through exploring good practices and improvement possibilities. And the next phase is the co-creation of a client-centered care pathway. The first phase, the exploring good practices phase. We did this through a qualitative exploratory research. Data is collected through literature research, expert opinions like professors in elderly care and healthcare providers associations. We also did 7 semi-structured group interviews with healthcare professionals, managers and policymakers. The data is analyzed through thematic analysis based on predetermined topics: referral, triage, treatment, and care and discharge. The next phase is the co-creation phase. We did this through 6 online sessions, and each session had 7 to 14 participants from 9 participating SCRC wards across the Netherlands, both in rural and urban areas, as you can see on the map of the Netherlands on this slide. Participants were selected through purpose sampling. The participants had to work in direct patient care in SDRC or be closely involved in SDRC. Participants were nurses, physiotherapists, nurse practitioners, team leaders, and policymakers. Each session covered one of the following topics based on the steps in the patient's journey, starting with referral, the next was triage, treatment and care, and discharge. After each session, the data was summarized and presented to the participants to check for its accuracy. Then a little side note about the care pathway itself. When we started this research, we expected there would become more funding available in order for us to expand treatment hours. Unfortunately, while doing the research, there became no more funding available, which is why we had to shift our focus from expanding treatment hours to improving the actual care. Then the care pathway itself. We structured the care pathway in different elements based on the patient's journey, starting with optimizing referral information. We would like to know, especially for patients with cognitive problems, we would like to know how did they function prior to referral. The next one is case discussions between special professionals to learn from each other and to give the patient the right care in the right place. The next one is when the patient is being admitted. We advise to do a multidisciplinary intake and the development of personal goals. The multidisciplinary intake has to be with at least one member of the nursing staff and at least one member of the medical staff. We advise to do it in a holistic way, which means seeing the patient as a whole and not just assessing only the medical problem. Then preparation for discharge. We advise to start early after the patient is being admitted by identifying what is necessary for the patient in order for them to return home. For example, home modifications. We also advise to do digital home visit, which means getting a total view of the living situation of the patient through videos and pictures. And the last one, informal caregivers, that's the one I would like to highlight a little bit more. Involving informal caregivers in SDRC doesn't just mean adding help, it also means improving the quality of care. Informal caregivers often have a key role in the patient's life because they have a lot of knowledge about the patient, which improves the care alignment, especially for patients with cognitive problems. It also strengthens the connection between professionals and informal care. And the last one, it supports the transition back home. Involving the caregiver makes the process smoother and safer because the caregiver knows what to expect. We have different actions we recommend doing while being admitted in SDRC. At first, we advise to assess the caregiver's burden and identify ways to reduce it. How much stress or strain does the caregiver experience and what are ways we can to reduce it. The next one is discuss the caregiver's preferred and possible roles in treatment. What role are they willing and able to take during treatment? And the last one is exploring training opportunities for caregiver skills. So we developed a client-centered care pathway in close collaboration with healthcare professionals, ensuring that the healthcare pathway is aligned with what is needed in SDRC. We focused on participation, individual goals, and needs. Unfortunately, due to a lack of funding, we had to shift our focus from our research from expanding treatment hours to improving the current quality of care. Future research is on identifying patient characteristics. My colleague Lisa Klein talked about this earlier today. We're also implementing the care pathway in participating organizations, and we're conducting a process evaluation of its implementation.
Thank you, Robin. We are going to save the questions to the end for this session, so if you have some questions, you can pop them in the app. I'm happy to get them from there, or we will have a session of questions at the end. I'd like to now ask Kieran Holland to come forward to tell us about the Health Pathways community, enabling learning health systems to get evidence and policy into practice.
Well, I wasn't expecting this, I have to say. Kia ora koutou. I'm Kieran. I got off the plane from New Zealand yesterday and I'm feeling a bit dazed, but What an amazing venue, and the ICIC team have once again done a great job with this conference. Thank you. It's my button. All right. So today I'm going to talk about Health Pathways, which is a global care pathways collaborative that's working to enable learning health systems. But first, a different kind of pathway. This is in the Hooker Valley in the South Island of New Zealand. If you like beautiful pathways, this is my plug for the New Zealand tourism industry. Do come and visit us. We'd like to see you there. I was born in the South Island of New Zealand. Both of my parents were originally rural GPs, so from a young age I kind of got this concept that it was quite a tough job, because not only do you need to remember something about the hundreds of different conditions that could walk in your door every day, you also need to work out how the local health system works, and that health system keeps changing, and they don't teach you that at medical school. When I was 5, my parents moved us to Christchurch City in the South Island. They didn't know anyone, they didn't know how the local health system worked. To find out what to do for their patient, they needed to ask down the corridor, ring around, and just do trial and error until they found the right thing. My mum said it took her 3 years before she felt confident practicing in Christchurch. So you can see that the care that people get depends so much on the experience, the local knowledge of their doctor. And this became an inspiration for my work on pathways. I trained as a doctor too, but really found my passion in health system improvement. I happened to be in the right place at the right time, really, in Canterbury, where some really visionary leaders set about creating this integrated health system that was centred around the patient, where care was delivered at or near their own home, and hospital services were really reserved for those who really needed them. And the key metric for the system, for everyone, was not wasting the patient's time. So the team that I worked for was called the Canterbury Initiative, and it was charged with working at the interface between primary and secondary care. And the mode of working was to form small work groups with a handful of general practitioners, a handful of specialists and other clinicians around a particular condition or presentation. Often these people had been referring to each other for years, but they'd never actually met face to face, so it was about establishing the relationships and the trust. The facilitator would ask everyone, what was working and what wasn't working. At the end of those sessions, there'd be a whiteboard full of ideas and opportunities, mostly what wasn't working. But what became clear quickly was that often it wasn't complex stuff. It was like, if you guys included this information in your referral, then we could better prioritize the patients. If you guys gave us a number that we could call when we needed advice, we might not even need to refer these patients. And then there were the ideas about actually changing the models of care and improving the system. But what became very clear through these work groups was that we needed somewhere to write this down so that everyone in the system could see it, and that would help the system to work better. And so was born Health Pathways. Health Pathways is a website designed for clinicians to use at the point of care. It combines best practice evidence with local knowledge about the local health system, so it covers assessment, management, but also how to access local referred services in the community and in the hospital. And it includes links to related and relevant patient information. It's written by clinicians for clinicians. It's used in the consultation. People don't read the pathways from top to bottom. They go in there with a particular question in their mind that they want the answer to, and then they move on. And every page on the site has this feedback button at the bottom right corner, so every clinician in the system has the opportunity to make improvements to the system to point out where things aren't working. This one, Community Health Pathways, was the first one, and it was designed for general practice teams. We've subsequently developed something called Hospital Health Pathways, which is similar but designed for junior doctors and seniors working outside their area of expertise in a hospital setting. And the two together complete the patient journey so that the right people are getting as much care as possible in the community. When they need hospital services, they get those too, but there's early discharge planning happening from the moment they enter the hospital. Now, other health systems started visiting us in Canterbury after a few years and said, hey, actually, we want to do that too. Over the last 15 years, 55 other health systems have implemented health pathways across New Zealand, Australia, the UK, and very soon in Canada, as you'll hear shortly. So collectively, those health systems are caring for around 35 million people. And in the last 12 months, the site's been used over 16 million times. So hopefully that's 16 million consultations where a better decision was made as a result. You might be curious about the organisation. Oh, and before I go on, so that group of health systems is a community. It's actually a community of practice. So they're all really trying to do the same thing, develop care pathways, integrate the system, make things work better. So unlike Canterbury, which had to start from scratch, they all get to benefit from the work of others. They don't start from scratch. They have access to all the pathways that other health systems have developed. And so they can pick the ones that are most relevant and rapidly localise them into their own system. And we help them set up a team to do that. You might be curious about the organisation behind Health Pathways, which is called Streamliners. It's a social enterprise. It melds the commercial discipline of the private sector with a really strong social purpose. The founders of the organisation were a husband and wife team. They transferred their ownership into a charitable trust called the Just Trust, which supports integrated care. That's 80%, and then the other 20% is now owned by the New Zealand government in recognition of the Canterbury's contribution to starting all of this. So where's the evidence? Well, in terms of how clinicians think about pathways, there have been lots of surveys, focus groups, those kinds of things. This one from South Tyneside in 2023 is not unusual. And it shows that most clinicians think that it helps them deliver better care to patients, make better referrals, and saves them time, in this case around an hour per week. So because clinicians like using the pathways, it helps them do their job, it also then becomes a tool for the system. So most of you are probably familiar with the concept of the learning health system, which seems to be a growing concept. And the basic idea is that as people are delivering care in practice, they're generating routine data in the very systems that they're interacting with. That if you actually examine that data, you can draw out insights into what's working and what's not working in the system and generate new knowledge about how things could be better. And ideally that informs practice and you have this continuous learning cycle. There are hundreds of models around how learning health systems ought to work, but the reality is often they don't quite get there. And it's often this piece about going from knowledge into practice where there's an implementation gap. Why is that? Well, around 25 years ago, this pair, Gabay and LeMay, did some really interesting study, ethnographic study, where they actually went into a high-performing general practice in the UK and tried to examine this question: how do people make clinical decisions at the point of care? Now, in the idealized world of evidence-based medicine, you do the research, you write the guideline, and then magically the right decisions happen. Turns out that's not actually what happens at all. In fact, clinicians almost never in their observations in this study referred back to guidelines in a consultation. Instead, there was this kind of milieu of things going on in the clinician's head. There was social knowledge that they'd acquired in the tea room of the general practice. There was practice-based experience, things they'd learned on the job over the last 10, 20 years, rules of thumb and heuristics. There were the influencers in the system who persuaded others to change. There was the local context, so information about that they'd acquired about how the local health system worked. And most importantly, there were those patient factors that might mean that actually the evidence doesn't actually work for the person that's in front of me. And you can see that care pathways, while they can't capture all of this, do start to capture some of that stuff, the local knowledge, some of the heuristics and rules of thumbs. These can be embedded in the pathways, and importantly, in a way that's actually useful at the point of care. And so that's what Health Pathways tries to do, is close that gap between knowledge and practice. And there's an increasing range of publications describing new models of care that have been embedded using Health Pathways. If you're interested in going into more detail, I recommend this one in particular, which came from Geoffrey Braithwaite's team at the Australian Institute for Health Innovation. And they describe the way in which the Western Victoria region in Australia used Health Pathways to enable a primary care learning health system around and during the COVID response and subsequently. So that's Health Pathways as a system enabler, but ultimately, health systems want to generate outcomes for the people in the population. And one way of thinking about it, as we all know, is the expanding quintuple aim. Now, this is where things get harder in terms of measurement, because pathways on their own don't generate these outcomes. You need the models of care, you need the funding changes, you need the education, and so on. And ironically, when health systems are under the most financial pressure, they need economic analysis, which is often when they have the least resources to do the evaluations and the economic analysis. We had a first go at this last year, and no health system has done a full evaluation of pathways. So what we did was we looked at those who had done evaluations of specific pathways and aggregated them, applied them to a model population of 5 million people over a 5-year period, and found that if you could achieve this in that population, then potentially you could save $9.76 per dollar invested. But we also learned that we needed more robust and flexible prospective ways of evaluating the economic impact of pathways, and so we formed a partnership with IFIC and the University of Newcastle to look at what had people done in this area and what could we learn from it. And we're fortunate to have a pretty high-powered technical advisor group. Nick and I will be reporting back on our preliminary findings shortly. And lastly, it's become clear that most health systems don't have the resources or the capability to do evaluation. It's always, or often, an afterthought, done retrospectively. But I come to conferences like these and I meet a whole lot of researchers who do have those skills and potentially access to grant funding. So our focus now is to say, can we do with pathways what we've, with research and evaluation, what we've done with pathways, and form a national, international network where people can collaborate and share methodologies and collaborate on grant applications, working with the health systems that we're working with. They have good data, and hopefully this way we can actually get better evaluations of the pathways system. Thanks for listening, and looking forward to questions in a moment.
Thank you, Kieran. That was a wonderful presentation. I know Health Pathways from New Zealand has been crucial to the Health Pathways work in Australia, and it's a good example of how globally we can take things from country to country. I'd now like to introduce Alistair Rose, who's going to talk about leading system-wide collaboration and integration of health pathways from national policy to frontline practice in Wales. Thank you.
Diolch yn fawr. Gwrandawr, chi croeso bwgatadri. As you've heard, I'm Alistair Rose. I'm a freshly retired GP and former National Clinical Lead in Wales for health and care pathways rollout. So I sort of follow on from Kieran's talk quite nicely. What I'm going to talk about now is actually not the theory, not the academia. I'm going to talk about what we actually have done in a whole country with health pathways. Now, that country is Wales, so I'm going to talk a little bit about Wales, then I'm going to talk about what our story was, very briefly, to getting health pathways across the whole country. And then I'm going to talk about the impact and how we've used health pathways to make changes to our whole system. So, can I make it quite clear? Wales is the country, it is not a part of England. We have a completely separate health service. I just want to get that over. I don't have a chip on my shoulder, really. Now, the way the health service in Wales is arranged is that into 7 integrated health boards. They cover primary, secondary, tertiary, quaternary services in the community and in hospital. They don't cover social services, but they work closely with their local authorities who do provide these statutory social services. We should be doing it perfectly then if you've got one organisation covering virtually everything. But in spite of that, we just haven't managed to deliver, and we have massive waiting lists. For a population of 3.3 million, we have 700,000 people on waiting lists for outpatients. We have just 374 general medical practices, and the number is reducing all the time as people retire and they're not replaced. And our outcomes, to be honest, are not that good compared with the rest of the United Kingdom. So we're not starting from a great position. And one of those health boards several years ago teamed up with Canterbury in New Zealand and decided to develop the Health Pathways programme. This was Cardiff and the Vale Health Board in the south, the capital region of Wales. And they set up a team of GP clinical editors who worked with their secondary care colleagues and developed a platform of localised pathways that primary care clinicians, be that GPs, nurses, allied health professionals, pharmacists, they could all use, even district nurses were able to use them, they could all use them at the point of need, in anger, during a consultation. And this is the Cardiff and Vale website. Unfortunately, I can't give you a live demo, I haven't got enough time, but if you come to our workshop tomorrow at 4:45 in room 9, I'm doing a sell here, you can actually see a live demonstration. Also, colleagues from Health Pathways, Streamliners are on the stands as well, if you can't get to the session. And they've produced over 400 pathways over the last 4 to 5 years themselves. But I was interested in my national lead for primary care role in what the impact of what they've done is. And I'll just give you one example. This is a run chart. It is requests for MRI scans of the lumbar spine, requests from GPs only. And as you can see, in the left-hand side, that big green block is the time before the COVID pandemic. The middle block is our lockdown period, and the right block is after lockdown. Now, the point is that to begin with, there were 171 scans per month undertaken just from GP requests, but just for lumbar spine. The middle section, all non-emergency scanning was stopped because of the COVID restrictions. And at that period, they reviewed, the GPs and the radiologists and orthopedic surgeons reviewed all the referrals for scans and said, well, what actually happened to these patients? And they found that 2/3 of patients who underwent a scan still ended up being referred into hospital to outpatient orthopedics. And they said, well, really, what a waste of resource, because actually when we see them, we don't scan them necessarily. We could be using those scans for higher value problems in patients. So they agreed to write a health pathway that reflected this change and this experience and this data. And what they said was, okay, we'll write a pathway that says that GPs cannot refer routinely. If you think your patient doesn't meet that pathway, then we will give you a phone number where you can speak to a consultant radiologist at any time and discuss your patient's case with you. So in other words, there was remote advice and guidance offered as an alternative. And you can see the impact from 171 scans per month down to 53 scans a month. And the well-sighted of you can see that's a 70% reduction in activity, almost £200,000, which is roughly equivalent number of euros in savings nominally. Of course, that capacity was used for other patients. But it wasn't just MRI lumbar spine. This is MRI knee. There they found an 82% reduction when they adopted the same pathway change with access to remote advice and guidance. So they used the healthcare pathway, the community health pathway, to help change the service and the system, down to just 19 scans a month from over 100. And for ultrasound of the shoulders, there was a 92% reduction in scans undertaken without a reduction in the quality. And if you looked at these lines now, these charts now, you'd see that there hasn't been a drift upwards in referrals. They are still steady. There's been an increase in referrals to allied health professionals, such as physios, but not back to traditional outpatients. And of course, people can see a physio much quicker than they could see an orthopedic surgeon as well. So it's saving the patient's time and they're getting the right care straight away. So having seen that evidence, we asked, what else have you found? And here's a quick example. Triage. They started putting a GP in to triage referrals for diabetes clinics, consultant-led diabetes clinics. And they got the triage done against agreed community health pathways. Before the triaging clinician was introduced, 3/4 of all patients referred were seen by consultants. But it was the knowledge and data gained by that triaging clinician using the community health pathway that allowed them to change the system, rebalance the staffing, and now less than half of the referrals end up in front of consultants who now only see the more complex patients, and they've got other professionals, nurse practitioners, dietitians, for example, seeing the patients. I'm just going to whiz on. So we saw this evidence, and nationally we said, well, actually, with some funding, we could do things nationally differently. But rather than do a traditional rollout of pathways where each organisation has to set it up itself, what can we do nationally? And we came up with a national pathways by default approach. So Welsh Government supported each health board to recruit 1 to 1.2 whole-time equivalent GPs. That's all. And each health board gets its own equivalent GP to work as a clinical editor. And one of them stands up and says, well, I'll write the pathway on behalf of all the other health boards in the nation, and I will work with some national specialist clinical networks that include patient representatives and carer representatives. And I will work with those subject matter experts from that national network, and we will come up with our national pathway with the appropriate discussion with stakeholders. And then when we've got that national agreement together, it will we give it to each of the local health board editor teams, and they add the local colour, the email addresses, the telephone numbers, the stuff that can only be done locally. So we allow a balance between national consistency and localisation. You need the national consistency to give that standardisation and reduce the variation in quality. You need the localisation to get the buy-in between primary and secondary care and the local health organisations. So far, you can see the bubbles here, the people who've been involved in writing these pathways. You can see that specialists are key to this, a big part of it, as are our GP editors. That purple unknown other is patient and carer and charity and third sector representatives, but you can see all the other nursing and allied health professions involved as well. And our patient and third sector reps are there in the national and whatever local level stakeholders as well. And this is what we've done so far. Start on the right-hand side, that purple banner there. So far, in just 2 years and 2 months, we have developed 281 nationally developed pathways. We've got another 200 in development. Just in the last 3 months alone, that's 142,000 page views from our primary care colleagues. And we're now heading for almost 1 million page views in the last 2 years and 2 months. 1 million page views in Wales. And we're using health pathways as the foundation for the for how you can change the system then. When you've got figures like that, you're really onto something. So look, we said, well, you know what, if you've got these nationally agreed things, maybe we should be writing into a GP's contract, the nationally negotiated GP's contract, a requirement to actually consider these pathways. It's not rocket science. So we did that. With the agreement of the GP's trade unions, it is now a requirement, contractual requirement, that they have to consider at every consultation the nationally agreed advice and guidance. We've also put legislation in so that health boards can use the pathways as the basis for schemes for validating outpatient waiting lists and basically making sure that everybody on a waiting list is there, has a clinical justification for it. The chart on the left-hand side shows a couple of lines. The blue line just shows the number of page views. The green line is the number of new users, always increasing as more health organisations come on board. And that right graphic, the figures are too small, but it just shows that that at the moment, up to 78% of primary care clinicians are using our community health pathways as their preferred source of clinical information. And finally, just to give you an idea of how we're trying to embed this into a health system to help produce effective change. Recent ministerial advisory group in Wales were asked to advise on improving the performance and productivity of the NHS, the National Health Service in Wales. And the first recommendation was that the funding for the Health Pathways programme, the national funding, should continue. That's how much and the Minister has accepted that. That is how much weight is being given to what Health Pathways can do when you build on that foundation. It's also recognised that you can use Health Pathways to address the problem of accountability, and that actually we need strong medical leadership or clinical leadership to ensure that whatever pathway you have, that it is actually being effectively used and people aren't just putting it on the shelf in a glossy brochure. So a quick reminder that if you look at strip the layers back, right, it always comes back to the agreed community health pathway agreed between primary and secondary care, as Kieran's already described. And this enables you to build on this with some simple tools and interventions. Yes, some of those things are people level, some of those things might need legislation, but that is how we are trying to make a system change for the better in Wales. Diolch yn fawr.
Thank you, Alistair, and I think you'll agree that that was some impressive amount of work on their health pathways. I'd now like to ask Leah Lewis to come and tell us about Dynamo, redesigning care pathways to maintain business continuity during a crisis scenario.
Hello everyone. I'm doing this presentation on behalf of a colleague, Lutz Kubica, so bear with me if I make any mistakes. First one is to get okay. Hold these images in your mind as we go through the first few slides. Wildfires, pandemics, earthquakes, prolonged heat waves, wars. All of those crisis scenarios we've experienced to a greater or lesser extent around the world since 2020. They're all disasters. So why is this project needed? This project is funded by the Horizon Europe programme in the European Commission, and it was really funded because most of our countries during the pandemic suspended business as usual for their health and care services and focused all their efforts on managing those people that were infected or testing people. We've heard many presentations today from places in the UK, including Alistair just now, talking about our huge waiting lists that have started to increase before the pandemic actually, but have been exacerbated and we just cannot get on top of them. So we needed to make a case in the proposal to the Commission that there wasn't a solution out there that would help health and care delivery organisations to plan in the event that a crisis hit, that they could plan to sustain their essential services whilst the crisis situation was being managed. So we've looked at redesigning care process pathways so that we can redirect patients and citizens to other facilities or other resources in order to get their care and treatment. And when we discovered that there was no solution out there, this project is a pre-commercial procurement funding instrument that has been used, and we have 5 buyers, procurers in the consortium all of whom have collectively put their money in to procure research to actually collaboratively and co-create this solution that you will hear a little bit more about today. It's not a care delivery tool, it's not a point of care tool, it's a planning tool, and it's there to effectively guide either partially or entirely automated implementation of a response to the crisis to keep business as usual going for particular essential services. We've got procurers from Italy, Portugal, Spain, Wales and Poland. And they not only have seen that such a tool is needed, but actually they're prepared to do the hard work in working with a group of suppliers to bring this product or products to fruition at the end of the project. It's a multi-stage process, and the suppliers have to tender against predefined criteria that we've developed collaboratively amongst the consortium members. And in the final phase, which we are coming to, the procurers will simulate a crisis scenario and see how the solutions actually work in practice in terms of enabling them to continue with some essential services. Will there be a real benefit? That'll be interesting. We are developing one solution that can be adapted to address a future pandemic, increasing antimicrobial resistance, a heat wave, workforce shortages, energy blackouts, cyber attacks, floods, and anything else that we might think of that ends up being a crisis. The system is consisting of a dynamic pathway modelling tool to enable what's called the local modelling group to look at different options as to which pathway they might want to follow. So it's a sort of a decision support tool for the local modelling group, and it's there for each pathway option that is generated will also have an impact report so that the local modelling group members can assess alternative pathways and which ones they think they want to go with. And it will also facilitate task planning and skills matching in times of crisis. I think many of us know that from the COVID pandemic, it was all hands to the pump. It didn't matter whether you had a respiratory qualification or not in terms of drawing in all health and care staff. People were trained on the job to manage an increasing influx of patients. So the planning process itself, where the procurers have gone through these steps in order to build the solution collaboratively with the suppliers. And we hope that at the end we'll be able to do that real-life sort of simulation exercise and get the outcomes of that to determine what further developments will be required to the solution in order to bring it to the market. The consortium, as I said, consists of 5 procurers in the buyers group. It's got some research and associated partners, so Empirica is the organisation that coordinates the project. TIC Biomed in Valencia are the ones handling all the tendering processes. The University Hospital Cologne is managing the evaluation, and NHS Wales is the associated partner because at the time of funding, the UK was not eligible to participate in Horizon Europe, so they got their funding via a different funding body in the UK. So how are we making it happen? There have been a number of activities working with the market, the supplier community, with various calls. We are currently almost at the end of phase 2, where we've got 3 suppliers, supplier B, C and F, who are just last week and this week doing their prototype testing on site in the 5 Procura sites. They have to submit their last tender by the end of this month, and 2 of those suppliers will go through to the last phase, which lasts from August to January 26. From the Procura side of things, making it happen, each Procura has had to develop organisational stuff and establish their local modelling group. They have had to work through their current care process pathways from a pre-crisis phase, the crisis ramping up phase, the crisis developing, and sort of being full-blown, and then the wind down, and hopefully services returning to normal. And the technological innovation has been co-designed to support all those different phases. This is how it's supposed to be used as a starting point. So it's got setup, planning, modelling, and testing and operation. And for each of the bullet points, the procurers have been developing when it should be used, who's allowed access to the system and in what role, who receives training and in what regard. From the planning side, which clients and services and resources are being affected by the crisis, which clients and services and resources are to be prioritised, and how can service flows and or resources be reorganised so that critical services can be maintained. On the modelling side, we're looking at what KPIs need to be calculated for assessing impacts of reorganising service flows and resources in a particular way, and what data and information are available to calculate these KPIs and from which sources can they be obtained. That was very interesting. There's a lot still on paper. No surprise, perhaps. And what outputs and other information needs to be communicated to which parties and through which communication channel. Then the testing phase towards the end of this year will be looking at whether the data that's needed, how much has it had to be curated and prepared for being ingested into the Dynamo system. Do the defined KPIs deliver meaningful and reliable information for assessing the reorganised service flows and resources based on the data in the system? And does the initially preferred reorganisation of service flows and resources remain adequate as the crisis progresses? So there's quite a lot of activities that the procurers have been involved in. And this, you won't be able to read it, but it's been developed in Mural software, and they've sort of looked at the current way of managing certain groups of patients, so business as usual, and then they are looking at what point does the system need to trigger that it's out of capacity, and we need to be looking at options for delivering care and support somewhere else, potentially. What decisions are expected to be taken by the local management group to ensure the continued service delivery is in this section, and then the communication aspect of the system is represented at the bottom. What do we mean by pathway? It's not a clinical pathway like Alistair and colleagues have been describing. It's a planning process decision tree for maintaining essential health and care services in response to a crisis situation. And I'll just run through quickly how some of the data and information is being examined before it gets ingested into the Dynamo system for the last phase. So ISRA is a social care delivery organisation in Treviso in Italy, and they run a number of care homes and nursing care homes and domiciliary care services. So they have massive workforce shortages, and so their parameter is looking at the number of people that they might have away, be it on leave or sick leave or on holiday, and how does that relate to the numbers that they need to deliver the services. Aquas in Catalonia, they're focusing on the capacity of surgery and different surgeries. And so there's two parameters associated with that, which is not only the capacity of the theatres, but also what's the demand for the surgery that is actually required. And you can see that we're not linking to any of the electronic systems within the procurer sites, because we didn't want to get bogged down with interoperability and do nothing else. So this is about getting extracts from systems and uploading them into the Dynamo system to do the simulation. And we've looked at the update frequency that the parameters will actually required. We've developed thresholds for each of the parameters, and you can see from this, some of them are almost real time, some of them are daily, but very much down to the local configuration of what those thresholds should be. And that's it from me. Thank you.
Thank you, Leo. And please send your questions through to the Q&A section of the app for the conclusion of these presentations. I'd now like to invite Riam and Heather to come forward. They're going to present today on a one-stop shop platform supporting primary care providers diagnosing, managing and navigating patients living with chronic conditions. Thank you.
Good afternoon. My colleague Ram and I are very honored to be here today in beautiful Lisbon to share with you our journey on creating system planning for integrated care pathways. We've traveled all the way from another beautiful part of the country, Ontario, Canada, where we represent 3 Ontario health teams: the Burlington, Ontario Health Team, Middlesex, London, Ontario Health Team, and the Greater Hamilton Health Network. All 3 Ontario health teams were launched in 2019 as part of Ontario Health Systems transformation, and were recognized in 2023 by the Ministry of Health as high-performing teams. This recognition came with new deliverables, one of which was the development of clinical pathways focused on chronic disease management, specifically for COPD and heart failure. This slide here is a representation of a story that we want to share with you today of building these pathways. Each stop represents an area that we will share and discuss with you today. Engagement, setting a vision and direction, tri-OHT collaboration, landing on the intervention, implementing the intervention, and launching the intervention. Engagement. Engagement is always the first stop at any of our planning journeys. It's a key principle in our system planning for Ontario health teams. The 3 Ontario health teams conducted an extensive engagement process to understand the current state and system gaps in management of chronic conditions. The aim was to define the future state. We engaged with various stakeholders representing primary care, secondary, and community care services, as well as individuals living with chronic conditions and family caregivers. Together, we identified our guiding principles described in the colored boxes on the screen. We are building care pathways, not clinical pathways, paying attention to clinical and non-clinical needs. Our pathways are person-centered. Our pathways are evidence-based. Our pathways are standardized, yet adaptable. Our pathfinders are provider-friendly and are for individuals, not a population segment. Our pathways are easy to adapt. Our pathways are equitable. Our pathways are sustainable.
A direct outcome of the engagement, besides the guiding principles, was actually setting on one vision across the 3 OHTs. During the engagement, we learned that although clinical guidance and quality standards are available, their utilization by providers is very low, and that's because of the difficulty in accessibility. It's inconvenient for providers to look up quality standards for each individual patient that they're seeing in their clinic. We also learned that developing pathways, one pathway at a time, is not a great idea, because this requires providers to alter their workflows one pathway at a time. This approach necessitates that they are managing some chronic conditions based on a standardized approach and other chronic conditions based on the status quo, which is pretty inconvenient for our providers. We also learned that navigation and referral supports are essential components of any pathway, because managing chronic conditions doesn't only need to be managing the clinical aspect of the disease, but also social terms of health and any other factors that might determine the outcomes of the chronic condition. We also learned that an integrated care pathway should establish a comprehensive approach to care, looking at the full trajectory of the patient illness or disease, starting from prevention and early detection all the way to palliation. We learned that providers need to land on a local agreement where primary care providers, community supports, and secondary care providers have one approach to care for their patients. We also learned that a single source of truth is needed, where everything related to managing your patients, navigating your patients, and assessing them is in one platform. Based on these points, we landed on our vision that we need to be building one platform for our primary care providers and clinical teams, helping them assess, manage, diagnose, and navigate their patients. We are very determined to bring this vision to life. Once the teams agreed on this vision, we assembled an interdisciplinary tri-OHT team. This team included executives, clinicians, implementation experts, digital experts, also project managers, and system planners. And we've always consulted with our patient and caregivers partners. After we assembled the team, we conducted a second round of co-design in order to co-design together a blueprint for the solution. This blueprint was all about the technical and the content that needs to be included in the solution. It was also about what the solution is and is not. After that, we reviewed the market and the literature to try to find, is there anything out there that would fit our bill? Luckily, there is. We were able to identify a couple solutions in the market that might be having some potential to fit our requirements. So we conducted a comprehensive request for proposal process, and it seems like we have a winner, Health Pathways. You've been hearing Health Pathways a lot this session, so I'm not going to be going into details about the specs of the platform, but for us, it was a platform that's out there, validated, tried somewhere else, and it's all about adoption and localization to our local context. So we partnered with them. Implementing Health Pathways, as we learned it, is a pretty detailed process, yet a very interesting one. Initially, it involves adopting international health pathways, which encompass a library of about 600 pathways. Some of them are disease-specific, others are symptom-specific. Subsequently, these pathways must be localized to the specific context. In our case, it was Ontario, Canada. Localizing all 600 pathways simultaneously is not feasible due to the extensive effort required. Therefore, an essential step is to prioritize which pathways to start with. To start with, localization. This prioritization exercise should adhere to a locally designed framework that was co-designed by the interdisciplinary team across the 3 OHTs, and this framework considers both capacity and need. After a pathway is localized to the Canadian context, which means localizing the terminology used, the drug formulary, assessment and treatment approaches, more of the general clinical guidelines, a final stage of localization is to follow, which is adapting the pathway to the regional specs. And by that, I mean the regional resources and the referral pathways that you want to implement within each and every pathway. At this point, a localized Canadian version of the pathway is ready to be live. Maintaining accuracy through continuous updates for each and every pathway is the next step after that. And then after substantial implementation and long enough time that people are using the pathways, a very interesting last step would be to modify the model of cares or maybe create new ones based on the pathways. I've been talking a lot about what to do to implement the health pathways within our local context. But however, I think that you are all wondering now about how and who is doing that. I think I can simplify this through an SPO framework, so structure, process, outcome. And I'm going to be maybe listing each of these main components. What did we do under it? So for instance, in this structure, we initiated a governance structure across the 3 OHTs. We initiated a program implementation team, as well as local implementation teams within each of the pathways. Pathway teams, I mean, so each OHT. And also clinical teams who write the pathways. We also have some support functions, including communications and evaluations. After having the structures, some processes will come out of these structures. The processes include terms of reference and governance agreements, project charters, plans and workflows, recruitment of the teams as well as the writers of the pathways, lots of training, pathways selection process, pathways localization process, pathways sharing across the 3 OHTs, as well as a comprehensive communication plan and a detailed evaluation plan. What's the outcome of all this? 43 pathways localized to our local context in Ontario and available for our providers to use at the point of care at no additional cost for them, ready to be launched in June in less than a month, and we are very proud of that.
So as Raham just mentioned, we are happy to share that the first iteration of Community Pathways will be launching in Ontario on 3 OHT-specific platforms in the end of June of this year. Our next steps will include localizing more pathways, continue to refine the pathways via learning health system where we measure, enact findings, and improve, and then do it all over again. And with that said, none of this would have been possible without our dream team. This incredible group of partners, primary care physicians, nurse practitioners, subject matter experts, leadership, program managers, coordinators, health pathways community have worked tirelessly to bring this vision to life. They've committed time, expertise, and energy, and their collaboration has been at the heart of this entire journey. Together, we're not just launching pathways, we're laying the groundwork for something bigger, a more connected, patient-centered system that will continue to evolve. Thank you.
Thank you, Heather and Riam. And now for our final presentation for this session, I would like to invite Professor Nicholas Goodwin to the microphone, and Kieran Holland as well, to come back and tell us about developing best practice approaches to support the economic evaluation of care pathways, a scoping review. Thank you.
Hello again. So, as I alluded to earlier, I think one of the ironies about health economic analysis is that when health systems need it most is when they can least afford to do it. And health economists themselves are a scarce resource. We almost need an economic analysis of what the health economists should be applying their minds to, but I don't think that would help either. So we've turned our minds to what can we do to help economic analysis around care pathways happen effectively, and particularly at a local level where economic analysis is really not done well on average. We've also become more conscious that the economic methods that health economists use for evaluating drugs and devices are really not that good a fit for evaluating care pathways, which are complex interventions in a complex system. Usually the drug device type approach is looking at one outcome or maybe just a small number of outcomes, but often pathways have multiple different outcomes, all of which are important. The other thing we've become more conscious of is that the perspective that you're looking at value from is also important and varies with pathways. Often the usual focus is on the funder's perspective, but with pathways it's also important sometimes to look at the societal perspective, the patient perspective, the clinician perspective. As I said earlier, we formed a partnership with IFIC and University of Newcastle. It's been a real privilege working with Nick and a really, really smart bunch of people on this. I see it as very much just a first step in a longer journey to how we can actually leverage the community that we have to make economic analysis and evaluation more scalable. And with that, I can fortunately hand this over, because Nick understands this stuff a lot better than me, to Nick to present where we're up to in our scoping review.
Thank you, Kieran. I think the first caveat is to say I'm not a health economist, but I'm going to report this on behalf of my colleagues and hopefully make a good job. Now, I think we all know what care pathways are. You've just heard that. So aiming to provide that local guidance on best evidence care and reducing unnecessary variation in care. And we've talked a lot about the importance of care pathways in order to be able to streamline and make the right decisions and make the right referral pathways and so on. We've heard a lot about how we can co-design those with the community as well. And we know they can be time-consuming to develop and maintain, and that's why economic evaluations that Kieran mentioned are so important. We need to confirm that the care pathways that we're putting in place, the energy that we've developed in order to be able to enable them to happen, actually have an impact, have value, according to the criteria that we decide amongst ourselves, what's important for them to happen. So there's a need to examine the health economic evaluation of care pathways, and there are a variety of things that we need to look at. So with that in mind, working with Kieran from Streamliners and using some co-grant funding from the University of Newcastle, we tried to do what we thought was a simple thing of doing a scoping review of the evidence in the literature. Well, it turned out it wasn't simple at all. So we conducted a scoping review with really two key things that we wanted to find. Firstly, to determine the types of economic evaluation techniques that have been used and potentially to think through what might be the best approach to support an analysis of care pathways, but also to have a look within those studies that explored reported benefits. What are the different types of economic analysis that have been used and what potential impact did we see? Not going to give too much on the methodology, but it was a traditional review methodology, doing electronic searches with exclusion and inclusion criteria, and the important thing here, I think, are the inclusion criteria. So firstly, we wanted to look at the use of care pathways in the context of their application. So the care pathway that was developed for care within a particular local context, or kind of an active care pathway, the evaluation of that. Secondly, that it needed to be multidisciplinary. So we're trying to look for care pathways that focus on integrated care pathways that go across maybe health and social care between primary and secondary care. So we made a decision that it needed to be across one or more, two or more organizations or services and not just contained within one particular setting. And that was particularly true. There are many studies within a hospital setting that include multidisciplinary professional groups, but we excluded those because we wanted to have a look at the care pathways that went across different settings and contexts. And of course, that there was some form of economic or cost analysis that was included. But what we found, of course, is that there are many different approaches to doing economic evaluations, and you can see them on the screen here, from cost effectiveness analysis that compares cost of outcomes or two or more alternatives, cost utility, outcomes based on use of a measure that considers the impact on both mortality and morbidity, cost-benefit analysis that looks at cost outcomes expressed in monetary terms and the value in terms, often in terms of the individual's willingness to pay for an intervention, cost minimization, cost consequence, which is really interesting, that actually seeks to look at multiple outcomes and therefore provide a suite of outcomes that people can make a decision upon in terms of what they might value for themselves, and we'll come back to that point later. And some others that potentially did some more simple, just costing, reporting on the cost of a care pathway itself. We found 29 publications. We looked at over 1,000. I mean, the numbers that we were looking at and having to boil down to to a review was quite outstanding from the team. 29 publications altogether, which was 28 studies, and 13 of those, 13 across 13 different countries, and 9 of those were in England, and the rest really quite spread across a range of high-income and other countries across the world. And not surprisingly, when you were looking into those studies, you found really quite a heterogeneous range of experimental and quasi-experimental study designs used to answer the question. So most of them looked at a particular care pathway for a particular disease or condition. However, two of the studies, two of the 29 studies, looked at multiple care pathways. So that we're looking at in the context of a particular area. The Blythe study looked at 4 different diseases. The Dean Griffith study looked at multiple minor ailments. So they were trying to have a look at the care pathways in context that they were developing locally. Only 3 studies focused on comorbid conditions, and this has come up a lot during this conference, the issue of how do we develop the care pathways for mental health and cardiac disease, mental health and diabetes, mental health and homelessness. The most common approach was economic evaluation, was just the cost analysis itself, trying to find out how much these care pathways were costing, so not much in terms of the comparison, was only with the 19 studies. And most of them were not taking the perspectives that Kieran was talking about, the perspective from the workforce, or the perspective from the community, perspective from individual patients, perspective from professionals. It was mainly a health system perspective. So a lot of what was driving the economics here was, is this cost effective for us as a health system, for us to make decisions about investment? And that was in 18 of the studies. But you're getting a sense from this that what we were finding was a great deal of variation. So QALYs were generated in all-included studies using the cost-utility approach, and that was 6 studies. But whether we think QALYs is the right sort of approach when it comes to complex service innovations, complex comorbidities, was something we debated within the technical advisory group team. So we don't think that is for me, we don't think that is one measure that is going to capture everything. 2 studies used more than one economic method, and what was interesting here is that they were yielding different results. So if we look at the Everink study that did a cost-utility and cost-effective analysis, the care pathway was seen to be cost-effective based on the cost-effective analysis, which was more technical, but when it came to the cost-utility analysis, it was seen as less useful. So this comes up with a number of different important considerations that the scoping paper was coming up with. Is it important to compare across disease types? Probably so. If we're looking at just one particular condition, maybe we're not getting the answer to what we're looking for. Maybe we need to look at comorbidities and so on more closely within the care pathways that we're looking at. But the other one, is a generic measure sensitive enough to capture the impact of a care pathway? And that's a really important question to answer, because policymakers want a definitive answer on one measure that would be very helpful for us, but in reality, potentially, there are more possible outcomes that you can have through different economic methods that you need to have some form of approach to make sense of. The second thing that we found was the issue between multiple versus single outcomes. So almost all of the studies that used cost-effective, cost-utility, or cost-consequence analysis included multiple outcomes. They looked at multiple outcomes. But what was different was the cost-effectiveness and the cost-utility analysis actually aggregated the cost and care outcomes into a single metric, usually the incremental cost-effectiveness ratio, in order to be able to give one definitive answer to the question, whereas the cost-consequence analysis presented multiple disaggregated outcomes from which you'll be able to see what were the benefits or what were the downsides of a different approach for you to make a decision based on those. So this also led to a number of different considerations that we started to debate. Is the care pathway likely to have multiple impacts, both positive and negative? Probably the answer to that is yes. Can one outcome be identified as more important than others? Well, that's going to be really hard unless you debate it and come to some understanding of the value or the outcome of what you're trying to achieve. So going back to the Ontario example we've just heard, bringing people together to start to debate what matters to them and what value, I think is probably really important. And of course, different stakeholders will prioritize different outcomes. So how do you make sense of that when you're coming to actually integrate that thinking within an approach to look at the health economics of things? Often the studies of cost utility and cost effectiveness kind of use thresholds. So some of the thresholds, would people be willing to pay for this? Or things like that. And the cost consequence analysis was also very interesting because they developed a number of different criteria in order to be able to understand the weighting of the value that people were putting on the intervention, and using the economic analysis to use that weighting to come up with an understanding of whether this was a cost-effective or an approach that people were valuing in terms of the inputs that they used to make. And one approach which is gathering speed actually across integrated care, not just within care pathways, this is an idea of multi-criteria decision analysis. And really what that means is there could be a range of different outcomes. You develop a model, a logic model, to understand what the possible outcomes could be from your care pathway approach, and then you bring people together to actually understand what value they have in terms of whether it's reducing mortality or improving care outcomes or costs or the bottom line, and you're trying to bring those together to weight them. So when you do the economic evaluation, you can come up with a weighted approach to give you an understanding of whether there is a significant value in what you're doing or not. That's actually quite difficult to do, and what we see is most of these analyses actually happen after the fact. So sometimes the weighting is not necessarily related to the process or the care pathway you put in place at the beginning, so mistakes can be made using this type of approach, I think. But nonetheless, it leads to further questions. What criteria do we use to judge value? Whose perspective should be considered? And how will these be prioritized? This conference is, a lot in this conference is about equity. We found very little consideration of equity in any of these studies. A couple of studies focused specifically on homeless people. A couple of studies reported the consideration for equity. Some studies mentioned equity considerations in the development of these care pathways, but none of them really explicitly used that within their economic modeling. And that's a really important issue, because if we're going to be looking at integrated care and care pathways, are we going to miss some of the important things related to equity, about who's likely to be affected and how? Because we know integrated care, like health and social care in general, the inverse care law still applies. So the most vulnerable groups in our society, older people living with complex conditions, people living with mental health and physical comorbidities, people living in rural and remote locations, people who are ethnic minorities and have harder access to care, are often unlikely to be captured within these statistics. And as a result, are we really doing our economic evaluations robustly enough to understand whether the equity issues are really being created? So it creates really significant questions of us in terms of what the questions we're going to ask. So final considerations, and I think we'll come back to panel. Clearly multiple approaches are possible when it comes to looking at economic evaluations, and the economic evaluation that you choose follows on from the purpose that you put to the care pathway that you're putting in place. And I think the technical advisory group felt the cost-consequence analysis, where you can see the benefits and the potential non-benefits of a particular approach and try to make decisions as a group, might be the best way forward, but others would have disagree with that. So when choosing the approaches, what we're trying to do as a follow-up to this study, which is in the process of being published, is try to give some guidance around how would you go about doing economic evaluations of care pathways, indeed economic evaluations of integrated care more generally if you extend it. And that goes to the purpose of an evaluation and what you're really trying to find out, the likely impact of the care pathway that you might have using the logic model, which we saw the Ontario Health team do, and the possible perspectives of the different stakeholders, and trying to bring those in from the beginning so that the economic evaluation that you do is more robust at the end. So I'd like to acknowledge the true leaders of this, who are Mariko Carey from University of Newcastle and Hunter Medical Research Institute, who was the principal investigator and lead on this with us, and particularly to Christy and Bree, who are the engine room to do the work behind the scenes, and indeed to everyone on the technical advisory group, including Arturo, who's in the room here. So thank you to that. Okay. Thanks, Nick. Okay.
Thank you, Nick and Kieran. I'm sure we will agree that was, again, another wonderful presentation. And that concludes the presentations for this session. I just have some questions that have come through on the live Q&A. So you guys have got some microphones there. You might want to grab those. But we've got a couple here for Robin, so we'll start with those. So Robin, the question comes from Sylvie. If I understand correctly, you also focus on training for informal caregivers. Who conducts this training, and is it done individually, or are the caregivers brought together in groups?
Yes. Yes, it's correct. We're also focusing on informal caregivers. We don't advise to do a specific training. We advise to involve informal caregivers, and it's on the organization itself to develop a training.
Thank you. And I think it was an important thing. That was a really good point to bring the caregivers into that. I found that quite interesting. There's another question for you, Robin. Could you describe some of the similarities and differences between the STRC model and respite care? And second to that, do LTC homes have designated STRC beds? If so, how many on average? And that's a question from Lauren.
I'm sorry, can you repeat that question again? Sorry.
So I'll go for the first part is, could you describe some of the similarities and differences between STRC model and respite care? So respite care, in the context, I guess, of Australia is where people who live at home go into some kind of care setting for an amount of time to give respite to the families. So I'm assuming between your model, which was the STRC, and that model.
STRC in the Netherlands fills the gap between the hospital and home care. When people can go home safely without care, they go to STRC. I hope that answers the question.
Yep. And then just a question, do LTC homes have designated STRC beds? If so, how many on average? So long-term care, I'm guessing that refers to.
It varies, it depends. Some have a total department with 20 to 24 beds. Other departments only have 2 to 4 beds.
Thank you. So this question is for you, Leo, in reference to Dynamo. And the question is, how will issues on triage be dealt with? And we might ask that one first.
I'm not sure I understand the question in terms of the triage.
Henry, do you want to ask the question?
Yeah. Yeah, okay. So Dynamo wouldn't be managing the crisis. That's for a completely separate solution to manage, okay? But in relation to, so for example, the Health Board in Wales that's involved in the project, their clinical focus areas are the business continuity for people requiring urgent and emergency care, and secondly, for people with suspected cancer and those people receiving cancer treatment currently. So those are the 2 clinical areas that they are focusing on in the event that there's another pandemic in the future, okay? But they're not looking at managing the pandemic itself. This is simply a tool to be looking at what essential services should we be providing and how might we best provide those. So the local modelling group would look at the redesign pathways that Dynamo will offer them and determine which patients can be seen where in a safe, uninfected environment. And I think the second question related to the public debate. I'm not sure that there would be any public debate about the business continuity side of things, but in Wales we have an organisation called ICIC, which is the patient's voice, and they are a member, the representative from the local area is a member of the local modelling group that is determining, co-creating the options for continuation of those 2 services in the simulation exercise that will be undertaken. that make sense, Henry? Okay.
Thank you. I think this question is for Reham and Heather, and it's regarding if your project is successful at the 3 OHTs, what would scaling to all of OHTs look like?
That's a great question. So I think we tried to be the pilot. We tried to be the first 3 who would be courageous enough to try something new. And we are happy to share our learnings with all the other OHTs. And that's actually happening through multiple avenues. So I would say that many OHTs reached out to us already to learn more about the solution, but also how did we do it? And I think like the how is the most interesting piece of this project given the scale of it. Are there anything to add?
I think the other thing I just wanted to add is in Ontario, for those that are not familiar with our system, we have a lot of work that lives in silos. And part of our vision with this work was to look at this as, you know, something that could be adopted across the province, a resource tool for all primary care physicians within the province. That's still our vision, that's still our goal. So we hope to progress towards that and reduce that variation in care with the number of siloed working systems that are happening in Ontario.
What would it look like? It would look like Wales. Yeah? Yeah. Don't reinvent the wheel. You know, learn from our mistakes.
Thank you. And I have a question for Professor Goodwin. When is the best time for an economic evaluation of a care pathway? So that's the first part to the question. I'll let you answer that.
Well, it starts at the beginning of things. So if you're working with the community to develop a care pathway, you've got to start the economic evaluation from the get-go, and that starts with what this team did here, by getting people together to understand what you value and what impact you're trying to achieve. That's where it starts. And then once you've got that and you understand the logic behind what you're trying to do with your care pathway, then you can begin to build that into the process itself. So from the beginning, like any research really, has to be from the beginning. If it's not from the beginning, then you can make mistakes. If it's coming in a year down the line or 2 years down the line, you're making assumptions about what the care pathway was designed for retrospectively. And so consequently, you can put in economic evaluations that are focusing in on a different set of values and criteria than were there from the beginning. So if at the beginning it was all about cost containment and reducing costs, and then 2 years' time people are telling you it was all about improving care for patients, and that's what you value in the economic evaluation, but the economic evaluation says to you it's not doing that, it's just saving costs. Well, that's probably what it was designed to do. So you've got to try to do it from the beginning in order to make sure your methods and approach is correct.
Wonderful. And the second part to this question is, the studies that you looked at what point did they analyse the costs of health pathways?
This is a good question. I remember it being developed, I think, at an early stage. So I think the majority of them would have been in the period about 1 to 2 years, I think, I'm guessing a little bit, but 1 to 2 years after their application. And that's an important question because actually often the evaluations of what we're seeing and in integrated care in general happen at a point where potentially the care pathways and the methods are at an early stage of their creation and therefore not necessarily as mature and robust as they could be once they've had the opportunity to embed in the system. So one of the issues that you have is you need to do that evaluation from the beginning, but often we're too quick to get to the answers that we're looking for in too short a time frame, and you end up getting either positive or negative results that might not be the sort of results you'd see in the longer term. So possibly you need to ensure that you're doing your evaluations over a longer time period in order to be able to understand the sustainability question. So that's a good question because a lot of the evaluations, not just here, happen possibly a little bit early.
Thank you. And just one I'm going to throw to the group because it's not for anyone in particular, but it's for health pathways generally, to what extent are third sector organisation services included as community-based care options?
Thanks. So the Welsh experience is that by using a national pathway development by default approach, so that was where I was talking about that you start off nationally because, you know, the evidence, it doesn't matter whether your patient is in Cardiff or Carnarvon, Betws-y-Coed or Bridgend, they need the basic same care. Yes, equity, yes, communities, yes, but most of the time it's the same basic nuts and bolts. So you start off with what is nationally agreed guidance. Community health pathways that we're using is not about creating a new clinical line, clinical journey. It's about agreeing what we do here today, what we do in Wales, or what we do in Ontario, or what we do in the Netherlands. It's about what we do today. So at that national level, we use our national clinical networks, which are specialty specific. They have, yes, doctors, but they'll have nurses, nurse specialists, allied health professionals, but they'll also have patient, carer, third sector representatives as well, largely. So there's the first opportunity when you start off to actually get the voices involved. And then when you localize those pathways, it's your local clinicians supported by your whatever local arrangements are for the community services as well. So the first step is you end up with a national pathway which is handed to the local organizations to localize. And then that is a pathway that is, this is what we do here today, which may have massive gaps in, particularly about community services. If everybody's being referred to a hospital outpatient clinic when they could be seen by a nurse, a pharmacist, a therapist in the community, then that gap, that will become obvious, and it'll be different in your patch compared with a patch elsewhere in your country or your region. So this is what we do here today approach allows you to get people agreeing a standard approach today. It then also allows you to think, well, actually, is this what is the best we can do for our community? And it allows you to identify those gaps in your processes. So you then have a second conversation. The first was, what do we all agree on today? The second one is, what should we be doing? And that's really where, that's another opportunity to get your communities and your patients and carers involved. Sorry, it's a very wordy answer.
Yeah, and so to the third sector, I think one of the key functions of health pathways is to give visibility to all the clinicians in the system of all the resources in the system that are available to help get the best outcomes for their patient. And going back to equity, I think, you know, one of many sources of inequity is when different clinicians actually have different knowledge about what's available for patients. So a key thing is kind of equalizing that knowledge across the whole system so that no matter which clinician you go to within the system, you get this similar level of care.
I think in Ontario we took a different approach, and maybe this is because the health pathways in Ontario are being built by Ontario health teams, and Ontario health teams are integrated care systems that are supposedly playing in this intersection between health and healthcare. So community supports are part of what we do on a daily basis. And that's why it was pretty easy for us to, or like easier compared to other systems, to include all community supports within our pathways. So I would say that our pathways do have community supports, but maybe because we have been already doing this.
Thank you. And I think we will call it an evening there. It's 6:05, so I would like to thank the audience for their questions and for coming along to this session this afternoon. I would like to thank our speakers and invite you to thank our speakers again for their presentations. I'm sure that you'll agree they're of high quality. It's wonderful to go through this global journey of health pathways, and anyone that's worked in health pathways, I know my experience was in COVID, there's a huge amount of work that goes into this process for our clinicians and for our consumers. So I think it's a testament to a huge amount of work that's been done. So thank you to you and for your presentations today. Thank you. You can go home.